Dear faculty members, for your information, today's session manager for Hall A is Atish. Today he has put the name as Hall C Atish. If you have any concern, you can contact him.
Thank you.
Okay, there was a question for the audience. Right now, there is no audience online. So probably they will join in a couple of minutes.
Dear faculty members, all the faculty members will be in the Zoom platform and the delegates will be watching the program from Omnicure's website.
Hello. Good morning, Rekha ma'am. Amandeep.
Hello, Amandeep. How are you?
I'm good. Hi, Shobit. I just want to check my PPT. Can I share my PPT?
Yes, ma'am, you can.
Yeah, good morning. So, do I have the right to share the PPT? Share my screen?
Good morning, ma'am.
Okay. Let me just check whether. Yeah.
You got it in the on mail or the WhatsApp group?
Yeah. Can you see the screen? I have already shared my PPT.
Yeah, ma'am.
Okay. Just quickly, I'll move. Is it moving?
Yeah.
Okay. Thank you. Thank you so much.
Adish, all set from your side? Please announce when we are live.
Yes, sir.
Please announce when we are live.
Okay. We are going live. 4, 3, 2, 1, go.
Shobit, hello.
Yes, ma'am.
Uh, can we start the program?
Yeah, you can.
Rekha ma'am, Anjali ma'am, can we start it?
Yeah, please. This.
Shobit, I will share the screen because there are some corrections. I will share the screen, please.
Okay, ma'am.
Namaste, a warm good morning to everyone. I hope all the participants have completed the pre-test. If you have not received the link, kindly find the link in the chat box and complete. It's mandatory to complete the pre and post test to receive the certificates. Please feel free to post your questions for discussion in the chat box. Namaskar, Adab, Sat Sri Akal. A very good morning, ladies and gentlemen. My name is Sapna, nursing in charge in Indraprastha Apollo Hospital, New Delhi, is your host for today. It's my pleasure and honor to host 20th Delhi Nurses Neuro Association Conference 2022. I recognize that these sessions are principally designed to enhance the development and understanding of fellow delegates within the neuro field. I assure you that this annual conference enables the building of productive health professionals. It also provides an individual opportunity for enhancing the knowledge. I quote, "Learning is a treasure that will follow its owner everywhere." You are the owner of learning. I wish all the owners a very fruitful and productive session. At this time, I would like to start split session, that is paper presentation. We have received 12 abstracts for the presentation. But we have kept slot only for 6 presentations. The presentations were selected by the scientific committee and 3 best paper will be awarded. The judges for the session are Ms. Rekha Anil Kumar, PhD Nursing Scholar, MSc, Faculty College of Nursing, RML Hospital, Delhi. Active member of DNNA, contributed for DNNA conferences as judge, speaker, chairperson, presenter, resource person, and many more. Expert in handling emergencies, neuro-OT, Neuro ICU, Public Health, Managing COVID Census and Uploading at MHFW, Chairperson Welfare Committee, TNAI, Delhi Branch, State Secretary, NTAI, Delhi NCR, Chairperson, NSS, Delhi NCR, awarded excellence in the field of nursing, education, and community by SCFI in 2021, Best Teacher Award on Teachers' Day, (2021), Educator and Administration in 2018, Best Role in Leadership and Team Management in 2015, awarded a letter of gratitude for her selfless contribution and extended help to NSS on 3rd October 21, contributed 3 years project of Government of India in drafting objectives of patient safety for 2020 to 2030, work for public health and government program under DGHS like under 5, ANC, PNC, participated in online mental health counseling under TNAI and WGHI, taken sessions on air live and question answer of teenagers and their related psychological issues, and coordinated various national and international conferences, workshops as speaker, chairperson, faculty, panelist, organizers, guest speakers, and contributed 8th chapter in a book by Dr. Vikas Dikar, Pharmacology for Nurses, reviewer for various nursing publications, conducted public awareness program on latest issues by online, offline, camps, webinar, and conferences.
Thank you so much, Sapna, for a nice introduction. It's my honor to be attached with DNACON from last more than 2.5 decades. Thank you so much.
Now, the next judge, Ms. Anjali Devi M, MSc Nursing Medical Surgical, Nursing Officer, AIMS, New Delhi. She is the life member of Society of Neurocritical Care, Society of Indian Neuro Nurses, Trained Nurses Association of India, Delhi Neurological Association of India. She had enriched experience as a clinical nurse and in teaching.
Thank you, ma'am.
Now, each presenter will get 5 minutes for the presentation, followed by 2 minutes for discussion. Let's welcome Ms. Rekha Anil Kumar and Ms. Anjali Devi. The first presenter is Mr. Vein Singh Prince, Nursing Officer, AIMS Neuro Center, Delhi.
So, good morning. Am I audible?
Yeah, please.
Yes. Good morning. I welcome you all for this presentation. I thank the organizers for providing me this opportunity. I'm here to present about the quality improvement project. Next slide, please. I'm here to present about the quality improvement project, which was carried out by us in our department, with the purpose of, next slide, please. Next slide. Next slide. With the purpose of reducing the revisits of patients and patients' relatives to get their DSA procedure done from an average of 7 to 8 revisits to 2 to 3 revisits within a time period of 3 months in our department. So when you see the background of this this issue, this problem, next slide, please. In any healthcare agencies, if the patients are continuously experiencing long waiting period as well as making frequent revisits to avail the services like taking consultation, getting a procedure done or a treatment, definitely it ends with a dissatisfaction and frustration. Next slide. Likewise, in our department, DSA, digital subtraction angiography, is an daycare procedure which helps in the diagnosis of cerebral vascular anomalies. The patient will get a tentative date from our OPD and followed by the patient has to report it in the neurosurgery department for a preliminary workup, and the next day the procedure will be happened. In most of the cases, we found that the procedure was not done on time, and the patients are keep on revisiting the department to get a new date done, to get the procedure done. So next slide, please. Next slide. So this is the cycle of revisits. Once they get the date from the OPD, they will revisit the department, and the procedure will be done. And due to some factors, the procedure get cancelled, and again the revisit of the patient will be continued to get a new date. Next slide. So we have this is, you can see the patients waiting to get a new revisits to get a new date for DSA. Next slide. Next slide, please. Next slide. So we have formed a QA team with the 12 members, on which, next slide, on which 8 members were the active directly involved in the project, involving senior nursing officer and the nursing officers. Next slide, please. So we sit together, the team discuss the root cause analysis of this problem. Next slide. Next slide. Root cause analysis of the problem. Next slide. And we found with using the fishbone analysis, we have found the 2 important causes. Next slide. That is fixable causes and non-fixable causes. The non-fixable causes are if the patient on the stipulated, if there is any emergency cases rushes to the neuroradiology department, the procedure get cancelled, and if the machine get fault, the procedure get cancelled. And the fixable causes are if the patients are not on NPO status, if their vitals are not stable, if their blood reports, especially the PTINR is not on range, the procedure get cancelled, and if the patients fail to report on time, that also lead to the cancellation. Next slide. So we decided to start. Next slide. We decided to take a preliminary data by keeping an patient revisit entry register in the entry point of our ward, involving the guard of the department, the security guard, who is also a QA team member. We have collected the data. The data collection was done for the period of 1 month, and by using a systemic sampling technique, out of 43 samples, we found that next slide, the patients are making an average of, next slide, 7 to 8 revisits to get the date. So we come with a change idea. Next slide. So we so the team come with a change idea of making a date slot system on a weekly basis for a month. Next slide, please. So we have involved a series of PDSA method, that is plan, do, study, act method. Next slide. Next slide, please. So we have come with a change idea 1, that is, this is the slot register. So we have assigned 2 patients per day. Next slide. 2 patients per day for a week, and we have assigned like this. And we have found, next slide, we have found out of this change idea also, many patients are get cancelled, and we don't know whether to slot this patient. So next slide. So we have quit this change idea, and we have moved on to the second change idea. Next slide. PDSA 2. In this, we have, next slide, we have given 2 slots for the patient. If any of the patient get cancelled, the previously cancelled patient get the priority on the next day. But even in this also, the cancellation, the revisits were made, and we have quit the idea. The next slide. So on the third change idea, PDSA 3, we discussed together and found, next slide, we exclusively made the Wednesday, every Wednesday for the cancelled cases and the Saturdays. So after this, next slide, after this, we found that the significant reduced in the number of revisits made by the patients. Okay, next slide, please. So next slide. So you can see the significant results. Next slide. So regarding the next slide, so sustenance. Due to the pandemic situation, we couldn't able to sustain it. Still, it is on the progress. If there is an planned, well-organized plan, and if proper guidance to the patient, definitely we can reduce the unnecessary burdens that happens on the patient, as well as we can provide a quality service to the patient. Thank you. Next slide. Thank you.
Thank you, Mr. Singh. It's really a nice initiative you had taken to come out with the problem and try to find the solutions of the problem. So I really appreciate your efforts.
Thank you.
And if any questions from the audience or from the panel, from the Zoom room? Over to you, Anjali, for any question.
Ma'am, I don't have any questions.
Thank you so much.
Over
to you for the next speaker.
Okay. Thank you, Mr. Singh Prince. Our next Next, we have Mr. Dev Muni Verma, Nursing Officer, GB Pant, Delhi.
Is the screen visible?
Please.
I'm audible?
Yeah, please.
Yes, yes.
Good morning to all of you, and thank you for giving me this opportunity. My topic of presentation is study of tomophobia in neurosurgical patients. Among all branches of surgery, tomophobia, that is fear of surgery, is maximum in the field of neurosurgery. The most feared complication of surgery is death, and other fears can be anesthesia, disability, post-op pain, and etc. Aim and objective of my study was to analyze the factors for anxiety during surgery and Aim of my study was to analyze factor for anxiety during surgery and to further differentiate the fear among the patient undergoing cranial versus spinal surgery. Material and method. It is a pilot study. A questionnaire was circulated to the patients or relative a day before the surgery, and it was filled by me after interview. The interviews was done about the 20 years of age and the less than 20 years of age. Diagnosis of the cases and patients of qualification were recorded. A day before the surgery was the interview for his or her anxiety and various known causes that can result in fear. This is the questionnaire. It includes 15 factors for fear, and it was already explained to the patients or relative before giving them. 200 patients were selected for the interviews, in which 175 patients participated. This study was done in July to December 2021, and characteristics of my study are: diagnosis, it includes 77% of the cranial cases. In age group, 42% of the patients are between 20 to 40 years of age, and 31% of the patients are illiterate, because it's a government hospital and more patients are coming from the villages and they are illiterate. 27% of the patients are primarily educated. Male patients are more as compared to the female, and 54% of the patients were come from the villages. Now, this slide shows the main observation of my study. The data is tabulated in descending order. The concern about the family is the 41%, and unable to recover is the 40% of the fear. Other fears are fear of complication, fear to death are less than this. Now, nurse's role. A knowledge about the various factors for anxiety can help in improving confidence of the patient undergoing further neurosurgery. So, a nurse can significantly help in reducing anxiety, as she is the first person to meet and greet the patient in OT. At the stage of anxiety, we are the first person in OT who can allay the anxiety and also while the patient is being wheeled out. Every patient has his own anxiety, which can be addressed by us in most satisfactory manner. In absence of clinical psychologists in most of OT, we can fill that gap. Limitation of my study: its sample size is small and it only identifies the fear factor. No methodology has been evolved to allay the anxiety. Discussion. Pain is the most common fear in other surgery like general surgery, gynae, ortho, dental, etc. Conclusion. Concern about the family was the most common fear. Fear of disability is more common in patient more than 20 years of age. Fear of death was much less than me anticipated. Cranial concern about the family. In cranial cases, concern about the family is more than spinal. In spinal, disability is the most common fear factor. Thank you.
Thank you, Devbuni. Being a OT expert, I can just tell you the things like I don't feel that there is a separate need for the psychologist in the OTs. We nurses have a lots of time during the time of pre-anesthesia or in the time of recovery to interact with the family and the patients, and they can make a beautiful change while get a one-to-one interaction and counsel them on that spot only, because that is the time which they listen properly to the healthcare providers, and that during that time only you can give a better psychological support to the family and the patients.
Yes,
and as you have taken more people from villages, even the highly educated people have lots of fear related to disabilities.
Yes.
As it's a pilot project, what is your recommendation for the, are you taking forward for the main study?
Yes, ma'am, I'm working on it. Or it's a pilot study. That's why it's a small sample size.
And then what about psychological questionnaires? You are not mentioned separately. How many questions you are taken for the mental health?
Oh, no, ma'am, it's not recommended.
Because basically lots of fear are associated with the mental health only.
Yes, ma'am.
So it will be good if you just add the questions more based on mental health in your project. Thank you so much. Any question, Anjali? Over to you.
Yes, ma'am. Thank you. Hi, Ms. Devbuni. It's a good study. But yes, of course, the fear is the commonest one for every patients, those who are undergoing the surgical interventions. And of course, for the neuro patients is more common than others. But here I have a question that whether the questionnaire was validated or is because I think this is a self-structured questionnaire.
No, ma'am, we made this question with our seniors and we are working on it because it's a very small study. That's why by the next year, I'll try to be validated.
Okay, all the best for that. And I have one more question also. And how you reduce the fear?
What? Pardon, ma'am?
How the fear was reduced?
Okay, by supporting the patient that the surgery will be fine. You will after that we can make the patient comfortable that the surgery is going nice. You don't have to take tension like this.
Means it's like counseling and guidance.
And yeah, by counseling the patients and their relatives, we can make them comfortable.
Do we get enough time to counsel the patients before surgery?
After post-surgery, when relatives are standing outside the OT, and while shifting the patient, we call the relatives and make them understand.
Okay, thank you.
Thank you, Anjali. I just want to add one more thing with this last. When the patient is entering the OT, we have lots of time to interact.
Yes.
So during that time, we get utilized for counsel the patients. Thank you so much.
Thank you.
Thank you, Ms. Devbuni. The next presenter is Dr. Jaslina Ganarani, Vice Principal, Apollo College of Nursing, Chennai.
Can I start my presentation? Am I audible?
Yeah, please.
Namaste, everyone. It's my pleasure to present. I thank the organizers for the opportunity. The study that I'm going to present today is effectiveness of Glasgow Coma scale versus full outline of unresponsiveness scale, 4 scale, in predicting clinical outcomes of neurological impaired patients. We know that more than 1 million people get injured all over the globe every year, and they have some neurological impairment. And nurses have been using the tool of GCS regularly in every shift to evaluate the patient's severity of disease. And that is useful for their outcomes and for mortality prediction. The 4 scale was first validated by Mayo. It's a 16-point scale. It assesses the patient's neurological status in 5 domains such as eye response, motor response, brain reflexes, and breathing pattern. It is useful for both traumatic and non-traumatic patients. It has been validated in many centers and in use. This is a comparison of the GCS scale that we have been traditionally using with the brain score scale. While the GCS is also a very useful system, 4 score has got an additional advantage of to be used in even verbally impaired patients or intubated patients for knowing their brainstem reflexes and respiratory pattern, and it's got more value compared to the GCS. So that is why we took up this study. The study was done by the 3rd year BSc nursing students guided by me. Very few studies in India have compared this, so we wanted to do this study to validate the 2 instruments and for deciding on the usefulness of the 4 score scale. Next one. So this has been the statement of my problem. With this in mind, the objectives of my study were to predict the clinical outcome of patients by using the GCS, then to predict the clinical outcome of patients using the 4 scale, to correlate the GCS score, the 4 score, and to find the correlation between that and to find the association between the clinical variables with GCS, with 4 scale, and the outcome that we chose by GO scale. So we did this study with these objectives. Clinical outcome we considered was the condition of the patient at the time of discharge or ward shifting within a period of 1 week by using the GOSC scale, Glasgow Coma Outcome Scale Extended, which categorizes the patients into their level of outcome, good or they're having a disability or they're in a vegetative state or death. The neurological impaired patients we chose were head injury, stroke, encephalopathy, patients with brain tumor, etc., having a GCS of less than 15. So these were the patients who were taken. The study used a descriptive correlational design conducted in the ICUs of Apollo Specialty Hospitals in the Chennai region, Tenampet, Vanagram, Main Hospital, First Med Hospital, till we did a consecutive sampling, till we arrived at a 30 patient size. The instrument that we used were demographic variable proforma with the baseline variables and a clinical variable proforma for the patients, used the 4 scale, GCS, and the GO scale. So these were the instruments that we used. Patients who were brain dead were excluded. Patients who were in the neuro ICU for more than 3 weeks were excluded for the study. And the results were, the clinical profile of the patient I would like to focus is, some of the patients were mechanically ventilated and 70% of them were not intubated. And out of those intubated, 40% were on AT tube for more than 5 days. They were hospitalized for more than a week. And no deterioration, and 60% they improved, and no seizures or no paralysis we found in majority of the patients. This was the condition of the patients whom we took. We mainly had patients with traumatic brain injury, 60% of them, and stroke patients were there, and then brain tumors and encephalopathy patients were there. And when we considered their level of neuro impairment based on the GCS and the 4 scale, we found that about 13% of them, 43.3% of them had severe brain injury. And compared with the 4 scale also, the number was more. Among 11 patients, 36.7 patients had severe brain injury. And level of clinical outcome was calculated as per JOES, and we found that GO scale we used, and we calculated the GO score, and we according to the category wise, about 20% of them had mild to moderate level of disability. That was a clinical outcome of the patient. 66.7% of them had mild to moderate level of disability according to the GOSC scale. And these were the category wise, the mean and standard deviation of the scores. Eye opening and verbal response were similar when we compared the GCS and the 4 score, whereas 4 score had the advantage of knowing about the brainstem reflexes and the respiratory pattern. So that is why we were able to show that even patients who were intubated, not speaking, we were able to calculate using the 4 score, whereas the GCS has a significant disadvantage of not being able to be used for intubated patients. And this is a correlation we observed between the GCS and 4. There was a highly significant correlation between GCS score, 4 score. That was significant correlation. and one scale is not against the other. They are significant correlation. That was validated through this study. There was association between clinical variables. Some of the clinical variables, such as the length of time in the ICU, whether they were intubated, hospitalization, all these had significant association with the GCS score and with the force score. So this brings out the impact, the severity of the patient's condition is correlated with the GCS and force score are able to bring out the difference in the patient's level of disability. These were the significant variables that influenced. So in conclusion, I would like to say that GCS and force score were useful in assessment and evaluation of patients with neurological impairment. Both scores are very useful. In addition, the force score, through this study, we were able to bring out that force score provides additional depth of understanding about the clinical progress of the patients. Thank you all very much for your attention.
Thank you, Jaslina. This is the students' project. I think you are just guiding the students for this.
Yes, ma'am. But we were helping them, third-year BSc nursing students, to conceptualize the project. And they were posted in the WhatsApp. As third-year BSc students, they took up the study. I was
but the data was taken purely by the students only, no?
Purely by the students. They were posted in these ICUs in these places, and we made them to do the study.
Okay, one more thing I just want to ask you, why you are taking so less samples, so can we able to generalize?
Yes, ma'am. Students had a limitation in their number of weeks of posting. So they did this study over a period of 6 weeks. We were waiting for them to complete at least 30. A minimum sample size of 30 needs for generalization of the finding to a larger population. So we were waiting for them to complete. We were waiting for the patients who fulfilled the inclusion criteria and exclusion criteria were removed. And based on that, in the 4 hospitals, at least 2 ICUs of each hospital we concentrated. MD multidisciplinary CCU, the neuro ICU, some of the hospitals are neuro ICU, specifically like Tenampet and Vanagaram, then the MICU. So patients with these conditions, they were getting admitted, we had to take the patients. Constitutively, we sampled them.
Did any neuro nurses are helping in this during this project?
Yes, neuro nurses were helping, and they were routinely using GCS. They were very thorough with the GCS. Doctors in the part, they were knowing about force score. Nurses were not knowing that much about the force score. They thought it is only by the doctor. So they were also able to know this, and now they have also been sensitized to the force score.
Not like that. We all are using both the skills.
Both skills we are using.
Yeah. Thank you so much, Jaslin.
Yes.
Over to you, Anjali, if you want to ask anything.
No, ma'am, thank you.
Thank you.
Any questions from the panel, from the Zoom room or from the audience? Thank you so much, Jaslin. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. The next abstract will be presented by Ms. Nilanjana, Nursing Officer, Medanta, the Medicity, Gurugram.
Good morning, everyone. Thank you for giving me this opportunity. Am I audible, ma'am?
Yeah, please continue.
Okay. Ma'am, can you move on to the next slide? So my title of this study was Training Program on Stroke Identification and Early Management among Security Guards and Ambulance Drivers. And the training program that we conducted was on Stroke Day, that's on 29th of October. And the theme for this Stroke Day was Minutes Can Save Life by WHO. And we chose this study because we've seen that the background, according to the AHA, every 40 seconds someone new has a stroke, and approximately every time around 7.9 lakh people experience new or recurrent strokes. Next slide, ma'am, please. And global prevalence in India was seeing that there was 16.1% increase when we were talking about ischemic stroke. And from 2007 to 2017, there was a huge increase in the stroke cases in India. Next slide, ma'am. And therefore, we selected our study with the objective that we would conduct a training program on stroke identification and early management. And we did this based on the this theme given by WHO, because they've said that minutes can save life. And as we know that in the stroke case, we have a window period from 4.5 hours to 6 hours that everyone needs to get the treatment within this time frame. So therefore, we chosen the security guards and ambulance drivers so that we can improve their knowledge, so that they can identify what are the symptoms of stroke, and they can help the patients or the members outside the hospital or inside the hospital to reach to the CT room as soon as possible. Next slide, please, ma'am. And the approach we chose for the study was quantitative approach, and we selected pre-experimental pre-test post-test design. The population was non-medical healthcare worker. Next slide, ma'am. And samples were security guards and ambulance drivers. We used a convenient sampling technique because people who were available in the duty for that particular ambulance services, they were our samples. And setting, we conducted this study in Medanta, Gurgaon. Next slide, ma'am. We also prepared a self-administered knowledge questionnaire, and through which we collected the pre-test and post-test data. We conducted the training program with a health talk from 30 to 45 minutes, along with the help of the neuro nurses that we have in our department. The analysis was done on based on descriptive and inferential statistics. Next slide, ma'am. Data collection was done in pre-test, training, and post-test phase. Next slide, ma'am. And as per the analysis, we've seen that the pre-test knowledge score about the stroke incidences, stroke risk, and symptoms, they raised from 9.5% to 24.11% after the training program. Next slide, ma'am. And when we calculated the association and correlation, the risk factors, symptoms, and early management, everyone was accurate at p.001, but there was no correlation and no association between the job of the samples, like whether they were healthcare workers or whether they were ambulance drivers or whether they were security. They had no relation with the result of our study. Therefore, we did not put much focus on their job profiles. Next slide, ma'am. The knowledge score, when we calculated on the risk factors, it increased from 2.1 to 4.4. The symptoms, that increased from 2.5 to 5.3, and the management was from 1.8 to 3.5. Next slide, ma'am. Moreover, we had a more focus over the symptoms of the stroke, because through that only people are able to identify that this is a stroke. Not everyone is aware, everyone is taking seriously about the heart attack. So we got to the population through the mindset of brain attack. We explained them, like just like heart attack, as it is important, similarly it is much important when we're talking about brain. So stroke is moreover a brain attack, and every second 1 million cells are dying. Therefore, it is very, very essential that you identify stroke as much as early as possible, and you make the person reach the hospital at the given period of time within the window period. So therefore, we put much focus on the fast, that what are the symptoms and how do they recognize the symptoms of stroke. So we did not put much focus on the other symptoms, but the basic symptoms, that is FAST, we all are aware of. So at the end of the study, we have seen that majority of the population, around 96%, were able to recall the mnemonic of fast, and they were able to tell us about the fast and explain us about that, how the symptoms will look. Next slide, ma'am, please. So therefore, at the end of the program, we concluded that training program did improve the knowledge of the ambulance drivers and guards, and they were able to identify the symptoms. We've shown them the pictures of these cases, that what is this thing. So they were able to identify that, yes, this is facial dropping. Yes, this is arm weakness. So other things were also able to identify. Therefore, we had come to the conclusion that participants were aware about the early management and symptoms. Next slide, ma'am. These were the health talk and training program conducted by the neuro nurses along with the neuro nurses help. Thank you, ma'am. Next slide, please. Therefore, the conclusion was that if effective training program is there, then we can all combinedly reduce the gap of stroke occurrence and hospital improvement. Therefore, it will improve the quality of care. Thank you, ma'am.
Thank you, Nilanjana. I have a question.
Yes, ma'am.
What is the education background of your sample?
Ma'am, education background, we have chosen these people like ambulance drivers and these only because whenever a person comes to the hospital.
I know you're choosing the drivers. You must have any background, like 10th or 8th or 7th. What is the education status of these group?
Ma'am, education status was there. Everyone was graduate because the minimum qualification was graduate in the hospital. So everyone was graduate. But
all guards are graduates.
Yes,
all guards are graduate and ambulance are graduates.
No, ma'am. Actually, the data collection that we had, according to that, everyone was able to take on the graduate portion. So therefore, we found that everyone was graduate in that particular sample size.
Great. And you have just quoted over here, 2007 to 2017, there is a huge increase in the stroke.
Yes, ma'am.
Can you just specify the reasons behind that?
Ma'am, this data I've taken out from ICMR India. So I just
there must be written the reason of the increase of stroke during this period.
I'm really sorry, ma'am, but I didn't focus on.
Thank you so much.
Thank you.
Anjali, over to you.
Yes, ma'am. Thank you. Thank you for this study, but as I feel that apart from the security guards and the ambulance drivers, we can focus on the family members, those who are being in the hospitals. So I think that they could have saved some of their other family members also.
True.
This is my opinion. And another one is, can you tell me about the sample size?
Yes, ma'am. Ma'am, we use convenience sampling, and according to that, people who were available on duty for that particular stroke program were 37. So the sample size was very small. It was only 37. And to the second question, ma'am, that we did focus. We also conducted a role play along with the help of neuro nurses on stroke day itself. We conducted an awareness program in other societies like RWA societies and other clinics of Medanta. So by like 2 hours time, we have taken and we have gone to those clinics and we have also explained them about this particular thing. We arranged a role play, but that portion was not a part of study, ma'am. For study part, we have taken only this much as sample size.
Niranjana, I just noticed one thing that you
Yes,
and Nidhi both are doing the same things together.
Yes, ma'am. Yes, ma'am.
That's why you don't have the time to take a more sample. Thank you so much.
Yeah. Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, Ms. Nilanjana.
Thank you,
The
ma'am.
next presenter is Ms. Nidhi Sharma, Nursing Officer, Medanta, the Medicity Gurugram.
Hello. Am I audible?
Yes.
Yes,
Thank
please.
you. Thank you. Good morning and good morning to all the dignitaries as well. Next slide, ma'am. The problem statement of my study was a comparative study to assess the effectiveness of fall prevention measures among neurological inpatients in view of reducing the incidence rate of fall in the.
Your voice is not clear. Nidhi, just check your mic.
Okay, ma'am. Give me a minute, please.
Am I audible?
Yeah, better.
Okay, thank you, ma'am. So the problem statement of study was a comparative study to assess the effectiveness of fall prevention measures among the neurological inpatients in view of reducing the incidence of fall in the selected setting, Gurugram. Background of the study. So there were numerous studies conducted on the incidence and prevalence rate of the fall, but I have chosen a study from Stoll ZH et al. That they have conducted a prospective study on fall among the neurological patients to identify the prevalence, risk factors, and etiology. The total sample of their study was 548 patients they have investigated, among which they have conducted that they have concluded that 34% had a history of fall over the last 12 months of period time. Next slide, please. Okay. The major findings of their study was that 55% people had a fall due to the gait disturbances. 12% were due to epileptic seizures, 10% were due to the syncope, and 7 were due to stroke. Thank you. Next slide. So the main objective of my study was to evaluate the prevalence rate of fall among the patients who were admitted in the neurological ward. And the second one was to assess the effectiveness of the improvement measures adopted in the organization to reduce the incidence of fall rate. Next slide, please. Thank you. So the methodology of my study, the research approach was quantitative approach. Research design was comparative research design. Population were the people, neurological patients who were admitted under the IPD or the wards. Sample was patients who were admitted in the neurological wards in the hospital. Next slide. Sample size. So the study I have conducted was done under 2 sets. So the first set was from the period of May to July 2021, for which the sample size was 617. And the second was for August to October 2021, for which sample size was 900. Setting of the study was neurology ward in Medanta, the Medicity, Gurugram. And method of data analysis was descriptive statistics. Next slide, please. Okay, so these were the certain measures that we have adopted for the improvement program, in which a semi-structured educational program was disseminated among the following. So the patient-oriented was, first one was fall prevention videos were shown in each shift. So this is already a prevailing method which we adopt in our hospital. Extended side rails were applied for the patients who were at high risk for fall. Vulnerable patients were identified and monitored closely. Then caretaker-oriented measures were education awareness program, like video making competitions were organized for nurses. On-job sessions were also conducted regarding the fall prevention and its measures. Then self-incident reporting was also strengthened, and the appreciation was also done for the zero fall areas during the patient safety day. Next slide. So this is a photo gallery that shows first picture shows the nurse showing the fall prevention video to a patient. Then this blue band we have applied on the patient is for a vulnerable identification band. Next is high risk tag for the high risk for fall patient who have scored under the modified small risk for assessment scale. Next picture shows a extended side rail used for a high risk patient. Next slide. So this is a video that was sent by a participant for the video participation competition. Next slide, please. Okay, so this is a result that we have concluded. During the period of, as I've already told, that study was conducted in two sets. So the period of May to July 2021, the rate of fall was 6.48 in Medanta, whereas after the measures, as well as in the period from August to October, the fall incident was reduced to 0. Next slide, please. Okay, so the conclusion of my study was fall prevention aims to maximize the quality of life while minimize the individual risk for fall resulting to a severe injury. So the study have concluded that significant improvement was seen in the rate of fall, and safety isn't expensive, it's priceless. Thank you so much.
Thank you, Nidhi. I think you both have jointly did the same studies, Anna?
Yes, ma'am.
So I just want to just quote over here, you have chosen the two separate section of your studies. First is May 21
yes, ma'am.
To July.
Yes,
I think, and the second one is August 21 to October.
Yes, ma'am.
And May, July is, I think, the peak period of the COVID.
Yes, ma'am.
Did any COVID play a role during your study, or
No,
can interfere with the results?
No, ma'am. Actually, we have separate IPDs for COVID areas, but neurological ward was not under the COVID area, so there was no interference with the COVID at that time.
And one more thing is really surprising. There's a 0%.
Yes, ma'am. Actually,
it's a very rare.
Yes, ma'am.
I have never seen such a great fall in my last 25 years that your research is completely applicable.
No, ma'am.
Another applicable.
Yes,
the result, it shows that whatever you are done with the patients is 100%.
Ma'am, all these measures were not adopted only at the time of the study. Like we have prevailing measures which we are using like in the normal routine as well. But this video making competition and appreciation for the zero fall rate was the new thing.
Okay, thank you. Anjali, would you like to ask anything?
Yes, ma'am. Thank you.
Any audience?
My first question is, you have mentioned that selected setting.
Yes, ma'am.
Isn't it? So
yes,
selected setting, your hospital is a private sector?
Yes,
and the neuro center will be the separate?
Ma'am, we have different IPDs for all the specialties. Like neuro, we have 6 IPDs, 6 floor completely for neurology. Then the different specialties for different floors.
So for all the neurosurgical and neurological patients have you covered?
Yes, ma'am. Complete 6th IPD we have covered for the study.
And another question is 55% of gait disturbance you found.
Yes, ma'am.
Isn't it? So,
ma'am, this was the background of the study. Like this was a study conducted by someone else that I have taken from the PubMed.
Okay. And I am also surprised that about the 0 result. So anyway, it's a good thing, but I don't think so.
Ma'am, I will, sorry to interrupt, but I I will tell you the exact number from the period of that May to August. It was total number of fall were 4, and in the period of this, like where you are mentioning 0, it was actually 0.
Maybe your sample size is too less. That's why not able to just justify with the.
Yes, ma'am. It was actually for the number of like the formula that we have used is number of fall upon like divided by number of patient days. So patient days was for the first set it was 617, and the second set it was 900.
Okay, and extended side rails applied for high risk patients.
Yes, ma'am.
Mentioned in this.
Yes,
but this is the common one that the side rails applied for every patient in our hospital settings. So we never consider that this is a high risk patient, so only for those patients we have to put a side rail. It's not like that. Every patient, those who were come to the IPD, they will be put a side rails. Exceptional only that whenever the attender is sitting side by, then only we will leave the side rails open. Otherwise, the side rails will be on.
So, ma'am, in our hospital, we are using a Morse modified fall risk assessment scale for the assessment of patients, under which if we have scored 0 to 21 score, it is low. It is considered as low risk. So the normal interventions that we are using for each and every patient will be used for those patients. But if anyways patient has scored 45 or more than 45 score, at that time we would take that extended side rails. If in the PPT, I hope that you have seen the extra side rails. So we are using extra side rails for those, like whole the bed will be covered by those side rails, so that patient cannot move out of the bed at that time.
Okay.
Thank you, dear.
Okay, thank you.
Thank you,
Next, please.
Thank you, Nidhi. The last presenter is Ms. Kanchana G, Associate Professor, Apollo College of Nursing, Chennai.
Good morning, all of you. Ma'am, am I audible, ma'am?
Yeah, please.
Yes.
Yeah, please.
Okay, ma'am. First of all, I thank God Almighty and also the organizing team for giving me an opportunity to present this study. Title of the study, Effectiveness of chin tuck against resistance exercise upon feeding performance of patients with cerebrovascular accident at selected hospitals, Chennai. Next. Introduction. Stroke is a major health problem in both developing and developed countries. It is the second most leading cause of death above 60 years. Dysphagia can be seen in 65% of patients with stroke. The World Heart Federation states that every year 15 million people suffer with stroke globally. So it is important to rehabilitate mechanism is very essential. So the CTR exercise is helpful in restoring the oral feeding for patients with dysphagia. Next. The purpose of the study, the global burden of the disease study estimates that the annual stroke incidence shows more than 62% of new strokes and 69.8% of prevalent strokes, 45.5% of deaths from stroke, and 71.7% of disability adjusted life years lost because of the stroke. So it is important to rehabilitate the swallowing mechanism, as this helps to reduce the distress and reduce the risk of aspiration and maintain the fluid balance and promote motivation. Next. Statement of the problem, a quasi-experimental study to assess the effectiveness of chin tuck against resistance exercise upon feeding performance of patients with cerebrovascular accident at selected hospitals, Chennai. Next. Objectives of the study, to assess the level of feeding performance among patients with cerebrovascular accident, to determine the effectiveness of chin tuck against resistance exercise upon feeding performance among patients with cerebrovascular accident. Next. To find out the association between selected demographic and clinical variables and feeding performance in control and experimental group of patients with cerebrovascular accident. Next. The methods and materials, the approach used is experimental approach, the design quasi-experimental pre-test, post-test design, and the setting Apollo Main Hospital and Apollo Specialty Hospital, Chennai, and the sample size 35 in control and 35 in experimental group. So total 70 patients with cerebrovascular accident. And the sample technique used was consecutive sampling technique. Next. The instruments used were demographic variable performer of patients with cerebrovascular accident, clinical variable performer of patients with cerebrovascular accident, and functional oral intake scale. This was the standard scale developed by the Michael. It includes the 7 components in that. Then data collection method, it was a structured interview. The analysis used were descriptive and inferential statistics. Next. So this was the intervention, that is the chin tuck against resistance exercise. It refers to an activity performed with a 12 centimeters diameter inflated rubber ball, which was placed between the chin and base of the neck to provide the resistance when the patient is seated in upright position. Chin is tucked against the ball and sustained for 10 seconds, and this is repeated for 10 times. That is, we have practiced this for 3 times a day for 8 consecutive days among the patients with cerebrovascular accident. Next. First we did the pre-test and followed by the exercise we gave, and then we did the force test. Coming to results and discussions, 34.28% and 42.85% of patients with cerebrovascular were aged between 51 and 60 years, and more than half of them were males, and majority of them had a family income of rupees less than 30,000 and working in private sector in both the control and experimental groups. Next. This was the figure, depicts the percentage distribution of type of work, that most of them were moderate workers. Next. This is the frequency and percentage distribution of clinical variables. In this clinical variables, that is more than half of them were doing the exercise. The frequency of exercise more 3 times in a week. And then most of them were on the medical management, and the number of days hospitalized were more, that is 8 to 14 days. Next. This is the percentage distribution of the feeding performance in both the groups. That is, in the control group, 37.14%, and in the pre-test and post, that is 42.8% of them were on NG2 with minimal semi-solid trials, and 42% of them NG2 with consistent oral take. Whereas in the experimental group, totally NG fit, that is 54.28% of them. Whereas in the post-test, 54.28% of them were on regular diet without any restrictions. Next. This is the comparison of mean and standard deviation of pre-test and post-test score. Here we can see the mean difference between the pre-test and as well as the post-test, and we can compare with the control and experimental group also. Next. This is between the groups, the comparison of feeding performance between the groups. Here the independent t-test value shows 18.2. So it was a significant difference we can observe between the control and experimental groups. Next. This was the association between the clinical variables and feeding performance. There was no significant association with the demographic variables, whereas there is a significant association between the feeding performance and clinical variable. That is, only the frequency of exercise is having an association. However, there was no significant association between other clinical variables like current age, comorbid conditions, and the type of stroke. Next. Coming to the conclusion, the study findings reveals that chin tuck against resistance exercise is effective in improving the feeding performance and the well-being of the patients with cerebrovascular accident. Thank you. Thank you very much.
Thank you, Kanchana. I think you are guiding the students of BSc.
Yes.
This is the study of the students. Sample
Yes,
size is taken
this
by
was
the
the
students.
study of MSc nursing student. It was guided by me, because we will be continuously in the clinical area. Okay, so during that time, along with the student, we did this.
But the data is taken by the students' POT, right?
Yes, ma'am. Yes, ma'am. MSc
so
nurse. MSc nurse.
Thank you. Over to you, Anjali.
Yeah, thank you. Ma'am, I have a question. Even previously, Dr. Jaslin and Dr. Kanjana, why can't we offer the opportunity to the students, ma'am? When the study was done to the students.
Yeah.
For the no, ma'am. Now, yes, ma'am. We have sent these articles, okay, because they were in these asked by us, so that's why we thought we need to present. So we are presenting.
Okay. Okay, ma'am. Thank you.
Thank you all the presenters, and we will come with the result very soon. Over to you, Sapna.
Yeah.
Thank you very much, and all the best.
Thank you,
everyone.
ma'am. Thank you.
Thank you and all the best to all of you.
Okay, thank you, ma'am. Thank you, Ms. Rekha Nilkumar and Ms. Anjali Devi and all the presenters for sharing your immense knowledge with us. The awardees will be announced during the valedictory session. Thank you.
Thank you.
Thank you.
Now moving to split session 2 on neurological nursing. The chairperson of this session is Ms. Rachna, Nursing in Charge Neuro ICU, Indraprastha Apollo Hospital, New Delhi. She has enriched experience as a critical care nurse, contributed towards setting up of ICU in Apollo Navi Mumbai, participated in JCI 360-degree audit and cross audits, organized cardiac conferences at national level, conducted Center of Excellence and Service Excellence campaign at unit level. She has a part of induction training program at unit level. Over to you, Ms. Rachna.
Thank you, Ms. Sapna. Good morning, everyone. As a nurse, we must all have faced so many issues while caring for a neurological disorder patients in the units. So in the first session of this DNACon, our speaker, Ms. Sibi Riju, would be touching one of very important aspect of neuronursing, that is patient with increased ICP nurses role. Ms. Sibi Riju, she did MSc Nursing in Medical Surgical. She's an Associate Professor, Faculty in Charge, MSc Neuroscience Nursing, College of Nursing, AIIMS, New Delhi. She has varied clinical experience of working in medicine, surgery, and orthopedic wards, and cardiac OT, recovery room, etc. She was also actively involved in the in-service education program of the hospital. She's a nursing expert in the expert group committee meeting in the formulation of stroke guidelines in the year 2015. She has organized various national level updates and workshops for nurses. She is a AHA approved BLS ACLS instructor 2021 to 2023. She is a lifetime member of TNAI and other professional bodies. She is also a reviewer of textbook of Medical Surgical Nursing, Southeast Asia, edition Elsevier, and Medical Surgical Nursing Clinical Skills, Manual Elsevier. She has published articles in national journals, and she got first prize in the state level quiz competition. Ms. Sibi. I would request all the candidates, if there is any query, you can put your query in the chat box so that later we can discuss at the end. Over to Ms. Sibiji.
Yeah, am I audible?
Yes, you are audible.
Yeah, good morning, the organizers, and good morning, Rachna. So thank you for the introduction. So I'm just, should I share the screen on my end?
Yes, you can share from your end.
Okay. Yeah, I'm sharing my screen.
If you're facing any problem, then we can also help you out.
Is my screen visible? Is my screen visible? Can you hear me, Rachna?
Sibi, I can hear you. Your screen is visible.
Okay, thank you.
Make it in slide, full screen.
Yeah.
Thank you.
Okay, so the session for today is care of patients with increased ICP. So before going into the care of patients, we would just have a quick recapitulation of what is ICP. So the intracranial pressure or the ICP, it is a pressure which is exerted onto the brain by the external forces. It can be the cerebrosinus fluid and the blood. So talking of normal ICP, in the adults, the normal ICP is 10 to 15 millimeter of mercury. So 15 to 20, if it's a rise of from 15 to 20 in the adults, it is manageable. But more than 20, if the ICP rises in an adult, it is a medical emergency. In children, the normal ICP is around 3 to 7 millimeter of mercury. In infants, it's 1.5 to 6, and in neonates, it is less than 2. So skull, we all know it's a very rigid bolt, and it is composed of 3 essential components. That is the brain tissue, which is occupying 70% of the space. And if we can, if we can give a number, it is 1400 ml of this brain tissue. And blood, it is occupying 12% of the space, and it is having around 75 to 100 ml of blood is flowing in the blood vessels of the brain. And the CSF occupies 10% of the entire space of the skull. And the CSF is produced at a rate of 500 ml daily, but in circulation, it is around 75 to 100 ml. So the buffers in the brain, because we cannot compress the brain tissue, so the buffers are the blood and the CSF, which can adjust. Coming on to the CSF, so we all know it is a colorless, clear body fluid, which is circulating in the brain and the spinal cord and acts as a shock absorber. It is formed in the choroid plexus, and it is coming into the lateral ventricles, and through the intraventricular foramen, it drains into the third ventricle. From the foramen of Monro, it goes into the fourth ventricle, and from there it is continuous with the subarachnoid space in the brain as the spine, as well as the spinal cord. So the Monro-Kelly doctrine is very essential if we can understand, and it is very essential in the management of patients with an increased ICP. So what does this doctrine states? This Monro-Kelly doctrine states that the cranium is a very rigid vault. It is having no space for expansion, and the vault is filled by the brain parenchyma, the CSF, and the blood volume. So any increase in any one of these 3 characteristics would lead to a decrease in the other 2 or any one of the characteristics, which will help in maintaining a balance. When this balance is disturbed, then the patient will have an increased intracranial pressure because of the pressure exerted by the CSF, because of the expansion of any one of the components. So if we can understand from the next slide. So here we can see that the first pictorial is showing the normal state of the brain, in which everything, the brain, the blood, and the CSF is in tandem, or is it is in balance. So whenever the CSF or whenever the brain is having an extra growth, for example, a mass or a blood collection or a hematoma formation or a hemorrhage, so what is happening is the brain tries to compensate it by increasing the circulation of either the blood, increasing the blood outflow or the CSF outflow. So you can ask me what is the blood outflow. So what is happening normally when the brain is increased or expanding, so there is vasoconstriction. So the blood circulation is decreased, and in the CSF drainage or the absorption is increased. So this is a compensated state. But what is happening when there's a continuous increase, the mass is increasing, or there's a continuous hemorrhage, the brain will not be able to compensate for the increased pressure. And as a result, the outflow will not be balancing the excess pressure or the excess thing which has come into the skull. And as a result, the intracranial pressure increases. So the causes, as we have already discussed, the causes can be any cause which will increase these 3 components. It can be any cause which increase the brain volume, any cause which increase the blood volume, and any cause which increases the CSF. Coming on to the causes. So the causes can be traumatic brain injuries. So we know whenever a brain suffers an insult, there is a primary mechanism and there is a secondary mechanism. Primary mechanism will be immediately after the brain injury. So it can be any immediate structural injuries and any secondary injuries. And the secondary injuries, it can be as a delayed effect of the primary injury or other cerebral pathologies. Coming on to the next cause, it can be any space-occupying lesion. So, say space-occupying lesions can be of any disease. It can be like neurocysticercosis. The lesions are formed in the brain. It can be due to the hemorrhage which is occurring into the brain tissue. The CSF flow obstruction, it can be genetic causes as well as other causes. In the genetic causes, we can see there will be aqueduct stenosis. The fourth ventricle will not, the aqueduct will be blocked. It is a genetic disorder and which will lead to an obstruction in the CSF outflow. Chiari malformation, it is a brain herniation from the cerebral vernixes, which can lead to again a CSF flow obstruction. Meningitis, the inflammatory exudates of the meninges, of the inflammatory processes of the meninges, it can also block the CSF flow. Cerebral edema can be due to the blood collection in the brain, and it can be due to the edema of the cerebral tissue. Then there can also be conditions where there is increase in the venous pressure. It can be due to the cerebral venous sinus thrombosis. So the factors associated with increase in ICP, there are various factors associated with increased ICP. It can be the hypercapnia. Hypercapnia is increase in the carbon dioxide content. The normal is 35 to 45. So if there is an increase in the carbon dioxide content more than 45, then the ICP can increase. Why? Because it increases the cerebral blood flow, which further compresses the already compressed brain tissue, and that can increase in the ICP. Respiratory procedures, suctioning, frequent suctioning, the positive end expiratory pressure, asynchrony of respiratory rate with the ambu bag, and intubation. These are all procedures which is putting a pressure on the intrathoracic cavity, and which in turn will increase the ICP. Vasodilating drugs. What is happening is they are helping in the dilatation of the blood vessels. So whenever there is an increase in the ICP, the compensatory mechanism is vasoconstriction, because the ICP, the CSF needs a space. So if the blood flow is reduced, then only the CSF will get a space. So whenever we are dilating the blood vessels, the brain blood vessels may also dilate, which will actually cause more blood to enter into the system, and that will increase the ICP. Body positions like Trendelenburg position, prone position, extreme hip flexion, they can also cause increased ICP. The pressure on the neck, we can like if the patient's neck is flexed, or if the patient is having a collar or any other hard collar, soft collar the patient is wearing, what is happening? The venous return from the brain is compromised due to the compromise or constriction of the jugular vein. So that can also further increase the ICP. Coming on to the signs and symptoms, whenever we are talking of signs and symptoms, one of the foremost early signs would be decreased level of consciousness. So by decreased level of consciousness, we do not say that the patient is unconscious. Decreased level of consciousness can also happen in a conscious patient. The patient may get confused, the patient may be lethargy, the patient may be drowsy, the patient may get restless. So these are all one of the most earliest sign of increased ICP, that is the patient's level of consciousness is decreased. Pupillary dysfunctions, there can be unilateral pupillary dilatation, changes in vision, the patient can complain of diplopia, blurred vision, deterioration of motor functions, the patient may not be able to use his or her limbs properly, there may be headache, personality changes, the patient may be very restless, the patient may show aggressive behavior, and the decreased GCS score. If we are scoring the patient on the level of GCS, we will see that as compared to the earlier features, the patient's GCS again has further decreased. The late signs is if we are not intervening at those early signs, the ICP is continuing to increase. So it will again continue to compress the brain, and it will lead to the patient going into stupor or coma. The bilateral pupils become dilated. It becomes non-reactive to light. The patient may suffer a hemiplegia. And because of the increasing headache, the vomiting is a therapeutic, the projectile vomiting the patient may have because of the increasing headache. The patient may have bradycardia, decrease in the pulse rate. The patient may go into hypothermia. Papillary edema may develop. There may be loss of corneal and gag reflexes. There may be positive Babinski reflex. And the vital signs will present a Cushing's triad. So changes in vital signs, the patient may have an abnormal vital signs. The patient may go into bradycardia, there may be increased respirations, the temperature fluctuations can be there. These are all related to the increasing pressure on the thalamus and the brainstem. And Cushing's triad is a late sign, and if it has occurred, it means that the patient's brain stem is compressing, and it may present as an emergency. And the triad is the increased BP, there'll be bradycardia and decrease in the respirations. So what are the diagnostic tests which we can do for confirming a patient is having an increased ICP? We can go for CT scanning, MRI, cerebral angiography, the PET scans, the positive emission PET scans, transcranial Doppler studies. These all will be telling us any structural abnormalities in the brain in the form of CT scan and MRI. Cerebral angiography and the transcranial Doppler will help us to understand any problem with the blood vasculature of the brain. Lumbar puncture is avoided. Why is lumbar puncture avoided? Because the CSF is at a very high pressure. So when we are puncturing the lumbar space, what will happen? The CSF will flow out at a very high pressure. And because of this increased pressure, it will also pull on the blood, the cerebral cortex or the brain matter will also be herniated. So lumbar puncture is always avoided in any patient who is suspected of an increased ICP. So now if the patient is having an increased ICP, we have ICP monitoring devices also, which can monitor the patient's fluctuations in the ICP level. So we have two methods, invasive and non-invasive. So the invasive methods are those methods which will actually necessitate the neurosurgeon to actually insert something into the brain to monitor the ICP. It can be intraventricular catheter, which is inserted into the intraventricle, into the lateral ventricles. We have a subdural screw or bolt. Subdural, it is above the dura mater, between the skull and the dura mater. Then epidural, subdural is below the dura mater and epidural will be above the dura mater. So these are all the types of invasive ICP monitoring. We can insert a subarachnoid bolt into the subarachnoid space. We can have an EVD, external ventricular drainage. External ventricular drainage is a device which is through an intraventricular catheter which is inserted into the ventricles. The CSF is drained outside the body into a drainage bag. It can be tunneled and non-tunneled. Tunneled will be the point of insertion and the point of insertion of the ventricular catheter, and the point of exit of the catheter will be different. It will be tunneled under the skin, and it can be non-tunneled also. And then we have an epidural bolt, which is also kept in the above the dura. So epidural bolt and the subarachnoid bolt will not be able to drain out the ICP. They will only CSF. They will only monitor the pressure. But the EVD and the intraventricular catheters will actually help in both monitoring as well as drainage. So this is the extraventricular drainage. So the patient into the lateral ventricle, the catheter is attached and it is connected outside through a drainage system. So non-invasive ICP monitoring can be done on an OPD basis, and it doesn't require actually any insertion into the brain. It is done from outside. So we have many methods. Due to the lack of time, I will not be discussing much in detail. Two-depth transorbital Doppler, it is measuring the ICP based on the orbital pressure, intraorbital pressure. Transcranial Doppler ultrasonography, this is an ultrasound which is done on the transcranial surfaces outside on the cranial surfaces. It can be the Doppler is placed on the nape of the neck or in the eyeball or near the head, near the frontal portion of the face, where the bone is very thin. So that will pick up the waves. Then tympanic membrane displacement is based on the principle that the increased CSF pressure is reflected in the perilymphatic fluid of the inner ear, and this will displace the tympanic membrane. Optic nerve sheath diameter, again the optic nerve sheath will expand due to any increase in the ICP, and that can be measured. And then MRI and CT pupillometry can also be done to have an idea on the increased ICP. So I think we'll just skip all this. So what are the complications? So the complications, if ICP is not, the ICP is increasing and we are not taking any measures to decrease, there will be continuous increase in the ICP. So what is happening? The cerebral perfusion pressure is decreasing. What is cerebral perfusion pressure? The pressure at which the brain is getting the blood supply. And it is dependent on the mean arterial pressure minus the ICP. So if the ICP is increasing, the other end is increasing. Mean arterial pressure minus ICP is the cerebral perfusion pressure. So ICP is inversely proportional to the cerebral perfusion pressure. So as the ICP is increasing, the perfusion pressure will go down and down. And the normal cerebral perfusion pressure is 50 to 80 millimeter of mercury. So once the ICP rises and the CPP goes down, it can lead to death of the patient, and the brain will not be perfused. It can lead to permanent neurological deficit. The patient can throw up seizures, and the patient may also land up in stroke. So to manage, so the goals of management of an increased ICP is identifying and treating the underlying cause of increased ICP and maintaining adequate perfusion to the brain. So first and foremost is treating the cause. If any cause is identified for an increased ICP, for example, there can be hematoma collection, there can be tumors, there can be space occupying lesions, there can be meningitis, which is increasing the pressure. So we can treat the underlying cause. We can go for a hematoma evacuation. We can drain all the blood which is collected. We can go for surgical removal of tumors. And if there is any CSF blockage which is leading to hydrocephalus, we can go insert a shunt or whatever. So once the patient is in the hospital, the immediate management will be the ABC management. We have to maintain a patent airway for the patient because we know that the patient may have a decreased respirations. So a patent airway can be the airway should be patent, and it can be maintained by either inserting a temporary airway like a Goodell's airway or going for a definitive airway management like an intubation. Then patient's breathing is also compromised because of the pressure on the brainstem. So the patient's breathing may also be erratic. So we have to support the breathing. We can support breathing by the use of oxygen or by the use of mechanical ventilation. Circulation, the cerebral perfusion pressure is decreasing. The brain the oxygen reaching the brain can also be decreased. So we have to maintain the circulation, and this we can maintain by maintaining the fluid levels of the body. Head end elevation is also very necessary. We will give a semi-Fowler's position. The head is elevated to 15 to 30 degrees with the head in neutral position. Drug therapy, we can go for osmotic diuretics. So this mannitol is a drug of choice in the care of patients with increased ICP. What it does is it increases the fluid excretion from the body, and as a result, this will maintain the pressures. Corticosteroids are also administered. The drug of choice here is dexamethasone. What is happening is, due to the increase in the ICP, the cerebral cortex, there is inflammation of the cerebral cortex leading to cerebral edema. These steroids will reduce the inflammation and reduce the edema. Barbiturates like midazolam can also be given. Why so? Because when the ICP is increasing, the patient's aggression level, the patient becomes very restless. So as a result, the cerebral metabolism increases, the brain's requirement for oxygen increases. So with barbiturates, we are trying to sedate the patient so that the patient is calm and the cerebral metabolism decreases. Analgesics can also be given for controlling the pain, and anti-epileptics prophylactically we can start for prevention of seizures. Coming on to the non-pharmacological therapy, we have already discussed head end should be elevated to 30 to 40 degrees with the neck in the neutral position, head in the neutral position. Hyperventilation therapy can be given. What is hyperventilation therapy is, we are trying to increase the amount of carbon dioxide. What is happening here is, because of the hyperventilation, there will be vasoconstriction and there will be reduced blood flow, which can help in the reduction of the ICP for a temporary period of time and keeping head in neutral position. Surgical management, if all these measures are not failing and there is increase in the ICP due to any cause, we can go for a craniotomy, which will help in decompressing the brain. We are creating an opening into the cranium, which will allow the brain space. Nursing management, first and foremost, is the nursing assessment. So any changes in the level of consciousness should be of concern to the nurse. The nurse in the neurology ward, GCS assessment is a normal routine. So in the GCS assessment, if the nurse finds any changes in the level of consciousness which is decreasing in nature, that should be reported. Any drowsiness, any lethargy, any restlessness, any irritability, confusion, apathy. Okay, these are all the red flags for the nurse to intervene. So the decreasing scores on the on the Glasgow Coma scale can be reflected in the changes in the orientation. The patient may be disoriented to time and person. The patient may be showing a difficulty or an inability to follow commands. The patient may have a difficulty in verbalization, or the patient may be unable to respond to any stimulus given to the patient. So these are all the clues for a decreasing GCS. And the patient may also take on an abnormal posturing of decerebrate or a decorticate posturing. And also changes in the vital signs should also be of concern to the nurse because it can also signal an increasing pressure of the brain. So we can frame certain nursing diagnoses according to the Nanda diagnosis. So the first one is, we have already discussed this, ineffective cerebral tissue perfusion related to increased ICP as evidenced by the decreased level of consciousness, sluggish pupil response, papillary edema, and posturing. So we have to maintain, our goal is to maintain effective cerebral tissue perfusions. For that, we can keep the head end of bed elevated. We will avoid extreme hip flexion. We will avoid the range of motion exercises until ICP approaches normal. So this hip flexion and this range of motion exercises and anything which will disturb the positioning of the patient will increase the abdominal pressure. For example, hip flexion and the range of motion exercises will increase the abdominal pressure, which in turn will increase the ICP. And we have to administer reduced fluid volumes. This is of very necessary because overhydration of the patient will again lead to an increase in the intracranial pressures. So what is the fluid of choice? Fluid of choice would be an isotonic saline, that is normal saline, which is given at a reduced rate. We are not overhydrating the patient and we are not rapidly rehydrating the patient. Give diuretics as prescribed. So we can give mannitol. We can hyperventilate the mechanically ventilated client. We can increase the tidal volume. We can increase the PEEP and keep suctioning brief. Now, various researchers have said that frequent suctioning in a patient with increased ICP will worsen the client. So we have to keep suctioning very brief, less than 10 seconds per pass. And the passes should be kept less than 3. It has seen in the researchers, in the meta-analysis and all, that the 4th pass of suctioning is the most debilitating, or it will result in worsening of the condition. So at a time, only 3 passes of suctioning, and it should be less than 10 seconds. Risk for ineffective breathing pattern and ineffective airway clearance related to diminished level of consciousness. So we have to look for the saturation levels. We can attach a pulse oximeter. We can insert an oral airway. We can administer oxygen. And if all these measures fail, we can intubate and mechanically ventilate the clients. Then risk for infection, because the patient is already at an increased level of pressure of the cranium. So all the more the patient is at risk for infection, maybe due to the causes of traumatic brain injury, meningitis, or any surgery has been done. Okay, or invasive diagnostic procedures have been done. So we have to maintain aseptic precautions, and we have to always keep the wound clean and dry. Then we have skin integrity impaired related to low capillary blood flow, secondary to pressure and inactivity. So again, we have to tilt or turn client from side to side every 2 hours. This is only done in the patients who are more or less stable patients. If the patient is having an increased ICP and the patient is in acute phase, our main objective will be to maintain the head end elevation. We have to avoid friction, and we can use a pressure relieving mattress, and we can keep skin clean and dry. So now if the patient is on an external ventricular drainage, okay, as I already told you, it is an intraventricular catheter going into the brain, and then the drainage system is outside the body. So the nursing responsibility is somewhat different, because we have to maintain the patency and we have to also prevent infection. So what are the nursing interventions for patients on external ventricular drainage? As in all the external monitoring devices, zeroing is very necessary. So we have to ensure that the zeroing on the pressure scale is level with the patient's tragus. Tragus is of the ear. Okay, when the patient is lying down, it will be at level with the bridge of the nose. So you can see here, we can see the tragus of the ear is illustrated. So from the tragus of the ear, there is a pressure scale. The zeroing should always be in line with the tragus of the ear. And we have to prevent infection at all times. We have to keep the handling of the external ventricular drainage to a minimum. Only when it is required, like for example, you are going to suction the patient, or for example, you need some samples to be collected from the extraventricular drainage, then only you will handle. Otherwise, we will not handle the EVD. Use aseptic practices and periodically vital signs monitoring for any early signs of infection. And we can also check for the presence of any debris or any cloudiness in the CSF which is drained, and that should be reported because this can be the signs of infection. And whenever we are transferring a patient from one place to another, as with our Riles tube and with with Foley's catheter, we are making the drainage bag lie flat on the patient's bed. But in EVD, we have to ensure that the EVD system remains in an upright position and not lying flat on the patient's bed, because that will also affect the drainage of the CSF. And if it is lying flat, it can go in, the drainage will be blocked, and that will result in infection. And the integrity should be maintained. We have to check for any wet dressing and any CSF leakage on the EVD system. The intraventricular catheter, which is coming out from the brain, it will have a dressing. So we have to check for the patency of that dressing. We have to check whether it is wet. It should be kept dry at all times, and any CSF leakage should be promptly reported. And change the drainage bag when it is 3/4 full, as too much weight could disrupt drainage. The drainage bag, whenever it is 3/4 full, it should be emptied, because excess weight of the drainage bag will again disturb the zeroing, and this will cause under drainage of the CSF. And we have to check the CSF output on an hourly basis, and we have to prevent over drainage and under drainage. So the bag should be at the 0 level to prevent this over drainage and under drainage. Maintenance of regular bowel habits is very necessary, because constipation will again increase the ICP. So we can give stool softeners if prescribed. And if any intervention is there which is involving patient movement, the drainage should be turned off. Okay, so what is this drainage? There is a stopcock, okay, on the EVD. Yes, this is a stopcock. So if it is upright, it means that the EVD is off to the drainage, and if it is on the left side, it means that it is on. So any procedures on the patient, the stopcock should be upright. So to conclude, ICP, increased intracranial pressure, it's a very dangerous condition, and the patient should be immediately managed. And increased intracranial pressure, it can cause worsening symptoms of the body of the patient, and the treatment includes relieving the brain of the increased pressure. With the diligent nursing care, many patients can be infection-free and maintain a near normal intracranial pressure. This was all about my topic.
Thank you, Ms. Phoebe, for enlightening us on the care of patients with increased ICP. You have highlighted many of the points. You have highlighted on CSF circulation. A nurse should know all this. Causes, factors associated with increased ICP, signs and symptoms, diagnostic evaluation, where you have focused. We should not be going for, the patient should not be going for the LP. As a nurse, as a bedside nurse, we all should know why we should not allow anybody to do the LP, though as an part of a 24 hours care, we are at the bedside, so we should focus on all this. We are focused on ICP monitoring, complications, immediate management, as well as the nursing management. You have focused many nursing roles, skin integrity, EVD care, infection control practices. So I think there's no question in the chat box. Your information was so good enough to clear their doubts. But is there any question from any of the participants? Okay. May I ask one question to you?
Yes, yes.
How the position will affect on ICP?
Yes. So thank you for the question. So the position, I already mentioned that the position should be supine with the head end elevated to 30 to 40 degrees. Why is it done? And the head should be in neutral position. Why is it done? Is it will promote the venous drainage from the brain by gravity. Okay. Any positions like Trendelenburg position, supine position, prone position, This will all block the venous drainage from the brain towards the heart. And also, when we are giving a Trendelenburg position, the effect will be entirely opposite. So the CSF, the pressure will increase. So that is the reason why we are maintaining a head end elevation and our head in the neutral position. Any extreme flexion of the neck will also compress the jugular veins, which will again affect the venous drainage of the brain. Thank you.
Thank you, Sibi. So moving further to the next session, in this plenum, Ms. Sakshi Gautam would be talking on GCS, a nurse perspective. Ms. Sakshi Gautam, she did MSc Nursing in Medical Surgical Nursing Oncology. She's a nursing officer in ICU in Dr. RMN Hospital. She has published an article titled Intra-Hospital Transportation Practices and Mishaps in Indian Journal of Forensic Medicine and Toxicology in January to March 2021. Ms. Sakshi, over to you.
Thank you. I'll be sharing my slides. Is it okay? Am I audible, Rachna, and my slides are there?
Coming at 8:30. You're audible, but your sound is not much clear.
Okay, wait. Is it okay now?
Yes, it's okay.
Okay, thank you for the intro, Rachna. And let's start with the session, Glasgow Coma Scale. Glasgow Coma Scale was introduced in 1974 by Graham Frisdale and Bernard Jennett. It is a neurological scale which usually aims to give a reliable way of recording a conscious state of a person. It is actually to assess the impairment of the consciousness level of the patient, or in a very straightforward language, we can assess the level of consciousness by using a Glasgow Coma Scale. So Glasgow Coma Scale has three components. One is eye response, second is verbal response, and third is motor response. So eye response has 4 criteria, ranging from 1 to 4, and verbal is 1 to 5, and motor response is 1 to 6. So if you can see, the lowest score of each the criteria is 1. It is not 0. So the lowest score of Glasgow Coma Scale will be 3, and the maximum score will be 4 plus 5 plus 6 will be 15. Okay. So we'll start with the components of the Glasgow Coma Scale. Before that, we needed to know how to use the Glasgow Coma Scale actually. So for this, the University of Glasgow has given 4 things. First one is check, observe, stimulate, and rate. So what we need to check before assessing? Before assessing, we need to check that the patient or we should not have any kind of language barrier or mode of communication barrier, any kind of that. Apart from this, we need to check whether the patient is under the physical or pharmacological deficit. Physical would be if the patient is having any kind of tracheostomy or endotracheal tube, or the pharmacological will be if the patient is under the effect of any sedative or paralytical agent. So then we will check all these things. Apart from this, there could be a way of, that is, the patient might have intracranial injury, or he has periorbital this edema, so we won't be able to use it effectively. Then after checking the things, we will go for the observation without giving any kind of stimulus, either maybe eye, either maybe the speech or pain, anything. We just need to back up our hands and just observe the patient for the spontaneous response. Then next will be stimulus. The stimulus is of 2 types, whether it is of the sound or to pain. Okay, so the sound will be spoken or shouted request, or physical pain. The physical pain we usually give to the 3-point areas. We'll discuss later. And after the stimulation, we will rate the criteria to the definite. For example, the patient has responded in this manner, then we will rate the particular response of the patient in the Glasgow Coma Scale. So these 3 are the site of physical stimulation. First one will be the fingertip pressure. The fingertip will be pressed by any kind of pen or pencil if the patient for at least 10 seconds. The trapezius pinch is in the notch of the shoulder near the neck. We'll slightly pinch the trapezius muscle, and then the patient will have a physical stimulus. The third will be supraorbital notch between the brows. There will be a pain perception by the patient. It will give the physical stimulation to the patient. So our first component for the Glasgow Coma scale is eye opening. It has a 4 criteria. First one will be spontaneous. We will score as 4. While going to the patient, and when we reach to the bedside of the patient spontaneously opens the eyes without touching, without asking anything. If he or she spontaneously opens the eyes, we will grade as 4. And if she or he doesn't, we will ask the name or we call out, okay, open your eyes. To my words or to my speech, if she opens her eyes, then there will be, the scoring will be 3. And if not, I'll provide a supraorbital notch pain perception as the picture has been shown. And then she opens her eyes, we will give the eyes opening response to pain and the scoring will be 2. And apart from giving the pain, if the patient does not give any kind of response, we will give the scoring 1. So I will be 4 with spontaneous, 3 with speech, 2 with pain, and 1 is nil. And one more thing is we can also write not testable, NT, in the eye component if the patient is having any kind of eye surgery or eye injury or periorbital edema, which will physically or pharmacologically let not the patient open their eyes. So we won't be writing 1 that is not response. We will write E is equal to NT, not testable. So next will be your verbal response. The verbal response contains 5 criteria. First one will be orientated. We will give 5 marks. We will ask the patient, where are you? What is your name? Which year it is? If the patient responds correctly, then we will mark them as oriented and the scoring will be 5. But if the patient has a little bit of confused conversation, like he doesn't know the exact area where he is or he doesn't know which year it is, but he is responding to the question, then we will give 4 marks as a confused conversation. But if the patient, from our question, if I ask, and the patient will give an inappropriate word. For example, if I ask, where are you? And he will say, yesterday, mother, or I want to eat an something like that, not even the whole sentences, but an inappropriate words, then we will give 3 scoring, 3 marks. And if of my question, if he doesn't even go for the words, he'll only go for incomprehensible sounds like scream, mourn, no, kind of thing, then there will be a incomprehensible sound. We will give 2 marks. And if there is a no response, then we will give 1 mark. For this, the verbal component has 5 components. Again, 1 is no, 2 is incomprehensible sound, 3 is inappropriate words, 4 is confused, and 5 will be oriented. And in this also we can write NT, that is not testable, VNT, verbal, non-testable. Why? Because the patient might be with a vocal cord injury or something like that, or the patient will be intubated or on tracheostomy tube. So we will write V as non-testable. Now moving to the third component of Glasgow Coma scale, it is motor response, have the 6 criteria of scoring. So first one will be, if I'll ask the patient to shake your hand or just show me your finger or raise your hand, if he obeys my command without giving any kind of stimulus, then we will give 6 scorings in the motor response. If I'll provide a pain perception, if not, he doesn't obey my command, I'll give a pain stimulus to the patient. And if the patient is about to reach to my hand, for example, if I've given the pain in the supraorbital notch, if he removes my hand or localizes where the body is having the pain perception, he will bring that hand and remove that perception. Then that will be localize the pain. And there is a little bit difference in the next criteria, withdrawals of the pain. If I'll give the pain stimuli and he withdraws his hand from the stimulus of the pain, not localizing, he cannot remove that particular thing, but he withdraws his own hands, or we can say normal flexion will be there, then there will be a scoring of 4. And if I'll give the pain perception, none of these things happen and he abnormally flex the hand towards his central line of the body, then there will be abnormal flexion. This is a classical posture. We say it as a decorticate posture, and it is always communicated in the level of injuries. And the next will be the abnormal extension. After applying the plane stimulus, if the patient abnormally extends the forearm, then there will be abnormal extension and the scoring will be 2. And if there is no response, then there will be 1. Again, the non-testable things can be there. If the patient is having hemiplegia or quadriplegia, then we will ask the patient to open the mouth and protrude the tongue out, something like that. Then we won't go for the hand movement, we'll go for the mouth movement. If he obeys the command, then definitely we will give 6 marks. If none of this happens, we'll give 1 mark. Or if the patient is having any kind of problem, we'll say it is non-testable if he has some kind of backward seizure. So this will be the motor response. This is the 2 postures I was talking about. That will be M3 and M2. M3 will be decorticate or the abnormal flexion. See the arm of the patient. It is literally looking like a C shape. It is moving towards the core, and this is decorticate. And the patient, his arm is against the body, protruded outside. The shape will be like C. It will be decerebrated section. There will be a problem with the midbrain or the forehead. These 2 are the postures which we can see in the patient while assessing the Glasgow Coma scales with a poor Glasgow Coma with a poor level of consciousness. And I would like to express my gratitude to each. There is a little bit of difference in the adult and infant. So there is a proposed Glasgow Coma scale modified for the pediatric population. The only difference is the verbal responses. The eye opening and the motor will be similar. The only thing was the verbal response, because you cannot ask a 2-year child or 1-year child, where are you or what's your name? So we will differentiate if there is a comparison, like for the 5 in the adults, we will go for if the baby is cooing or babbling or smiling or he's okay, then we will give the 5 scoring. If he cries but he's consolable, like taking in a lap or feeding, then we will give the 4 marks. If he persistently crying and have extreme irritability, then we will give 3 marks. And if he does not respond to the consoling and he grants to the pain and he's extremely restless, we will give 2 marks. And if there is no response, we will give 1 marks. This verbal component is specifically extended for pediatric population. So next will be the level of brain injury. Glasgow Coma scale is usually started with the level of brain injury. So if the Glasgow Coma scale scoring is less than 8, we will give severe level of injuries. If it is from 9 to 12, it's moderate level of brain injury. And if it is more than 13 to 15, it will be minor level of brain injury. And I have one video for you. Let's state it and it will be easier to understand.
Patient, there are 4 steps: check, observe, stimulate, and rate. The preliminary check is used to identify any factors that might interfere with your assessment. It is important to identify local factors, such as a hearing impairment, that could cause a lack of capacity to respond. Following these preliminary checks, we observe the patient, noting any spontaneous behaviors in any of the 3 components of the scale: eyes, verbal, or motor. The patient is rated in each component by matching findings with the corresponding criterion. There are 4 criteria for eyes, 5 for verbal, and 6 for motor score. For each component, the top criterion is a normal response, whilst the lowest criterion is no response. If the patient's eyes open spontaneously, spontaneous is recorded. Remember, there may be local factors, such as swelling, that prevent eye opening. If spontaneous opening is not demonstrated, a verbal stimulus is used by introducing yourself clearly and requesting eye opening, if necessary by shouting. If the patient opens their eyes, to sound is recorded. If the patient does not open their eyes when you speak to them, a physical peripheral stimulus is then applied. Stimulation starts at a low level by pressing on the nail tip and is applied with increasing intensity for up to 10 seconds until the patient demonstrates a response or until maximum stimulus has been applied. If the patient opens their eyes, record to pressure. If they do not open their eyes, record as none. If there are local factors, such as swelling, interfering with eye opening, record eyes not testable. To assess the verbal response, ask the patient to tell you their name, where they are, and what month it is. If they answer correctly, record orientated. If during conversation the patient is able to speak in phrases or sentences, but is unable to give the correct answers to these questions about orientation, record confused. If they do not talk sensibly, but utter single words, record words. If the patient moans and groans with no recognizable words, record sounds. If the patient makes no sounds at all, then record none. Remember, speechlessness may result from factors other than depressed consciousness. For example, the presence of an endotracheal tube. In these cases, record verbal not testable. To assess the motor component of the Coma scale, first ask the patient to perform a two-step action by asking them to grasp and release your fingers with their hand, or opening their mouth and sticking out their tongue. If the patient does this, record obeyed commands. If the person can't move their arms, for example because of a spinal injury, you should ask them to open their mouth and stick out their tongue. In a patient who does not obey commands, a peripheral stimulus alone is inadequate to assess the motor component of the Coma scale, and an additional central stimulus is needed. This is first applied by the Trapezius Pinch. To perform this, place your hand over the patient's shoulder and press your fingers into the muscle above the shoulder blade. Apply pressure with increasing intensity for up to 10 seconds until you are sure that the response you observe is the patient's best response. The second location for central stimulus is the supraorbital notch. Apply this stimulus if there has been no localizing response to the Trapezius Pinch. This stimulus is applied by placing a hand on the forehead with a thumb over the upper rim of the orbit. Feel for the notch in the supraorbital margin. Apply pressure with increasing intensity for up to 10 seconds until you observe the patient's best response. The patient should not be rated as having an absence of response until the maximum stimulus has been applied. This stimulus should not be used on patients with facial injuries adjacent to the supraorbital notch. If the patient moves their hand above their clavicle or collarbone in an attempt to move the stimulus away, record localizing. If their upper limb does not reach above the clavicle but does flex, then they are either normally or abnormally flexing. In clinical practice, the assessment of these non-localizing responses is based on a combination of both peripheral and central stimulus. In normal flexion, the elbow bends and the arm moves rapidly away from the body and from the stimulus. In abnormal flexion, the elbow bends slowly and the arm comes across the body. If in doubt, record normal flexion. If the patient extends their elbows rather than flexing them, record extension. A patient who makes no response is recorded as none. If they are paralyzed by other factors, such as paralysis by drug,
So this was the video to explain how to do the Glasgow scale valuation eventually. So there will be a quick revision. For example, if there will be a eye response and the scoring was 2, so what there will be the response to E2. So what will be the eye will contribute, the I 4 will be spontaneous, 2 will be to the speech, and 3 will be to the speech, and E2 will be to the pain. So E2 will be to the pain. If the verbal is 3, we will again give verbal. 5 is for orientation, 4 for disorientation, inappropriate words for 3, and incomprehensible sound V2, and none is V2. So V3 will be your inappropriate words, and M3 will be your abnormal flexion, that is decorticate posture. And again, if what will be the scoring? If the patient eye opening to the speech, it will be E3. If the patient is confused on the verbal component, it will be 4. And if the patient having a motor response to localize to pain, it will be M5. So this is a quick revision for this. And let's summarize. The Glasgow Coma scale is used whenever you receive the patient first in emergency department or intensive care unit. After that, from half an hour to every 2 hourly, the Glasgow Coma scale is being used. And in some settings, we use from every hourly also. And Glasgow Coma scale has 2 or 3 extensions. There is limitation for use of the Glasgow Coma scale. First one will be your sedation, paralytic agents, or the patient is having hemiplegia or quadriplegia, or the patient is on tube. Another thing I want to discuss here is that if the patient is having, for example, endotracheal tube or tracheostomy tube, and the response E will be 4 and N will be 6 and V will be T or not testable. So the score will be E will 4, N will 6, so it will be approximately 10. It doesn't mean that patient is having a lower Glasgow Coma scale scoring. Why? Because the V is in not testable thing. We have many patients like the spinal cord injury. The patient is unable to move his hand or in response to the stimulus, but he obeys your command. So the Glasgow Coma scale does not have the total scoring. We will have a division like I in this, M in this, and V in this. So the scoring will not, the total score will not be a recognizing factor for the level of consciousness, but the different component, the another separate number will be the score for this particular thing. And with this, I'll be ending my presentation. Thank you so much. Over
Thank you,
to you,
Ms.
Rachna.
Sakshi. Thank you, Ms. Sakshi. It was very wonderful talk. GCS, it's a very significant tool used for neurological assessment of the patient, and many a times we nurses face problem while assessing the patients. Like sometimes we don't know how to check the pupillary size, whether it's reacting or not, and mainly you're focused many of the good points. Your focused method of use site, especially I feel like many of the new nurses are also our participants. So we all will be putting more focus on sites because we are not giving the correct site pressure. Fingertip pressure, you have discussed Trapezius Pinch, Supraorbital Notch. And you have discussed on GCS Pediatric. Many of us, including me, myself, are not knowing much about the GCS on pediatrics. So you have covered in a very good way. Level of brain, you have discussed brain injuries. And the video was very effective to assess the correct way of assessing the GCS. Thank you so much. Is there any question from the participant? No more questions, everybody's clear? Okay, I'll be asking one question. Like if I'm giving a pain to the patient and patient shows one side flexion and one side extension, so how I'll score the patient?
Nice question. Actually, when the patient is giving 2 responses simultaneously, we will score the best possible response. If, for example, on the right side, if he is having abnormal flexion, and on the left side, if he is having abnormal extension, so the better score will be your 3. That will be abnormal extension flexion. So the score will be given the best possible score. The higher the score, the best possible score was there. So the score will be M3, not the M2 or not both M3 or M2. The thing will be that the patient will be scored as M3, the best possible or the higher response.
Thank you for clearing my doubt. I hope we all should, we are at the bedside for 24 hours. So we are the first person to inform to the doctors about the condition changes in the patient. So we all must focus on GCS. Thank you.
Thank you so much, sir. Thank you for the opportunity and inviting me. Thank you.
Thank you. Over to you, Ms. Sapna.
Thank you, Ms. Thank you, Ms. Sibi Riju and Ms. Sakshi Gautam for an informative session. Thank you, Rachna, for moderating the session. We have a tea break for 30 minutes. I request all the participants not to close the link. Please stay tuned.
Hello.
गिर गया ये वाला आप खाओ रुको 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 Pudu, pudu, tudu, pudu, mudu, dudu, pudu, gugu, mugu. चलो हम नाश करते हैं आगे करते हैं दुदू मुदू गुगू मुदू पुगू पुगू एक और बच्चा भी आपका लास्ट लास्ट गुमुगु गुमुगु टीथ दिखाओ टीथ
Harpreet ma'am, your mic is on. Harpreet ma'am, your mic is on. Please please mute yourself.
Oh, गिर गया नहीं गिरा yeah मम्मा का बकरू कौन है हाँ
Dear all, we have 4 minutes more. So please be on time. After 4 minutes, we will start again. Welcome back. Now moving to third split session. The moderator of this session Lieutenant Colonel Sandhya V. Nair, DNS and Head of Training and Development, Medanta, the Medicity Hospital, Gurugram. She has enriched experience of 26 years. She was commissioned in Indian Armed Forces 1996. She had specialization in nephrology and transplant nursing 2002, diploma in neurology and neurosurgical nursing, Niemann's 2006 to 2007, transplant coordinator course, organ donation and transplantation note to 2013, postgraduate diploma in healthcare and hospital management, Symbiosis 2017 to 2018, MBA Health and Hospital Administration, Symbiosis 2018 to 2019. She has presented and won third prize for oral presentation at Second International Conference on Neurosciences at Dubai 2002 on brain death evaluation, refusal to organ donation by the families at armed forces. Her achievements are commendation by Army Chief twice in the year 2014 and 2015, Mukund Award for the Best Academic Student Niemann's 2006-2007, Award for Excellence in Renal Nursing in the year 2017, Swami Narayan Award for Best Transplant Coordinator 2018. Asia Pacific Excellence Award in the category of Super Woman Achiever 2021. Ladies and gentlemen, let's welcome Lieutenant Colonel Sandhya. Over to you, ma'am.
Thank you. Thank you for that humble introduction. And on behalf of my entire organization, I'd like to thank Ms. Merlin and the entire organization for giving this platform and an opportunity. It's always been a pleasure to be associated with the Neurological Nurses Associations. To a lighter note, there is a saying, if you are a neuro nurse, you actually attempt to try painful stimuli to everyone who comes to you. You question the orientation status of your friends, and you actually visualize heads in terms of shunt placements. That's a lighter note. So let us start with our session. We have 2 topics lined up, and we have 2 eminent speakers too. So to start with the first topic, I think the topic is the most trendy topic of the period now. That is COVID-19 and the post-COVID neurological complications. We being always are familiar with the post-COVID complications like COVID pneumonia or mucormycosis, but neurological complications are much, much severe than, because there is a study actually which has been in 2019 that the COVID-19 associated with a stroke is much, the triple times severe than the stroke without a COVID-19. So to start with the session, I invite Ms. Amandeep Kaur. She has done a master's in neuroscience and is working as an assistant professor at it's SGT University, Gurgaon. She is also pursuing a PhD from INC. She is a master trainer in stimulation-based education at National Reference Stimulation Center and a master trainer for stimulation training and skill update under capacity building program of media-free faculty by INC and UNPFA. She's a certified BLS and ACLS provider, neonatal resuscitation program, and basic first aid trainer. She has eight research articles and paper presentations to her credit. She also is a reviewer of 3 national books of CBS publishers, including Target High 6th edition. She has been a contributor as content developer on CBS Nursing Next app and given 6 video lectures on CHO exam syllabus on Nursing Next Level app. She's been a frequent guest speaker in the various national conferences and workshops, and also been an organizer to hold the same. I welcome Ms. Amandeep to share her session.
Thank you, ma'am. I humbly thank you for my introduction. And let me share my screen. Is it visible, ma'am?
Yeah.
In slideshow mode? Yes. Is it moving, ma'am? The slides are visible?
Yeah, it's visible. Okay. You can continue.
Thank you so much once again. And a very warm good morning to each one of you and a happy Sunday. I hope you people are enjoying since morning this scientific feast. And here I am. The topic which I'll be presenting, which Madam has already explained, that is the post-COVID-19 neurological complication. So before starting, I would heartily thank the organizing committee members of DNNA and the Apollo Hospital who has given me the opportunity to speak on this wonderful topic. And as Madam has said that it's a trendy topic, it's an upcoming topic, and we all are neuro nurses and it's a COVID era. So we should all be aware of what all neurological complication a patient with COVID-19 could have. So here I am. Let me take across you to this PPT. So COVID-19, it's an emerging global health emergency. We all have been hearing so many things about COVID-19 since 2019, and it was declared a pandemic on March 11, 2020 by WHO. The cause, every one of us know that the cause is the novel coronavirus, which is also known as severe acute respiratory syndrome, coronavirus 2. So in this past years, we have been learning new things. Every day, the scientists have been discovering various aspects of COVID-19. One thing which we have learned is the primary complication of the infected individual that progress to COVID-19 is respiratory complications. So as Madam has highlighted, everyone is hearing about pneumonia and mucormycosis. But yes, increasing evidence have suggested that spread to key organs like central nervous system and peripheral nervous system is also seen that can compromise the functional capacity of the life of the patients. So if we see the clinical features, we all know that the most common feature of COVID-19 being the systemic symptoms like fever and fatigue and respiratory symptoms like cough, dyspnea, sputum production or shortness of breath. But if you see, there are reports which say that there are clinical manifestations related to the neurological manifestation like myalgia, dizziness, headache, and headache being the tension type headaches and altered mental status, and patients have been reported with loss of smell and loss of taste. So the neurological community, the people, the scientists, all over the world, they were alerted because of anosmia and ageusia, the high prevalence, why the patient with COVID-19, they were having loss of smell and loss of taste. So there were lessons that were learned from the past that there were neurological complication as a sequel of influenza infection that has been documented over the century. So here also in COVID-19, it was seen that patients were having these chemosensory disturbances like ageusia and anosmia. And it was discovered that the COVID-19 virus, that is the SARS coronavirus 2, it has a special affinity to the nervous tissue that is known as neurotropism. So neurotropism, because the SARS coronavirus not only attacking the respiratory tissue, but also the nervous tissue. And it has been seen there are two actions through which it is affecting the nervous system. So the first action was direct action and the second was the indirect action. So direct action being the direct attack to the nervous tissue that is usually occurring in the acute phase. So during the acute phase, when the viral load is high, it has been seen that the virus is attacking and damaging the structure and function of the nervous system, which could lead to encephalitis, toxic encephalopathy, and post-infectious demyelinating diseases. Indirect actions through the activation of immune-mediated mechanisms. So once there is, any microorganism that is entering in the body or any foreign object, there is inflammatory process that is occurring. And we have heard a lot about cytokine storm and interleukins playing a role in the pathogenesis and the involvement of macrophages, microglia, and the astrocytes, which are the supporting cells of the nervous system. So once there is inflammatory process and these cytokines, the body's own immunity, when it gets triggered, so it can cause nerve damage through the direct infection pathway. And also, as we have seen that COVID-19 virus, it affects the lung tissue. So there is a hypoxia. So because of hypoxia, it can lead to hypoxic brain injury and immune injury. Also, the SARS-CoV-19 virus, it has been seen that it has special affinity to ACE2 enzyme receptors, and which is also present in the brain, in the glial cells, neurons. And this could explain why the patient had anosmia and ageusia, which everyone was wondering why the patient have these non-specific neurological manifestations. Also, postmortem studies have been reported that there have been, when the COVID-19 infected patient, they died. So autopsy have revealed that there have been changes in the nervous tissue, there have been cellular inflates, then there is an edema that is seen, and also involvement of glial cells and neurons. Coming to post-acute COVID-19 syndrome. So when we talk about COVID-19 syndrome, we say there are symptoms in the acute phase when the infection is at its peak. But post-acute means once the viral load is settled, patient doesn't have the active inflammation. After that, the patient develops some symptoms. So a report from CDC indicated that 35% of the patient with mild COVID-19, they never returned to the baseline after recovery. So there were some lingering symptoms that were there in those patients, infected patient, and those symptoms reported were fatigue, change in concentration, loss of memory, sleep disorders, weakness, headache, dizziness, cough, and dyspnea. These were the main reported symptoms the patients, COVID-19 patient, after the acute phase, they have reported. So a study that was done by Moreno-Prez evaluated the incidence of post-acute COVID-19 syndrome in adult patient. And they revealed that these post-acute COVID-19 syndrome have been seen in the half of the COVID-19 survivors. So half of the COVID-19 survivors have some of these symptoms. But it was also relieving to see that all these symptoms were mostly mild. Coming to the post-COVID-19 neurological complications. So we have seen that there were various symptoms, systemic symptoms like fever, fatigue, or change in concentration, cough, dyspnea, but neurological complications have been seen after the acute phase was over. So these were the long-term sequelae. Once the patient has the chronic, COVID or a severe illness, patients were hospitalized because of the severe disease. So it was seen that patient had some neurological complications, some disorders after the acute infectious phase was resolved. The symptoms or disease. So if we go into the literal definition, symptoms, post-COVID-19 symptoms were those that persist 3 weeks, and disease sequelae was that persist 3 months after the first onset of COVID-19 symptoms. If we talk about the probable factors, the patient, as I have mentioned before, the patients who had severe COVID-19, which required hospital admission, especially the ICU admission, and older patient, obese patient, and patient with comorbidities, and the patient who had more than 5 symptoms in the first week of acute COVID-19, they were at more risk of developing these post-COVID-19 neurological complications. So this is the study which I have taken from Nature Medicine. It was published in Nature, and it has revealed the nervous system problems observed during the acute, para-infectious, and post-acute phases of COVID-19. Here you can see that in the post-acute phase, the patient were reported to have cerebrovascular symptoms. As Madam has also stressed, cerebrovascular events like strokes or thrombosis, they top the list. Also, as I have told previously, patients were also reported to having chemosensory disturbance like anosmia and ageusia. Patients were also reported to have encephalopathy and psychiatric disturbances like anxiety, depression, PTSD, and various types of neuropathies. Other symptoms which were reported in the post-acute phase were abnormal movements, dysautonomia, fatigue, headaches, and sleep disturbances. This is a study which I have taken. This is the article that is published in Lancet Psychiatry. This is the study I have taken, and they have divided the various complications of COVID-19, neurological complication, into 4 categories. First one being cerebrovascular events. Second, altered mental status, in which a patient with encephalitis and encephalopathy, they have mentioned those cases, and peripheral disorders like GBS or Miller-Fisher syndrome and other neurological disorders. This is also one of the study in which, as you can see, cerebrovascular diseases top the list, and second complication was the peripheral neuropathy, specifically GBS and encephalopathies and deep myelinating diseases. So let me discuss each complication one by one. So first was the cerebrovascular events. As we all know that it is the acute ischemic, hemorrhagic, or thrombotic vascular events involving the brain parenchyma or the subarachnoid space. So there can be ischemic stroke due to the occlusion of the artery due to some, thrombus or emboli, or it can be hemorrhagic also. So it was, seen why it is happening, why CVAs are occurring in COVID-19 patients. So it was basically due to the activation of coagulation system, hypercoagulable states. Patient have various vascular complication due to the multiple organ system failure. So that was the pathomechanism that was understood. And being a neuronurse, as we have been listening since morning, various presentations also from various other speakers, we have to, recognize the stroke symptoms. That's very, very, very important. That is fast. So as a neuronurse, it is very important, not only as a neuronurse, but even, educating the family members and other healthcare members that we have to recognize the stroke symptom, the warning signs that we have to assess for facial drooping, weakness, learning of speech, and yes, time is brain. But if we identify that patient is having these stroke symptoms, we have to, take this patient as soon as possible to the healthcare facility and initiate a protocol-based stroke management. Because you see the thrombolysis, the window period for the thrombolysis is 4.5 hours now. But if we talk about the management, then the diagnostic and the treatment for COVID-19 infected stroke patient is same as that is for the other stroke patients. So here I would like to discuss a case study that is about a 66-year-old female patient with significant past medical history of diabetes mellitus, hypertension, and hyperlipidemia. So patient had all, modifiable risk factors of stroke. The patient developed history of dry cough from 1 week, shortness of breath, and general malaise. She was initially presented in ER with cardiac arrest, which resolved with CPR and epinephrine. The patient was intubated and her chest X-ray showed bilateral infiltrate. She was tested for SARS coronavirus 2 and was found positive. The brain CT revealed SAH. You can see here there is a hemorrhage that is shown in the Sylvian fissure and also the diffuse cerebral edema. The patient was unresponsive, had fixed dilated pupil, non-reactive to light, absent corneal and gag reflexes, and absent oculocephalic and vestibulocephalic movements. She was again developed another cardiac arrest and was pronounced dead. So it is not that always the patient who COVID-19 patient, if they develop a neurological complication or CVA, their prognosis is poor. We have another case study that is there in the literature. The 31-year-old male patient who presented with signs and symptoms of upper respiratory tract infection, mild fever, malaise, cough, and arthralgia. He developed sudden onset of severe headache and loss of consciousness. The head CT scan revealed a SAH. The patient was intubated and placed on an EVD, that is extraventricular drain. Due to his respiratory complication, the patient was tested for SARS-CoV-2 and found positive. He was extubated on the second day of intubation and his symptoms improved gradually and he was discharged for rehabilitation. So here you can see the patient was survived and his symptoms improved. So here comes the importance of early recognition and initiate the early management. So we have to look for the symptoms, assess the patient. Nurses play a very, very important role. We have been talking about FAST. We have been talking about GCS since morning, and 4 scales also was presented. So we should be aware of all these assessment tools and we should assess the patient. And if the patient is having some hemorrhage, some decrease in the level of consciousness, we should be alerted and alert the physician. And also the nurses have very important role in the rehabilitation. Neurorehabilitation is also very, very important. Here I just want to stress. Second complication that was reported in the literature was encephalopathy. So acute encephalopathy is a non-specific term which is used to describe the acute impairment of brain function which presents clinically as alteration in the level of consciousness. So it can occur due to various underlying causes. It can be related to brain or metabolic changes like hepatic encephalopathy or other multi-organ system failure. Usually it is triggered by infections, and here the brain imaging, EEG and CSF analysis play an important role in diagnosing the encephalopathy. So encephalopathy in COVID-19 patient may present at early stage or as a disease initial symptom. Here again, I would like to highlight a case study of a 74-year-old male patient who had a sign and symptoms of cough and fever. The patient developed mental status alteration after 24 hours of initial presentation. The EEG showed bilateral slowing and focal slowing in the left temporal region with sharply contoured waves. His meningitis workup was negative. So patient did not have some meningitis, patient EEG was abnormal, and it was later found out that patient was diagnosed with encephalopathy because of the altered mental status. Suddenly, the patient developed a respiratory failure which required intubation and ICU admission. He was later tested and found positive for COVID-19 infection. Next complication was encephalitis. Now, encephalitis, as we say, it is the itis, an inflammation in the brain tissue, brain parenchyma, and it is associated with encephalopathy with evidence when the CSF WBC count is more than 5 cells per microliter, protein is more than 0.5 gram per DL, or the MRI is consistent with inflammatory process. So encephalitis can lead to altered consciousness, hallucination, confusions, abnormal movement, aphasia, and delirium. This case study is directly coming from, China, a Wuhan male. It is an initial case study when the COVID-19 started in 2019, 2020. He developed fever, shortness of breath, and myalgia since January 28, 2020. On February 10, he had a deterioration in his status and confusion. The lab test indicated leukopenia, decreased WBC count, brain CT was normal, but chest CT showed multiple subpleural ground glass opacities. Here you can see the ground glass opacities are shown on the chest CT, white opacities. The patient was tested positive for SARS coronavirus 2. There was positive meningeal irritation signs and positive Babinski sign. Lumbar puncture was performed and CSF showed no abnormality. So there was no virus that was detected in the CSF But yes, the pressure was high. The CSF pressure was high, and it was declared that patient was having encephalitis associated with SARS coronavirus 2, and the patient was given supportive treatment, including mannitol infusion, because the pressure was high. So mannitol led to decreased CSF pressure and improved level of consciousness. Next reported complication was GBS. Various type of neuropathy. Most common was Guillain-Barré syndrome, that is the acute inflammatory demyelinating polyneuritis. It is seen that it is usually appearing within the 5 to 10 days after COVID-19 diagnosis, but it may develop even weeks after infection. So the main, pathogenesis behind GBS was the patient cellular, immune, or antibody-mediated phenomena. So the peripheral nerves of the body, they had some demyelination due to the antibody-mediated phenomena. So CSF diagnosis is necessary to include any other infectious etiology in this case, because the peripheral nerves are involved. So it can lead to respiratory insufficiency, and there can be a need for ventilation. Critical care admission is recommended in case of GBS, and IV immunoglobulins is preferred, and plasmapheresis can also be considered in GBS. This is a case study of 55-year-old male who was admitted in the hospital due to COVID-19. So here the patient already was diagnosed with COVID-19, and once after 20 days of post-admission, patient developed acute bilateral eyelid ptosis, dysphagia, dysphonia, and hyporeflexia in the upper and the lower extremities. So here in GBS, it is a classic, characteristic feature that there is an ascending weakness due to the involvement of the peripheral nerves. So a symmetrical ascending movement weakness is there. CSF analysis showed presence of oligoclonal bands, and patient was diagnosed as GBS. Serum and motor nerve conduction study were consistent with GBS, but the patient condition improved tremendously following the IV immunoglobulin treatment. This is also a common, complication that was reported in the literature. The patient developed seizures or epilepsy. So already who were having epilepsy, it was seen that patient suffer from seizure attacks. So there were withdrawal attacks because in lockdown, the patients were not having access to the physician, or their medicines is not there. So they could not go out to procure those medications. So it was seen that there was withdrawal attacks. So seizure can occur as a sequel of encephalopathy or hypoxic brain injury also, because the brain tissue is devoid of oxygen. Status epilepticus is also seen as a part of post-COVID syndrome. So here also we have to manage the patient using anti-epileptic drugs, which are the mainstay of the treatment. First-line agents like lorazepam, diazepam, midazolam, and second-line agents like newer drugs, traditional drugs like phenytoin, fosphenytoin, sodium valproate, and newer drugs like lacosamide, levetiracetam, and phenobarbital. Refractory status epilepticus is also seen, reported in the literature, that it was seen in the patient, which persists despite adequate administration of benzodiazepine. So when there are the seizures, there is a reoccurring seizure, or the seizure lasts for 30 minutes, it has been seen the patient had refractory status epilepticus. So when the patient was not, recovering, even at least at administering the one anti-epileptic drugs also, it was labeled as refractory status epilepticus. So in these cases, we have to apply more aggressive measures like intubation, mechanical ventilation.
Make it a little faster.
Yeah. So this is the last slide. So intubation, mechanical ventilation, hemodynamic support with pressors and inotropes should be given. And drugs that has to be used like propofol, thiopentone, ketamine, and midazolam can be used. If the patient is having unresponsiveness, we have to refer to the higher centers and initiate, the critical care management. To summarize, COVID-19 has had a significant devastating impact on the world. COVID-19 can cause both acute and long-term neurological complication in many patients. The prevalence of these symptoms range from 10% to 87.4% across various studies. And if we talk about acute post-COVID-19 neurological manifestation, it includes fatigue, changes in concentration, loss of memory, sleep disorders, weakness, headache, and dizziness. Cerebrovascular events, encephalitis, encephalopathy, peripheral neuropathies like GBS, seizures are commonly reported post-acute neurological complication. So there is no evidence-based specific care guidelines of patient with post-COVID-19 symptoms. The rehabilitation process in these patients is a challenge. So here comes the role of nurses. As I mentioned, we have to assess, and then rehabilitation, because these patients, post-COVID-19 patient, once their respiratory symptoms are resolved and they come home, they have these neurological complications. There is neurological deficit, which we have to take care. So thank you. Thank you so much for your patience listening. Yes.
Thank you, Amandeep. That was a fantastic and very informative session. In fact, we being neuro nurses, we concentrate on nursing patients in our area, be it a critical care or a neurosurgical ward. We actually ignore what happens in on a follow-up, including the family members of our own. Because actually this is a learning eye-opener for all of us, that we should be on a continuous monitoring those patients or those persons in our family, our near neighbors, or wherever. Yes. And we can take few. I think there is a question which has come on the chat box. Okay, that somebody has complimented you, Rekha Anil. So we can take few couple of questions. There's any questions? I actually have a thing. I mean, it is an alarming, like you have told that 35% of post-COVID, they don't come back to baseline. Is it really, is this a study which has been done?
Yes, ma'am. This is the report that is published by CDC, and it has mentioned, even I have taken some literature from the national guidelines, which was published in Director, if you see the references, it is there in the Directorate Journal of Health Sciences, Ministry of Health and Family Welfare.
That's quite alarming, eh? Yeah, actually, every year we have one or other variant. Another one question is that, the D-dimers and all, like the identifying the D-dimers levels are always quite high on these patients. So it would actually, the amount of low molecular weight heparin and all would be adding on to this post neurological complications, or like what have you?
Yeah, ma'am. There can be a risk, ma'am. There will be a risk if we are administering these anticoagulants to the patient. As I have mentioned, there can be a risk like SAH can be there. There can be hemorrhagic complication, and patient is at more risk of developing strokes.
Okay, I mean, excellent, and a lot of compliments for you on the chat box, and an excellent presentations. I mean, it is quite eye opener for all of us, and quite alarming also.
Thank you so much.
Thank you,
Thank you, ma'am.
Yeah, now we come to the second topic. That is a quite interesting one. It's a development and supporting care and the impact on the neurological development of newborns. So I invite Dr. Rimpal Sharma. She has done a PhD and she's working as an associate professor in College of Nursing, AIIMS, New Delhi. She has a rich experience of teaching of almost 16 years, and to her credit, many publications and journals. She has presented scientific papers in national and international platforms. She has been authored a textbook of pediatric nursing published by JP Brothers Medical Publishers, and has been contributed chapters in 5 books. She's a certified NRP FGM trainer. She's also a level 3 stimulation trainer certified by Pediatric. So we have an excellent pediatric nursing officer to enlighten the topic. I welcome Dr. Rimpal.
Am I audible?
Yeah, Rimpal.
Good morning, ma'am. Thank you so much for the elaborate introduction and for the kind words. And first of all, I would like to thank DNACON for giving me this opportunity to be on this platform and sharing my opinion on the neurological development and how to go about or how to help the neonates who have been admitted in NICU as their neurodevelopment is compromised. And there are not many factors which leads to delay in the picking up the development. So how to go about them, how to help them achieve milestones at the age in which they should be achieved. So I'll be sharing my screen with you. Are my slides visible?
Yes, you proceed.
Thank you. So talking about the developmentally supportive care and its impact on neurodevelopmental outcome in newborns, let me give a brief introduction about the topic and then I'll go about it. So in this session, the participants will be able to learn about the concept and importance of developmentally supportive care, implementation of developmentally supportive care in nursing units, recognizing pain and use various methods to prevent or minimize pain, and outcomes related to developmentally supportive care. So talking about newborns and how do they develop? So talking about the sensory systems that develop and the sequence in which they develop in the newborns, tactile sensation is the first to come. Then the vestibular sense comes, then gustatory, then olfactory, auditory, and visual sense is last to develop. So stimulation of early maturing senses has a positive influence on late maturing senses. Untimely stimulation within this sequence disrupts the normal maturation. Normal development of newborn becomes challenging when newborn is admitted in NICU, but high technology neonatal care and sensitive individualized approach leads to optimal neurobehavioral development. What are the things or what are the challenges that actually comes in way, or what are the threats to neurodevelopment of newborn? So talking about the threats, pain is the most important threat posed when a child or when a newborn is admitted in the NICU. Talking about pain. So pain is a signal of nervous system that something may be wrong. It is an unpleasant feeling such as prick, tingle, sting, burn, or ache. So pain may be sharp or dull, and it may come and go, or it may be constant. Why do we need to assess pain in children? So effective pain assessment is a necessary component of successful pain management. Unless and until we know that there is pain, we will not be able to handle it. And in case of babies, accurate pain assessment is particularly important, though it is difficult because neonates exposed to prolonged or repeated acute pain, including procedural pain, are at elevated risk for such adverse neurodevelopmental outcomes. How to assess pain in neonates? So after obtaining and documenting the neonate's pain history, it is necessary to quantify the presence and level of pain, document the need for intervention, and determine the effectiveness of any pain management interventions used. So not only assessment of pain is important, but then quantifying it, like how much is the pain that the neonate is experiencing, that is even more important. And once we have assessed and quantified pain, then only we can take effective measures to alleviate this pain in neonate. If pain is not taken care of, it will have serious neurodevelopmental, it will pose threat to neurodevelopmental outcome in the neonate. So the following 3 types of assessments are used to measure pain intensity in children, and several tools or scales employ one or more of these 3. Physiological parameters, behavioral and observational parameters, and self-report. So any of these 3 can be used to assess pain in neonates. Talking about them one by one. So physiological measures of pain include parameters, vital parameters like heart rate, respiratory rate, blood pressure, and oxygen saturation. Behavioral observational tools These allow nurses to monitor observable behavior that are indicative of pain. So they may be used to assess pain in children who are either too young to self-report, distressed, restricted by bandages or sedating drugs, altering their self-report ratings because of fear, or they are slept or sleeping. Then there are certain self-report measurements which also can be used, but not for neonates. So self-report measurements of pain are preferred because they provide the most valid measurement of a patient's subjective pain experience and are convenient to use. Their clinical utility is limited, however, by the communication skill of the patient. That being said, children as young as 4 years of age can often provide a self-report of their pain if provided with a tool appropriate for their age and developmental level. Then several self-report tools can be used in children of varying ages, like the numerical rating scales that we all know about, and a very common faces pain scale. So the numerical rating scales, they require patients to gauge their pain severity using numbers, within 0 representing no pain and 10 representing the most pain possible. And these scales may be used to assess pain in children aged 8 years and older, provided they understand numbers, can express the pain in quantitative terms, and can communicate verbally. So this is the numerical rating scale, and we can show it to the child and he can say the number, quantifying the pain that he is experiencing. Then the other pain rating scale is the visual analog scale, called as VAS, that presents children with a horizontal or vertical line, most commonly 100 mm in length, which anchors at each end, indicating either no pain or worst possible pain. The child makes a perpendicular mark on the line to indicate pain severity score and demonstrates good inter-rater reliability and are sensitive to changes in pain following analgesic interventions. So we can show the line to the child, ask him to rate his pain, and after the intervention, we can also ask the child, like, is there any reduction in the severity, or we can give the same scale to the child and ask him to indicate his pain, so that we come to know whether the intervention that has been done was effective or not. So these tools are appropriate for children 8 years or older in age. This is the representation or depiction of the visual analog scale. 0 represents no pain and 100 represents severe intolerable pain. Another scale that we can use for children is the faces scale, which presents children with drawings or photographs of facial expressions representing different levels of pain intensity. So children, they are asked to select the picture that best represents their pain. These easily reproduced scales require no quantitative reasoning on the part of the child. So this was given by Von Becker. This is Von Becker's faces pain rating scale that can be used by children of all ages, like 3 to 18 years of age. And the child can be asked to pick the most appropriate face or expression that represents his pain. Coming to the neonatal age group. So for them, we can use the neonatal infant pain scale, also known as NIPS. That is a behavioral scale and can be utilized with both full-term and preterm infants. The tool uses the behaviors that nurses have described as being indicative of infant pain or distress. So it is composed of 6 indicators, including facial expression, cry, breathing pattern, arm, legs, and state of arousal. All these parameters, they are scored. Facial expression, if the child is relaxed or grimace, points are given. If the child is crying, if there is no cry, 0 score. If whimpering, then 1, and vigorous crying is given a score of 2. Breathing pattern, if it is relaxed, a score of 0 is given, but if there is alteration in breathing, a score of 1 is given. Arms, if they are restrained, score of 0 is given. If they are relaxed, again 0. If they are flexed or extended, a score of 1 is given. Similarly, legs, if they are restrained, score of 0 is given, and relaxed, then 0 is given. Flexed or extended, 1 is given. And state of arousal, if the baby is sleeping, then a score of 0. If awake, again 0. And if the baby is fussy, then 1 is given. So higher is the score, more is the level of pain. So total points for the 6 parameters, where minimum score is 0 and maximum score is 7. So 0 indicates no pain, whereas a higher score indicates severe pain. Each behavioral indicator is scored 0 or 1 except cry, which has 3 possible descriptions, therefore being scored with a 0, 1, or So total pain score is ranging from 0 to 7. And this is how we classified. 0 to 2 indicates no pain or mild pain. 3 to 4 is mild pain or moderate pain, and more than 4 is severe pain. Coming to the premature infant pain profile. So that was about that pain scale is NIPS is about neonates. And then we have, if the neonate is a preterm, then we can use the PIPP. So that is a validated pain scoring system for preterm neonates. And it is used for infants less than 37 weeks of gestation. That is, they are preterm. And to use the PIPP scale, the behavioral state is scored by observing the infant for 1 second, immediately before and after a painful event. So before and after pain medication is given, 30 minutes after intravenous and 1 hour after oral medication. So like after intervention is done, we again need to assess the baby whether there is alleviation in pain or not. And the baseline heart rate, oxygen saturation, and facial expressions are assessed. And changes from baseline should be noted for 30 seconds. So this is how we implement PIPP scale and assess pain. So we look for bulged, we can look for bulged brows, brow lowered, drawn together, eyes squeezed or shut, burrowed nasolabial creases, short tongue, open angular squarish lips and mouth, and quivering chin. All these are indicative of pain in neonates. So we have discussed this, discussed about the various pain scales that can be used for assessment of pain in neonates, term as well as preterm. So NDAS is another scale that can be used for assessment of pain, and it can be used for babies from birth to 2 months, premature babies from 35 weeks of gestation, and developmentally delayed babies. So this scale is a very well-designed scale used for assessment of pain. Now, once we have assessed pain, and now we need to implement, as neuronurses, we need to implement certain supportive care measures in order to alleviate pain and help in the development of baby. Because pain is the most important threat that we are posing in the neurodevelopmental outcomes in neonates. So the answer to this threat is providing developmentally supportive care. Let us look at this concept. So talking about the definition, developmentally supportive care is defined as care of an infant to support positive growth and development while allowing stabilization of physiologic and behavioral functioning. So that was given by National Association of Neonatal Nurses in 2000. So these are caregiving activities that are important for infants' growth and development, hygiene, and general well-being. So while we are taking care of this baby, we need to implement these care measures in order to help or support the development of the newborn. The activities include dressing and undressing, diaper change, sponging, massage, skincare, and feeding. So developmentally supportive care reduces stress and promotes growth in the preterm neonate. The goal of neurodevelopmental care is to provide an environment which supports, encourages, and guides the development and organization of premature and critically ill infants. Caregiving is stressful for the newborn and interferes with the newborn's physiology and periods of rest. The development of the brain is governed to a large extent by sensory input. These experiences can affect both the anatomy and function of the brain, and consequently, in long-term perspective, impose a negative influence on the individual's stress regulation and consequently future health. So if activities of daily living are carried on in a harsh manner, we are going to pose a threat to the neurodevelopmental outcome of the newborn. So what do we need to do? We need to provide developmentally supportive care. Individualized, family-centered, developmentally supportive care is a framework for providing care that enhances the neurodevelopment of the infant through interventions that support both the infant and the family. Developmental care is designed to minimize the stress of critical care setting and to support the development of parent-infant relationship. So not only providing care to the neonate in the NICU by the nurse, but also fostering parent-infant relationship is very important in order to have positive outcomes. All infants admitted to critical care areas are acknowledged as individuals in various stages of their development, and as nurses, we need to support them in these stages of development. The principles of developmentally supportive care are the NICU should be designed well and the environment should be such that it supports the neurodevelopmental outcome of the baby. So the nursing care routines and plans, use of positioning aids, use of self-regulation aids, feeding methods, management of pain, parental participation and support, and neonatologist's attitude, all these together make the environment of the NICU, either it can be supportive to the care, development of the baby, or it can have a distracting effect on the neurodevelopmental outcome of the newborn. So one needs to be very careful while handling the neonates in the NICU. Developmentally supportive care reduces stress and promotes growth in the preterm neonate. Stimulation of the early developing senses, tactile, olfactory, gustatory, and protecting the later developing senses, that is auditory and visual, is the core principle of developmentally supportive care. So the 5 key components of developmentally supportive care include: first is protected sleep, second, creating a healing environment, third, family-centered care, fourth, developmentally supportive activities of daily living, and fifth is pain management. Kangaroo mother care is the best form of developmentally supportive care. Talking about all these components one by one, let's see pain management. So we had discussed about assessment of pain. Then comes management of pain. We'll be looking at it in the coming slides. Protected sleep is the next component, and it will include cluster care, nestling, swaddling, environment, and PMC. Developmentally supportive activities of daily living includes activities of feeding, non-nutritive sucking, nappy change and massage. Family-centered care includes kangaroo mother care, education and participation of the family members, as well as collaboration with the family. And healing environment will include or will emphasize on noise, light, smell, positioning, and kangaroo mother care. So how to provide developmentally supportive care? So initially, assessment is important. So as nurses, we need to be very vigilant and focus on these points. Assess the general condition of the baby, assess behavioral clues for pain and any visible manifestations like maintaining a certain posture, squirming, wriggling, jerking, excessive crying, avoidance of feed, etc. So all these behaviors indicate that baby is not at ease, baby is in pain. Also assess the child for resistance to bedtime, temper tantrum, etc. Coming to the interventions, like once the baby is in pain, once the baby is in stress, what needs to be done as nurses? So give a comfortable position to the baby, provide a calm environment, avoid bright light, loud noise, limit the number of painful procedures and handling, that is also known as bundle of care, bundling of investigations and nursing interventions, so that again and again we do not disturb the unit. Whatever care is to be provided at a stretch or in one go, we should try to provide. Swaddling, facilitated tucking, distraction measures like talking, music, etc. can be introduced, can be used. Tactile stimulation like stroking, caressing, and massaging. And in non-pharmacological measures like sucrose or glucose solution induced analgesia, breastfeeding, skin-to-skin care, and non-nutritive sucking can be used for the baby, as they do not, and if they do not work, then we should shift to pharmacological measures. Then after medication administration, again assess pain to see whether there is alleviation in level of pain. Observe the infant closely during any intervention or handling to determine their tolerance of the activity. Provide rest periods, that is quiet times, where avoidable disruptions to rest, except in emergency, are minimal. And encourage and support periods of rest and sleep by decreasing light, noise, and activity at the bedside. Support opportunities for infant self-regulation by assisting with hand grasping, non-nutritive sucking, swaddling, or facilitated tucking as the infant's condition allows. Then one by one, let's see about the points on which we should focus on. Positioning. What needs to be done and what need not be done, or what should be avoided. So talking about the do's, sideline or lateral position should be given to the baby as it enhances hand-to-mouth coordination, prevents retraction of the shoulders and abduction of legs. Prone position also can be given as it helps develop the balance between flexion and extension, improves oxygenation, reduces heat loss and energy consumption. Also, supine position can be given with resting, as this allows flexion Midline orientation and forward gaze. We should not keep the baby continuously in supine position without nesting, as this leads to retracted shoulders, delay in midline orientation, and delay in eye and mouth coordination. Also, continuous lateral position should be avoided, as this leads to upward gaze and flattening of head on one side. Extended position should be avoided, as this inhibits flexion and impacts the movement and functioning. Coming to healing environment, what should be done? Reduce lights at night to follow a circadian rhythm. Cover the bassinet for preterm infants. Move away from the bassinet while discussions. Gently roll the baby towards you while lifting the baby or changing their position. So all this will help the baby sleep comfortably. We should not switch on the lights when not needed. Do not write on or discuss near the bassinet, as this may disturb the baby. Loud noises should be avoided in NICU, as it leads to stress and startling of the newborn. Do not pull chairs and add extra noise in NICU. Do not pick up an infant in a harsh manner. So if we take care of all these things, then we are providing healing environment to the newborn. Nesting, another very important concept that is preterm. So nesting in the NICU involves placing a thick boundary made by clothes around the preterm infant to reduce stress, encourage protected sleep, and facilitate growth and development. You can appreciate very well in the picture that baby is placed in the center, and a boundary of cloth is made around the baby. So this gives a sense of security to the baby, and the baby feels like he is in the womb. So this position can be used for keeping the neonates. They will have a feeling of security and safety and will be sleeping well if kept in this position. Feeding. So feeding is another stressful activity for a preterm baby. So what should be done to make this activity less stressful or a pleasant experience for the baby? So feed the baby while in kangaroo mother care. If on palliative feeding, swaddle the baby and hold the baby close to the body. How to swaddle the baby? The picture below shows. Like the baby can be kept in mummy restraint, wrapped well, handed over to the mother and then or the caregiver, and then the baby should be fed if the baby is given palliative feeding. During breastfeeding, also swaddling will help the baby. Will keep the baby supported and will help in maintaining the temperature of the baby. So swaddling is very important while we feed the baby. Implement strategies designed to support feeding, like non-nutritive sucking, skin-to-skin holding during nasogastric tube feeds, and immunosupportive oral care, like mouth care with breast milk is very important, and it really helps in maturation of the immune system of the baby. Parents should be encouraged to feed the infant as much as they are able, enabling the parents and infant to develop their feeding routine. And where possible, facilitating opportunities for breastfeeding are encouraged, and this may include sucking at an empty breast to encourage lactation. So baby should be handed over to the mother whenever possible, and as long as she can keep the baby in her lap close to her chest, it is good. Do not feed the baby with arms dangling. If the baby is not tucked well, if the baby is not swaddled, then avoid feeding the baby when the arms are dangling. Then feed the baby while the baby is drooling. Do not feed the baby if the baby shows signs of drooling, and feed if the baby shows signs of stress. So avoid feeding in all these conditions: in arm dangling position, if the baby is drooling, if the baby is showing signs of stress or is in severe pain, then immediate feeding should be avoided. Containment should be practiced. What is containment? It is the procedure of calming a preterm or sick infant in the NICU by the caregiver or a healthcare provider. Place one hand on the infant's head and other hand on either the infant's arm, lower back, or soles of feet. So this gesture gives comfort to the baby. So all the activities, do not consider the baby is crying, aise ro raha hoga. Okay, we should be very particular about each and every move of the baby. If the baby is crying continuously, this shows that baby is in stress, or maybe the baby is wet, or maybe the baby may be in pain. So try to comfort the baby, and one can comfort the baby by placing hands or touching the baby, providing gentle touch to the baby, keeping hand on the infant's head, or holding the hand of the baby or the arm, or supporting the lower back, or patting on the back, or touching the soles of the feet. Family collaboration in providing care and kangaroo mother care are another important concepts in developmentally supportive care. So let's look at this concept. The relationship between an infant and their family is of critical importance, as it forms the basis for infants' future social, emotional, and cognitive development. So to support the provision and collaboration of family-centered care for neonates, we should promote the following. Parents are not considered visitors in critical care settings. Parents and siblings should have unrestricted access to their infants. Parents are encouraged and welcomed to be present at any time, especially during ward rounds and nursing shift change. Parents are supported by staff through demonstration and education to be involved in daily
Dr.
care.
Dimple, the time is up. Can you make it little faster?
Sure, ma'am, sure. Cuddling, skin-to-skin contact, non-nutritive sucking, feeding and bathing of the baby. So in all these activities, parents should be involved. Another concept is positive touch that we were talking about. So positive touch involves various types of infant touch interaction, including handling, holding, and kangaroo care. So positive touch is a way of counterbalancing the many and often inevitable unpleasant experiences which are a result of highly technical care, neonatal care that is provided in the NICU. So then comes the role of nurse. In all these concepts, there is a very important role that nurses play in taking care of the baby. So the traditional focus of hospital nurses on the medical concerns of infants and toddlers is now expanding to encompass the more global view that integrates the developmental level of each infant or toddler into the nursing care plan. Research on early brain development has supported the focus on developmentally supportive care in NICU. Nursing support in the early relationship between infant and parents will influence the infant's future development, and the nurse is in an excellent position to support the family integration into the care of the newborn. So they should be introduced with the concept of developmentally supportive care. So the take-home message is stimulation of early maturing senses has a positive influence on late maturing senses. Untimely stimulation disrupts the normal maturation. Also, exposure to repeated pain could affect the developing brain adversely. So, developmentally supportive care should be provided, which provides a structured care environment that supports, encourages, and guides neurodevelopmental organization of neonates. It is important to do environmental and behavioral modifications to protect neonates in the NICU. So that's all about my topic. These are my references. Thank you for your attention, and I'll be happy to take any questions if there are. Thank you so much.
Thank you, Dimple. That was actually a session of profound knowledge. In fact, we actually, being a neuro nurse, we actually, the neonatal part is little bit of ignorant for most of the neuro nurses. Yes. So that was amazing, and it was a lot of knowledge, lot of take-home messages. In fact, I should be saying that the DSE, and the best part of your presentation was you put on the do's and don'ts. In fact, we actually, that was easy to differentiate between the things and the family collaborations. In fact, that how I feel how a nurse molds a family, a mother during the neonatal care, actually take the care ahead also. Because we should not think about the stereotypic message, because we all been in the older times where our own grandparents or the great grandparents used to say that the child should cry and develop. So that all stereotypes and all, you actually read. I think there is the chat session. Let me come to. Like at present, there is no questions. We can ask the audience for some questions. If there is any questions, I think the time also is. So, Shruti, we can take a question or not? So, now for me, one thing is that, Trimple, the thing is that the teaching towards the nurses, in the neonatology. I've been being a neurological thing. So the nurses to the teaching to the in the neonatal ICU should be more strengthened about this collaborative and family collaborations. What do you think? Your experience or thing?
Yeah. Like I've been going to NICU for regular rounds, supervision of my students. So what I felt is few nurses, they are like very much caring, very much attached to neonates, but few nurses, very few, they may handle infants harshly. So my take is they should be sensitized to this concept. Like touching infant harshly will have later, we may not realize now, but it will definitely, it's going to help have long-term consequences in the development of the baby. Then if the baby is in pain, if we do not pay attention, baby is going on crying, if we are not concerned, not looking at the baby, not handling the baby, this again is going to have long-term consequences. So one needs to be, or the nurses, they need to be more knowledgeable, they need to be taught, and continuous reinforcement of these concepts should be there. And they are not very difficult to follow, very easy to follow things, but very minor things, which if nurses will keep in mind, definitely their care will be they'll be able to give 100% care, and the developmental outcome of the newborn will be good. So we'll be improving our quality of care.
Absolutely true. I mean, thank you so much, Dr. Rimple. And it was a very interactive and very informative sessions, I should be telling. Thank you so much.
Thanks a lot, ma'am.
So
It was a
we can
pleasure.
wind up for this session. I hand over to the moderator, please.
Thank you, Ms. Amandeep and Dr. Rimple Sharma for an informative and interesting session. Thank you, Lieutenant Colonel Sandhya, ma'am, for moderating the session effectively. Former President, late Abul Kalam once said, learning gives creativity. Creativity leads to thinking. Thinking provides knowledge, and knowledge makes you great. The learning and knowledge we are acquiring from each session is amazing. With that zeal, we are moving to the split session 4. The chairperson for the session is Ms. Namita Basaya, RN/RM, Nursing in Charge, Neuro ICU, Apollo Hospital, Guwahati. She has worked as educator in community-like school health program, industries, with collaboration of Rotary Club and marketing team Narayana Health. She has been actively participated in different audit processes in the hospital. For example, 360-degree, NABH, Nursing Full Circle Audit, and various internal audits in the hospital. Have coordinated and worked as organizing member for Neuroscience Workshop Conference in Guwahati. To name few, stroke awareness, epileptic disorder, pediatric hydrocephalus, stroke thrombolysis, and many other. Have been involved in organizing the Stroke Nurse Certificate Program for nurses in the Apollo Guwahati Hospital. Over to you, Ms. Namita.
You are muted.
Ms. Namita, you are muted. Please switch on your mic. No, you are not audible.
I request Mr. Atish. Request Mr. Atish to. I request Mr.
Am I audible now?
Yes, Namita, you're audible now, please.
Yes, thank you. Thank you so much. Namaste and good morning to one and all present. I hope you have been enjoying the session since morning. It has been a very knowledgeable session. So I'll be chairing this session, and in this session, we have two eminent speakers. Our first topic is spinal cord injury, nursing management. Spinal cord injury is one of the most leading cause of morbidity and mortality. Spinal cord injury association states that approximately 450,000 people are living with spinal cord injury in USA. Also, every year, 17,000 new spinal cord injury occur. Also, CDC states that spinal cord injury costs $9.7 million each year. So its appropriate nursing management is of utmost care and utmost importance. Therefore, let me introduce our speaker for this session, Ms. Beena Malhotra. She is the Senior Nursing Officer, Neuro Unit. She is the founder of Delhi Neuro Nurses Association 2003. She has presented many papers in national and international conferences and won competitions between 1987 and 2014. She had been the scientific coordinator for many neuro conferences from 2009 to 2012. She has won this Delhi State Award in 2012 and DNA Achievement Award in 2019. She has won the most prestigious Florence Nightingale Award in 2019. So without further delay, I would like to hand over the session to Ms. Beena Malhotra to present her topic.
Hi, good morning. I'm audible?
Yes, ma'am, please carry on.
Yes, good morning and namaste to everyone. Once again, I'm so happy. I think it's a huge numbers of registration in DNACON. And I'm once again welcome on behalf of DNA. It is my privilege to welcome all of you to 20th Annual Nurses Conference of Neuro Nurses. Hello, are you audible? Some problems are there?
Ma'am, you're audible.
Once again, I'm welcome to you all of you, 20th Annual Conference of Neuro Nurses Forum of Delhi and NCR. And we are meeting along with our colleagues on 24th Annual Day of DNA. You may not be aware of that Delhi Neuro Nurses Forum is one of the first association of its kind in Delhi, wherein specialized continuous nursing education program is happening for the last 20 years. It's I will not be a surprise that ours may be the only specialized association amongst various other super specialty branches in Delhi. This has been a long journey for the last 20 years. And I would like to express my gratitude to each one of the one of you who have supported neuro nursing and have with this team and stood with us over the years. I'm great and thankful to Indraprasth Apollo Hospital who have wholehearted supported us to organize this year meeting. It's once again, thanks to everyone and especially organizing team. Now I'm come on the my presentation, spinal cord injury, nursing management. I'm coming from GB Institute of Postgraduate Medical Education and Research. And I'm a senior nursing officer in Neuro Operation Theatre. The basic anatomy of the spinal cord is shown. The spinal cord extends from the skull to the first lumbar vertebra. It consists of gray matter and white matter. Gray matter located centrally and white matter is surrounding the gray matter. The white matter of spinal cord consists of ascending and descending fiber tracts. Two types of fiber tracts are the ascending and descending. Ascending transmitting a sensory informations and descending tract transmitting a motor informations. The spinal cord is also responsible for the spinal reflexes. And spinal cord injury incidents are approximately 15 to 20,000 per year. And most common injury is the cervical spine injury, and area is the C5, C6, and C7 because of his mobile area, mobile spine area, and 50 to 60% are the cervical injury in the whole spine injury cases. And damages ranges as a concussion, contusion, lacerations, compression, and complete cross-section. Early treatment prevents total and permanent damage. And as a nurse, we have various components of spinal cord injury. And now we are stress on the each components, who, when, what, where, how, and watch out. And who all are the stakeholders? Are the patients, relatives, nurses, are the nurses, helpers, nurses, aides, and nursing orderlies, ambulance team, ambulance driver, all are the stakeholders. And the spinal cord injury is a dynamic process when time is the best for management of spinal cord injury. First 72 hours has the best time for the outcome of the patient. And the first 72 hours is the spinal shock, crucial time for the spinal shock period. But it may be prolonged within 7 days or more than a year or within years. But delayed is the poor recovery. And where to site of accident to and the rehabilitations. First site of accident and end of rehabilitation. Patient goes to in each area, site of accident, emergency department, operating area, spinal unit, maybe ICUs, special ward or general wards, and of the rehabilitation. And now my in spinal cord injury, main aim is the summarized under the following heads: protect further injuries, provide an optimum environment, prevent complication, ensure the optimal results. And these are the various causes for the spinal cord injuries. Most common cause is the roadside accidents. And patient can be fall, assault, disasters. So many disasters is earthquake and etc. And sports injury is very common. And two types we have a mechanism injuries: high velocity and low velocity. In high velocity, needs a lot of care. And high velocity injuries most commonly is a high speed four wheels vehicles. And low velocity is a special rickshaw, cycle, and thelevala is a low speed velocity. And there is a various types of injuries in spinal cord injury. That's complete, partial, with vertebral injuries and without vertebral injury. In CT, we have seen this area is C5, C6 fracture with dislocation, and MRI shows in this area as have a spinal cord injury or maybe partial injury in the same C5, C6 area. And now is the patient, how to localize the level of injury. So we have divided in the 4 level: presentation, cervical, thoracic, and lumbar sacral. If patients have a cervical injury, patient may be a quadriparesis, and tone will increase, reflexes are brisk, and sensory loss may be below neck. And thoracic injury, patient have thoracic injury, patient may be paraparesis, increased tone, reflexes are brisk, and sensory loss is below the chest. And when patients have a lumbar and sacral area injured, so spinal injury, so patients have a paraparesis and tone is decreased, reflexes are low, and sensory loss is below abdomen. And now we are going on scores. There are various scores to quantify. Commonly in use in India, Asia scores. We are commonly using Asia scores. Japanese score is also we are using, but in India, most common patient evaluate through the Asia score. American Spinal Injury Association scores. Score is very important for like how much extent the injury, how the patient's prognosis, and compensation help for the claim. And it's also helps for the disability certificates too. Disability certificates. So we are sensory loss in patients. We are dividing in the 3 criteria. We are dividing in 3 criteria. Absent sensations in 0, and 1 for the presence of sensations but abnormal. And our 2 is for normal or intact in sensation. In motor, dividing motor loss in dividing in various category is 0 for the total paralysis, and 1 for palpable or visible muscular contractions. And second is full range of movement with gravity eliminations. 3 for full range of movement against gravity. 4 full range against gravity and partial resistance. And 5 for normal or full motor activities. And the diagnosis is largely clinically. Now we are already explained you in previous slides to how to evaluate the patient through clinical examination, and also helps the X-ray, CT scan, and MRI. In this below this one, this slides have you already showed. I have shown you patients have posterior damage. Patient have sensory loss. Sorry. Patients have a sensory loss, and this one is same fracture and dislocation. And this is the Shivora, spinal cord injury without radiological abnormalities. Patients, in this case, patients have a neurological deficit, but MRI and CT scan shows no deficit, absolutely normal. CT and MRI is normal, but patient have a deficit. So doctors evaluate through the clinical examination. I already explained you in previous slide. And now is the very important, most important point for the how to transport the patient. Is everyone is responsible for the transport the patients. Start from the site of injury and end of the rehabilitation. Always we stress on the transportation. So patient should be always transporting through the hardboard. Always use hardboard. not like a patient put on the sheet and is a bundle. Sometimes we are making a bundle. So further we have extend the injuries. And patients always immobilize. Patient immobilize the part. Maybe the spinal or spine should be always immobilized because we don't know patient which area is damaged. So always spine should be immobilized and in neutral position. In any injury, patient should be transport to the neutral position and a supine position. And patient should be immobilized to a collar and so different types of belts shown in the picture also, and braces, apply the braces. But neck collar and the belts should be applied during the transportation. And a few devices have these type of the collar and traction, and this is the traction for the cervical. This one also collar is for the cervical area. This is the device for immobilize the part. And the few are the same devices for immobilization, and these are the dorsal and lumbar immobilization. And spinal shock, in which this flight, spinal shock period is the first 72 hours. It's a very crucial time for the patient. So patient watch for the transient suppression or reflexes below the spinal cord injury, flaccid paralysis, hypotonia or areflexia, loss of autonomic function, cessation of all reflexes, activities below the site of injury, last normally for 24, first to 72 hours is very crucial. And sometime may be prolonged with more than a year or months. Return of reflexes, activities, and development of spasticity below the level of injury indicates end of spinal shock. A nursing care plan. So how to we make the plan for give a care to the patient. Is very most important is the psychological or physiological, environmental needs to revise from time to time collaborative approach. It's a routine patient care for the in physiological, and psychological support is a very important point. Patient is conscious, but patient in mentally trauma or physically trauma. So as a nurse, we have improved the patient's moral support for and psychological support. How to improve the patient's normal and back to the normal life. And also environmental is very important. So surrounding environment is effective for the improvement of the prognosis. And we have a various components for the improving the plan. Injured part stabilization. I already explained you how to stabilize the part. So we have to see, sometimes patients have a head injury. So we think the patient, everyone is stressed on the head injury. But always patient have already injured, but spine should be, because we don't know when the patient's head affected, so along with the cervical area is also affected. So we are assess the vital signs, motor and sensory functions also, and assess the hemodynamic parameters, ensure optimal end organ for perfusions, and gastritude for the first 24 hours, and pain. Pain is important point. Patient is in very severe pain, so pain relief is the very crucial for the patient. So always first relieve the pain, along with side to side treat the emergency. And bladder and bowel care is also in this spinal cord injury patients. Drug therapy for the spinal cord injuries, methylprednisolone is a very, very most important drug. Is very effective first to 7 to 8 hours. Is very effective. And along with dextron, atropine, vasopressor, analgesic, antispasmodic, and anticoagulants, etc. And the second approach is the surgical approach. Surgical treatment is depend upon the site of injury, which type of injury, patient's age, and extent of injury, nature of work, patient's ka jo lifestyle, how's the lifestyle, is depend on, everything is depend on the surgical treatment, and is very expensive also. Spinal cord injury, patients suffered, so it's very expensive treatment for the spinal cord injury patients. And most important aspect of the rehabilitation start from the day one rehabilitation and start of the site of the injury to end of the rehabilitation. Is each and every place have the rehabilitation is a very more important, and rehabilitation is not a single person job, is a teamwork along with the physiotherapist and occupational therapist. They are playing a very, very major role for the spinal cord injury patient. And these are the few robotics are using in advanced stages. This picture is patient can mobile in this device, and this is the for devices, the hand movements, hand and finger movements, but it's very expensive. And now prognosis are very good prognosis, not very good, but good prognosis in partial injury, hypertonia, and lumbar injury. Patients gradually improve, not as like other medical problems, patients improve in within week or 15 days. And bad prognosis in anal reflexes are totally absent, hypotonia, bladder and bowel improvement, and cervical injury is also. Now again, cost of treatment. Spinal cord injury is one of the costlier medical problem for us. It's very expensive. So normally poor people suffer lot suffer for the cost of treatment. And rehabilitation is very costly along with the caretaker, because it's not a single person job. So caretaker is required for the spinal cord injury patients. Is overall is very expensive. And recent future treatment. Now the recently we have seen stem cell treatment and autologous bone marrow transplant is a recent researches is going on. In our institutes also apply these stem cell program and autologous, but in later stage because of patient report in our institute later. So reports are not satisfactory, but research is going on what's effect on early stages and later stages. So only 8 to 10 patients we have done the research on the stem cell or autologous bone marrow therapy. And the complications are in early stages. It's very common: respiratory failure, atelectasis, and pneumonia and spinal shock. And later, autonomic dysreflexia include the full bladder, distended bowel, skin irritations, and etc. If infection, any kind of infection, bad sores, malnutrition, dehydration, DVT, and bowel elimination, along with cholecystitis, cholelithiasis, and bladder training program also. And contractures and spasticity is also seen in the patients, along with respiratory infection also. And carry home messes patients have during the discharge, or patient shift to anywhere, the home or rehab center. And so as a nurse, we have a major responsibility to what type of messages we are giving to the patients. Head injury patients can have a spinal cord injury. So we have generally missed along with the head injury patients. Brachial plexus injury also missed. क्योंकि always stress on the head injury patients or maybe the spinal cord injury. Sometimes patients have limb is not working. So it may be a fracture or plexus injury, also root injuries also. And we should be know the level of injury and effect of level on presentations. Type of care based upon the level and types, DVT, chest, how to improve the chest, how to give the chest therapy is the very important for teach the patient's relatives or attendants or take care. And bladder bowel exercise and how to improve the bladder and bowel eliminations, autonomic functions, and how to feed the gastrostomy or rice tubes feeding, care. And we have no national level program in according to my knowledge, but head injury have I think so many programs in on national level. So we should be, and government should be stress taking for the national level program of the spinal cord injuries. And thank you so much, and thank you for listening me once again. Thank you. Slides.
Thank you, ma'am, for the enlightening session. Any queries? I do not see a question in the chat box. Ma'am, yes, ma'am, it was a very interesting session, and I really enjoyed that you emphasized on the use of spinal board, which is usually being neglected. So I think after emphasizing, many of our young nurses will realize that when a patient comes to the emergency, maybe a case of an RTA or maybe a fall history, we would now be more cautious to use of a spinal board and avoid all those movement. We will immobilize to a good extent and prevent further injury. That would be very nice, ma'am. Thank you for the wonderful presentation, ma'am.
Thank you so much. Thank you so much.
Who else other than a nurse, the backbone of Healthcare Institute, could have better spoken about this topic, ma'am? Thank you so much for your enlightening session, ma'am. And we have our next topic, brain death and organ donation. Just like a phoenix is born from its ashes, a person is born after organ donation. So without further ado, we'll move on to the next speaker, Miss Jenny C. John. She has done her master's in clinical psychology. She is the transplant coordinator for cadaver in the Prasta Apollo Hospitals, New Delhi. She has worked with hospitals, addiction center, orphanages, old age homes, and clinics. She has also wrote a dissertation on the topic emotional maturity and adjustment in homosexual and heterosexual college students. Since 2020, she has also been working as a freelancer. She has a keen interest in attachment styles and human behavior. She is skillful in handling counseling and providing support to individuals who are going through emotional and psychological struggles, intra and interpersonal issues, along with sexual and relationship issues. As a counseling psychologist, she is passionate towards providing a safe, non-judgmental space along with a client-centered approach. Over to you, Ms. Jenny C. John.
Thank you so much for that introduction. Without any further ado, I'll just start with the slides and we'll talk about organ donation and transplant. I'm hoping you can see the slides.
Yes, we can see the slides.
Yeah, okay. I'll just start. What exactly is organ donation? Organ donation is a process of surgically removing an organ or an tissue from one person, that is the donor, the potential donor, and placing it to another person, that will be the recipient. Just a second. The Indian scenario, what we have about organ donation, the two leading causes for end-stage kidney failure in India is diabetes and hypertension. And it's estimated that around 210,000 patients are suffering from end-stage kidney failure. And again, for the same, for liver failure, we have B and C viruses and alcoholism that, that has led to an increase for the liver failure. You can see the figures. Overall, it is estimated that 500,000 people in India need kidney and liver or heart transplant, against which only 8,000 transplants are done annually. So you can see the numbers. It's like 500,000 people are here and it's just 8,000 transplants that are done, which again barely meets 1 to 2% of demands for organs. In India, around 6,000 people die waiting for an organ. So it's just not kidney and liver, it's heart or it's lungs, it's any kind of transplant. And the death rate is also quite high. Every 17 minutes, someone dies waiting for a transplant. And as a coordinator, I can like give this a surety that in every 13 minutes, someone is added to the waiting list. The waiting list is, just increasing day by day, but we are not getting that many organs to be donated, or, any donor is not really that available. Now, the role of nurses in organ donation. Professional nurses are often the primary caregivers for patients approaching the final stage of life. It is a nurse who facilitates the coping of patients and their families. The nurse, along with the work of transplant coordinator, is anchored on counseling and facilitating the process for organ or tissue donation. By again, educating the families, because, the families do not really confide in a transplant coordinator because they are new to them. They are not around the families a lot of times. Obviously, the transplant coordinators are going on for rounds and everything, but it's nurses who are there in the ICU. They are present there. They are seeing the attendants daily. So they have that connection with them. Again, if I talk about the transplant team, there are a lot of challenges faced by them, among which one of them is poor coordination. And that is between nurses, consultant, and obviously the transplant coordination. It is mandatory for the transplant coordinators for, the ICU rounds and everything. But logically, if we see, they can't be present in the ICUs all the time. It's the nurses again. So there are possibilities when hospitals declare brain death and people are not in place to counsel the families or, educate them or create an awareness, because of which it leads to poor conversion rate. And this happens because of lack of coordination. In the light of number of brain deaths that probably take place every year, the number of donation is the comparison of donation is very, very low. This is also because the brain death cases go unrecognized by the hospital itself. Again, the nurses stay with the patients and help the family to understand the organ donation process. The transplant team is obviously making an effort and making them understand how they can, donate and everything. But again, end of the day, they do confide in nurses, and I have seen that live itself. So that's why the role of nurse is very, very much there in the whole donation process. Now, facts about donation. Organs like heart, pancreas, liver, kidney, lungs can be transplanted to those recipients whose organs are failing, because it allows many recipients to come back to a normal life. As a nurse, one should always have in-depth knowledge regarding these things, like what is organ donation, as I said before, what it is and why is it needed. It is needed because in India, we really need organs and people are really dying because of lack of it. How does organ donation help patient with organ failure? Who is to contact when you suspect a brain dead person? So this is also important. You need to contact a transplant coordinator as soon as possible whenever you suspect a brain dead patient. Counseling the family members of brain dead patient for organ donation. Now, every hospital have these grief counselors, medical counselors. So obviously they will be there to counsel them, but the nurse is also to be there to be with the families, because again, she or he knows the family better. What body parts can be donated? Who can be potential donors? So, a lot of time attendants are like asking nurses these questions that they want to donate. They want a family member whosoever is brain dead and they want to go on with donation. So the first person they will be contacting is the nurse itself. The nurse should be knowing these things a little bit, if not in depth, so that she can even, she or he can create that awareness. Now there are ethics also. The nurse's first obligation is the well-being of the patient that is entrusted to our care. First of all, you need to see about the well-being, and all of the other things are secondary. Then there are she should be the whistleblower if there is any unethical things that is happening. The act of procuring organs should never be the explicit cause of a person's death. After declaring the brain death, only then we can talk about organ donation. It's not that even before that we are going and talking about, that if you are interested, you can just give out the organs and all. Only after the, we have this Form 10, only after the declaration, only then we can talk about it. Now, types of donors, we have living donor, we have deceased donor. For living, we have related and unrelated. So living, we are not really talking about living here. We are specifically talking about brain death here. So that comes under deceased donors. So in deceased also, there are two types, brain stem death and natural death. Natural death in India, in Delhi, we are not really doing that. But yes, PGI Chandigarh has been doing that. So brain stem death is something we are, following a lot. Now, organ donation after natural death. These are the organs that can be donated after death. You can see them: eyes, skin and fascia, heart valves, bones and tendons, cartilage, veins and arteries, middle ear bones. The concept of brain death, I'm sure you all know already the concept behind the brain death thing, but I'll again repeat. Irreversible brain damage and loss of brain function as evidenced by cessation of breathing and other vital reflexes. Common cause of brain death. Again, most of the brain death causes in India are because of road traffic accidents. That is the most common cause. You can see here, it's the causes. Mumbai and Delhi are the leading among everyone for the road accidents that's happening. Now this is for after brain death, the organs that can be donated. Both your eyes, kidneys, liver, lungs, pancreas, small intestine, voice box or larynx, hand, middle ear, bone, skin, fascia, numerous bones and numerous. Now this also is important, time factor and preservation. For kidney, it is 48 hours. For pancreas, it's 24 hours. This is in between 48 hours, the transplant should happen for kidneys. The least time frame there is for heart and lungs, that is 6 hours. You can see the age factor also for organ donation. For tracheal skin, they have an age limit. It is not 0 to 100 years, it's 50 to 60, 16 to 85. Now, cadaver seen in India. For cadaver to take place, there should be a license for the hospital in Delhi for carrying out cadaver transplants. Among almost 50% of cadaver is done in Tamil Nadu, that is the south of India, and most of the cadaver cases are also run in South India, which specifically one of them is Tamil Nadu. Testing before testing someone for brain death. These are the things that is tested. Pupils must be fixated or fixed. There must be no corneal reflexes. Almost all the reflexes should be absent. So no limb movements, no gag reflex, no cough and other. No respiratory movements should occur in response to disconnection from the ventilator. Now there are apnea tests. This is the deciding factor of brain death. So this test has to be happened in the interval of 6 hours. So 2 times this happens. This shall be done by 2 consultants other than the treating consultant. So including neurologist, neurosurgery, neuroanesthetist, consultant, all these people are the one who are, directing this apnea test. They should be included in the panel approved by the Directorate General of Health Services. certifying brainstem death. So all the ICUs always have the panelists. Mostly all of them have it. Again, the completion of Form 10 is also very important when you are testing apnea, and the second one also comes positive. So make sure you always fill the Form 10. The legal time of death when it's brain death. So second apnea test, when it comes positive, that is the one that is considered as the legal time of the death. Now consent, if at all the family agrees for donation, the consent could be given by someone blood relation. If it's a son, if the parents can give, if he or she is married, the spouse can give. Anyone above the age of 18 can give. Now there is also a possibility, when in case of a child, the consent is next of kin from Form 8. So Form 8 is the form, it is very important to fill that form if at all it's going on for donation. So organ retrieval in brain death. In general, the order for organ removal is as follows: heart and lungs first, then it will be liver, pancreas, and then both kidneys. The corneas are the last to be retrieved. This is the card, the donor card that we can also fill. Anyone can fill these cards. Again, even if you are filling and God forbid something happens and it ends up with any one of us being brain dead, this doesn't mean that you have given the consent. Your family should be there. The family will, give the consent. It does act like a donor card because of your interest, but if the family is not filling, we are not going to take any organs of yours. Thank you. This was the PPT. I would also like to share something. A lot of times when we talk to attendants about brain death, they have this very big confusion that, the patient has gone into coma and not brain dead. So between coma and brain dead, they have this confusion. So I would like to, share a video also with you guys to not have this confusion that coma is very, very different from brain death. Brain death itself says it's death. So it is death. Coma, you can come back and come out of it also. So I would like to share a short video. Just a second. Can you see the?
Yeah, the video is visible. You can start the video.
Okay.
Difference between brain death and coma. People often confuse brain death with coma, and to the untrained eye, they do look similar. But in reality, telling them apart is a question of whether or not one is alive or dead. The brain consists mainly of two parts, the cortex and the brainstem. The cortex does higher thinking, whereas the brainstem controls breathing and is the center of human consciousness. If one's cortex is severely damaged, one can become unconscious and fall into a coma. But since the brainstem controls breathing, while in a coma, one can still breathe. Although occasionally, comatose patients are sometimes attached to a ventilator to help them breathe. Comatose and vegetative state mean the same thing. Comatose is just short-term, 30 days or less, and after 30 days, it's called vegetative state. Sometimes people can recover from a coma and from a vegetative state. Brain death, however, is a whole different story. Brain death is qualitatively different than coma. Brain death means the whole brain has died, both the cortex and the brainstem. Normally, if your brain dies, you can't breathe, you can't get oxygen, and all other organs die. But if you had already been connected to a ventilator when your brain died, your heart keeps on getting oxygen from the vent, and it keeps on beating on its own accord. The heart has its own natural pacemaker and does not know the brain has died. The organism is dead, but its organs remain alive for a few more days. The most important difference between brain death and coma is you can wake up from a coma But you can't wake up from brain death because brain death is death. Brain death is final, even on a ventilator. Upon the onset of brain death, all the organs, including the heart, will die in a short period of time. No one has ever woken up from brain death. Unfortunately, many people, including journalists, use the terms coma, vegetative state, brain death, and brain damage interchangeably. And this confuses people. But now you know better. Coma is not brain death, and brain death is not coma. Brain death is death. And the living organs, if donated, can save 8 other lives. Organ donation saves lives.
Yes, that was it.
Thank you, Ms. Judy.
I hope it's very, clear now.
Yes. We have a question in our chat box. The question is, which is the most common organ which is transplanted?
So it's kidney. And talking about living transplant, it's always kidney. So we have a lot of transplant that's going on. Like, in a month, it's like 30 to 40 kidneys that has been transplanted. Yeah. After kidney, it comes liver. But again, that is like, if we are comparing, liver is really in a small number, but the kidney is the maximum.
Okay. Does anyone wants to ask any question? Any of the faculties? And I must admit, it was a really interesting session. And now I think it must be very clear what is the difference between a brain dead person and a comatose patient. Yes. I think that small bridge which was there, now it is clear, and we can decide which side to cross and where to decide. And yes, thank you for really enlightening us about our responsibility as a nurse for a transplant. The coordination which is required between a transplant coordinator and a nurse. Yes. Thank you so much for enlightening us on that.
Thank you so much.
Thank you, Ms. Jenny, for the wonderful session. Yes, indeed, without the organ donor, there is no story, no hope, no transplant. But with an organ donation, life springs from death, sorrow turns into hope, and a terrible loss becomes a gift. So let's be a hero. Let's donate our organs. Life is a gift, and let's pass it on. Yes. Thank you so much, Ms. Jenny.
Thank you so much. Thank you.
Over to you, Ms. Sapna.
Thank you, Ms. Beena Malhotra and Ms. Jenny C. John for an informative session. Thank you, Ms. Namita, for moderating the session. Dear participants, the next 1 hour, we have a common session in Hall A. Dr. S.P. Agrawal oration from 12:30 p.m. to 1:30 p.m. Then 1:30 p.m. to 2 p.m. we have lunch. I request the audience to go back and click Hall A to join the oration. Faculty can leave this link and join the link for Hall A. After lunch, audience are requested join back in Hall C at 2 p.m. for the next split session on neuroscience nursing. Faculty are requested to join the Hall C through respective Zoom link. Let's go to Hall A.
about the gene, since Professor Dhavendra has already talked about how the gene sequencing is done and why understanding of the gene sequencing is important for any sort of interpretation of the genetic test results. The gene is actually made up of the coding areas, which are known as the exons, and the non-coding areas, which are the introns. And most of the single gene abnormalities or the single gene diseases occur due to mutations or changes in the coding sequence of the gene. The most common example of a single gene abnormality is a person with thalassemia, which occurs because of variation or a mutation in the beta globin gene. And traditionally, now the sequence of the genes used to be studied by something known as labeling these dideoxynucleotides, which actually make up the gene, and then studying the color sequence of these dideoxynucleotides. Slowly, it led to the capillary sequencer, and now we have automated sequencing, which sequences each and every nucleotide at every position in the gene. It is a very high throughput technology. It is done in a massively parallel form and on a very miniaturized platform, resulting in lots of data, in a large amount of data, which is reading the genes base by base. Now we have such massive data in the next generation sequencing, which is sequencing either a group of genes or all the genes together in the exome sequencing. And to make sense of the data by bioinformatics is the Herculean task that the bioinformaticians, along with the clinicians, have to undertake to sort of pinpoint the variation or the mutation, which is responsible for disease in our patient. And once we have filtered out these variations, there are specific guidelines according to the in silico analysis of these variations, by which we can further classify these variations for pathogenicity, so that we can pinpoint exactly which variation is disrupting the gene leading to the disease. So this is what goes behind when we characterize a particular mutation by exome sequencing or by a panel testing. However, in my next case, I would like to sort of highlight the other aspect also of the NGS. Now, this was a 27-year-old female non-consanguineous marriage, born out of a non-consanguineous marriage, presenting with proximal weakness and exhaustion for the past 2 to 3 years, and aching pain in the muscles. Lower limbs were more involved. There was some sort of an asymmetry present. There was no facial weakness, positive deep tendon reflexes. She was a simplex case in the family. There was a significantly raised CPK, and EMG was myopathic. Now, there was a big confusion regarding whether, this is a myositis or a muscular dystrophy. She had already been given a trial of steroids. Distinction between myositis and muscular dystrophy is very important to avoid inappropriate immunosuppressant treatment in a patient with.
I just request you to wind up in 2 minutes.
Yes, ma'am. Yes, ma'am. Or therapeutic abstention in a patient with treatable acquired myopathy. Now, thinking that, it is otherwise. Now, some pointers towards myositis could be that, this would be an acute, subacute onset, rapid evolution, typically middle age presentation. So there could be some pointers towards a myositis. However, there could be, important mimickers in the dystrophy, muscular dystrophy group also, which could mimic the myositis. And hence it becomes very important, it becomes extremely important to distinguish between the two. And this particular female was seen to be harboring on a next generation sequencing. She was found to have a homozygous variant, which means that on both the alleles, this particular missense variant was detected, which was consistent with the diagnosis of limb girdle muscular dystrophy type 2A. And here I would just like to make this point, as Professor Dhavendra had also mentioned, that there are now certain mutations which are, as the mutation databases are increasing, as we are collaborating and we are publishing more and more data. This was found that, this particular group of community, the Agarwals, this is a common mutation. This is a founder mutation, and approximately by when the Agarwal community was studied by this particular group in Maharashtra, they found 89% of the Agarwals with the LGMD phenotype to have these two mutations in various combinations. So in the interest of time, I think I will be leaving the rest of my cases. I somehow thought that the time given to me was about 30 minutes, but nevertheless, so the point to make here was that there have been advances in the diagnosis of inherited neuromuscular diseases by the genetic testing. And this paper by Dr. Madhuri Hegde from the Emory group in collaboration, this is not the one actually. So this paper actually highlights the importance of the yield of genetic testing for the various muscular dystrophies, neuropathies, myasthenic syndromes, mitochondrial myopathies, and other rare neuromuscular diseases. And more genetic yield is expected in the near future as genome sequencing comes into action. However, there are some limitations of next generation sequencing, particularly the exome sequencing, which need to be kept in mind. Like there are some difficult areas of the gene which cannot be sequenced. There are some repeat expansion disorders which cannot be detected reliably. There are some deletion duplications in the genes which can be detected but the sensitivity of this technology is less. Hence, clinical evaluation remains the mainstay and before any genetic testing. And I will be skipping most of my slides, just to emphasize on just my last case here, which also emphasizes the treatable genetic disorders. Now these are again very old case, two brothers, 14 and 16 years of age, with acute excruciating unbearable episodes of pain in the hands and feet. They had been shrugged off to various departments, neurology, rheumatology. They had been visiting for a diagnosis, but there was no diagnosis, and they were seen to have these skin lesions in particular distribution, which are very, very characteristic of this particular genetic lysosomal storage disorder, Fabry disease, which is in which there is an enzyme deficiency due to which the metabolite gets deposited. The diagnosis was confirmed here by the enzyme analysis and gene testing, and after starting the definitive treatment of enzyme replacement, the pain episodes were nearly nil. So this sort of emphasizes the need for genetic diagnosis and targeted treatments as well. So here again, I've just highlighted the list of disorders that amongst the neuromuscular group, which are highly genetic, almost all of the hereditary spastic paraplegias, the spinal muscular atrophies, a lot of amyotrophic lateral sclerosis now in the familial cases particularly are getting diagnosed to be having genetic etiology. And metabolic myopathies definitely, which are the potentially treatable forms. Thank you very much.
So thank you, Divya, for giving us a glimpse of variety of cases and highlighting the important point which one needs to remember while using such techniques. So maybe we can have one question because we're already running behind the schedule.
Just one comment, Dr. Divya, very well spoken about use of genetic studies, and Dr. Devender. I agree that the topic was quite big and covering in 12 minutes is quite difficult. So maybe in next kind of versions in next year also we can plan some full session on genetic studies in epilepsy specifically and other neurological disease.
So one message I would like to give, that just doing an ordinary biopsy, muscle biopsy, is no use unless either you do the antibody staining or the fluorescence or something, because only it will tell you that there is muscle atrophy. So it doesn't give you anything. What is the type? So just doing muscle biopsy, the age is gone. You have to either do the immunostaining or you have to do the antibody staining. Is it dystrophin? Is it calpain? Is it sarcoglycan? Whatever. So I think this is one message I would like, because I see a lot of neurologists do a biopsy in DMD, and all that they come back is muscle is atrophic. But that I knew even without putting the knife. Okay.
Okay. Thank you. Thank you all the chairpersons and all the speakers for this informative talk. And for the next session, which is a common session of Dr. SP Agarwal oration session, I, along with Dr. Sudhir Kumar Tyagi, who is a senior consultant neurosurgery in First Apollo Hospital, is likely to welcome Padma Shri Dr. V.S. Mehta as a chairperson for chairing this session. Over to Dr. V.S. Mehta, sir. Dr. V.S. Mehta, sir, please unmute your mic. I have introduced Dr. V.S. Mehta. Good afternoon, sir.
Good afternoon.
Over to you, sir.
Good afternoon, sir. So this oration is a very important oration. As you all know that Dr. SP Agarwal and I were together in MCH. So let me ask Dr. Anshul Rohatgi to introduce Dr. SP Agarwal's oration. Dr. Anshul.
Dr. Anshul, sir. Please unmute you, sir.
Doctor, you are not audible. Hello.
Yes, sir. You are audible, sir. Anshul, sir, you are audible.
No, I can't listen to him. Hello.
Anshul, sir, you are not audible.
Hello. Hello.
Maybe Dr. Anshul's mic is not working, or there is some connectivity problem.
Doctor, can you log out and log in again?
Am I audible now?
Yes, sir. Yes, sir.
Okay, I think there was some. Sorry for the. Just give me a second. I'll just relaunch the PowerPoint. Is my screen visible?
No, sir, your screen is not visible. You have to share.
Yeah, I'll do that. I'll share it. Is it visible now?
Yes, sir.
Okay.
Sir, do it in the slide.
Yeah, I'm doing it. I'm doing that only. So good afternoon, everybody. Sorry for the technical glitch. So we are all welcome to you to Professor S.P. Agarwal oration. Dr. Agarwal was born in Nakodar, Punjab on 21st October 1945. His family moved to Delhi in the early 50s. He completed his schooling from DAV School, Chitragupt Road, New Delhi. He did his MBBS in 1968 and thereafter MS General Surgery in 1972 from Maulana Azad Medical College and subsequently in MCH Neurosurgery in 1980 from AIIMS. He got a WHO fellowship in neurosurgery in 1984 from Mass General Hospital, Boston. His Inventions Award was given by National Research Development Corporation or CSSR-IR for developing multipurpose self-retaining new brain retractors in 1992 and modified trephines in 1987. He received a gold medal for inventing modified trephines at the International Exhibition for Inventions held in West Germany, where about 250 inventions from more than 40 countries were exhibited in the INA 1987. He helped the revised National TB Control Program, the DOTS program in 1997, the National Health Policy in 2002, the National Rural Health Mission in 2005. He had delivered more than 20 named orations and had authored about 5 books. He had 32 research publications and 28 chapters in textbooks. He had fellowship of 7 national academies. And his major appointments included, he headed the Department of Neurosurgery at the RML Hospital from 1981 to 1996. He was a medical superintendent of the same hospital from 1992 to 1996, Director General Health Services from 1996 to 2005, and Secretary General of the Indian Red Cross Society from 2005 to 2015. And of course, he was instrumental in institution building. He set up the Department of Neurosurgery at RML Hospital and the Subsing Hospital in New Delhi, chaired the Postgraduate Institute of Medical Education and Research at RML Hospital. He started the PGDM course in disaster management at Indian Red Cross Society. His major awards and recognitions include a Padma Bhushan by the Government of India in 2007, the BC Roy National Award for Eminent Medical Person in 2002, a degree of science by the Punjab University in 2007, the Henry Dunant Medical Medal for the highest honor conferred by the International Red Cross and Red Crescent Movement in 2006. So that was all about Dr. Agarwal, and we are all honored to be present in his oration today. Thank you.
Thank you, Anshul, for introducing Dr. S.P. Agarwal's oration. Now, I may add here something more what he has added, that he was right from the beginning was interested in neurosurgery. So when he was working as a general surgeon in the RML hospital, he used to come regularly for attending the seminars in the All India Institute. And later he became a MCH candidate and we both were together. And once he has passed the MCH and became the director health services, he was always eager to uplift the neuroscience in the country. And I must add here that at the AIIMS, when I was heading the department or chief of the center, I had a lot of help from him to obtain the lot of major equipments like gamma knife, intraoperative MRI, and a lot of faculty posts, and all because of his help when he was the governing body member at the All India Institute. So may I now request Dr. Sumit to introduce the orator, Dr. VP Singh.
Well, good morning. Thank you, sir. With your permission, can I share my screen?
Yes, please.
Can you hear me and see the slides?
Yes.
Okay. Good morning, everyone. I am Dr. Sumit Sinha, and I have the pleasure of introducing today's orator, Dr. Varinder Pal Singh, who will be delivering Dr. S.P. Agarwal oration, the prestigious Dr. S.P. Agarwal oration for the 24th annual conference of Delhi Neurological Association meeting to be held yesterday, which was held yesterday and to be held today itself. So Dr. Varinder Paul Singh, who is popularly known as Dr. VP Singh and affectionately known as VP by his seniors and colleagues, it is an extreme pleasure and immense opportunity to introduce you to the audience. And Dr. VP Singh did his MBBS from All India Institute of Medical Sciences in New Delhi in 1982. And after this, he joined the direct 5 years MCH course in neurosurgery from All India Institute of Medical Sciences, New Delhi in 1987. And after that, he joined as faculty in King George Medical College and Hospital, Lucknow. And from there, he further had training in cerebrovascular surgery and gamma knife radiosurgery in UK, Newcastle General Hospital, Newcastle upon Tyne, and Royal Hampshire Hospital, Sheffield. After this academic career, he had series of illustrious appointments, with the first being appointed in 1993 as faculty of Department of Neurosurgery at the Cardio Neuro Center, All India Institute of Medical Sciences, New Delhi, where he worked till he was promoted as additional professor of neurosurgery and unit head in neurosurgery at the Department of Neurosurgery, All India Institute of Medical Sciences. After this stint here at AIIMS, he went out for more greener pastures, and in 2002, he was there, joined as senior consultant at Women's Hospital, then Women's Hospital in New Delhi, and started a new department there and set up the Department of Neurosurgery along with Professor A.K. Banerjee there. And there he worked till 2007 when he joined Indraprasth Apollo Hospital as a senior consultant neurosurgeon and academic coordinator there, and worked there till 2018 when he joined the Medanta Institute of Neurosciences in Gurgaon in January 2018. Currently, he is the chairman of neurosurgery at Medanta Institute of Neurosciences in Gurgaon. He has a special interest in brain tumor surgery, aneurysm surgery, and pediatric neurosurgery, and he is considered to be a pioneer in the field of epilepsy surgery and gamma knife radiosurgery. Not to forget, he started these fields at the All India Institute of Medical Sciences and in the country. He is the CME convener of Neurological Society of India from 2012 to 2014. He has been the editor of Journal of Pediatric Neurosurgery from 2009 to 2015. He has been the president of Indian Society of Stereotactic and Functional Neurosurgery and Cerebrovascular Society of India, secretary of Neurological Society of India, and president-elect of Indian Society for Pediatric Neurosurgery. And currently he is the president of Neurological Society of India. And here he is in his younger days. Well, he is still young, and looking forward to, in this photograph, to achieve more and more illustrious dimensions, which he has done and he is still doing now. And he's a family man. He's been blessed with a wonderful family. His son is settled in United States of America and a beautiful daughter. And ladies and gentlemen, I present before you Dr. VP Singh, who will be delivering the prestigious Dr. SP Agarwal oration today, and his topic is epilepsy surgery. Dr. VP Singh, please.
I'm just going to share my screen. Dr. Mehta, my friends, colleagues, the members of the DNAEC, thank you for this honor of giving me the SP Agarwal oration. Dr. Agarwal was very well known to us. He was a senior, a mentor, and he was very helpful whenever anybody needed him. And it's a pleasure and an honor to be offered to do this oration of his, goes in his name. Thank you, Sumit, for your kind words. I didn't start the department at Vimhans. Vimhans was well established by Dr. Banerjee. I only joined him and worked with him at Vimhans and Apollo. Right. So the topic of my oration is epilepsy surgery, a challenging journey. How we did it, what problems we faced, and how we went ahead. I came across this beautiful quotation about the challenges of life. Smooth roads never make good drivers. Smooth seas never make good sailors. Clear skies never make good pilots. Problem and hassle-free life never makes a strong person. We have to be strong enough to accept the challenges of life. And when something wrong happens, don't ask life, why me, which is what most of us do. Instead say, try me. So coming to epilepsy surgery, this is surgery done 3 minutes. The imaging can be done after 6 hours, so that was not a problem. But the injection had to be done in time. Neuropsychological assessment was another hurdle. Trained neuropsychologists are rare, and there wasn't a neuropsych battery which was validated in India. So here, our neuropsychologist, Mr. Surya Gupta, developed a battery of neuropsychological tests which he validated in Indian patients and which we used in all our cases. And as time passed, it became more and more reliable. So what they did was in memory and IQ assessment, they did a lobar localization. And often, even if they could not localize to the frontal or the temporal, they would tell us whether it's the right or the left. And as the time passed, he became more and more accurate. And as long as it was not discordant, it would increase our confidence levels. Now came another dilemma, the VADA test. Sodium amytal is not there in the Indian pharmacopoeia. So its usage is not legal. And some centers were using it. Trivandrum were using it because they had got some personally from abroad and were using it. But we were worried. What if a reaction occurs? How do we defend ourselves? And mind you, it's a very frightening experience for a patient. When you inject the sodium amytal on the left side in the carotid, and the patient becomes aphasic and he's fully conscious, it's a frightening experience for the patient. It's a horrifying experience. So we decided to go ahead without it. We assumed that if the hippocampus is so atrophic and sclerosed to cause intractable epilepsy, its function is likely already severely impaired and transferred. So we cannot make them worse. And with this assumption, we went ahead and did our surgeries, even on the dominant side, without a VADA test. And now, worldwide, it is being used sparingly, and today practically nobody uses it. It's used only in very exceptional circumstances. The next dilemma was if the MRI was negative and we could not find any abnormality of any sort on a MRI, epilepsy-specific MRI. So here, the localization became even more important. So in these cases, the Icton video EEG localization was done, and we wanted to record more seizures so that we wanted to be sure that all the seizures were coming from the same side. So it's possible that a person has multifocal epilepsy and 1 or 2 seizures may occur from one side, but the next may occur from the other side. So in these cases, we had to have at least 4 to 5 seizure recordings to be sure. And in these cases, the Icton SPECT was a must. So we have to have at least 2 confirmatory tests of good quality before we could subject them to surgery. And in these cases, the electrocorticography was also essential. The next is if the video EEG, the patient did not have a seizure on the video EEG recording. So video EEG negative cases. So here, although we may see an abnormality on the MRI, we are not sure that the epileptic, that it is epileptogenic. So here we have to fall back on the prolonged interictal recording which is available. We should show frequent spiking from the lesion site as seen on the MRI, with no significant spiking from other sites. In fact, there are certain studies now which suggest that in a classical mesial temporal sclerosis, the Icton record is not essential, and they can operate based on the interictal study, provided you have a prolonged interictal record. But if there is a bilateral MTS, or if there is a dual pathology, then one cannot compromise, and you have to have repeated video EEGs till you can establish the epileptogenicity and decide which of the 2 lesions is causing the epilepsy. So once this workup was done, we had regular epilepsy surgery meetings, and we would discuss the patient's threadbare. All the specialists would give their inputs. And before the MRI data was presented, the neuropsychologist and the nuclear medicine specialist were actually blinded to the MRI data, so that they gained the confidence, and we also gained the confidence that the data was not biased in anything. And then only the MRI was shown. So the decisions were taken jointly in these meetings. And concordance of the test is extremely important for a good outcome. And the best result would be if there was an MRI evident lesion, which was shown to be epileptogenic on the Icton video EEG. The neuropsychological assessment should at least not be discordant. And if the inter-Icton spec corresponded, it added to the confidence levels. Now coming to the surgical issues. Temporal resections is the standardized resections. There are anatomical resections. There are a variety of resection techniques. No special instruments are required. All that you need is good microsurgical techniques and clean sections to avoid scar epilepsy. So this was doable. But the temporal lobe, especially the median temporal lobe, has important structures all along. If you look at the uncus and the hippocampus, you're working right next to the brainstem. There are the perforators of the brainstem are there, the third nerve is there, the vessels are there, and one has to be extremely careful. As neurosurgeons, we operate on the temporal lobe, but mainly on the lateral temporal lobe. So the anatomy of the median temporal structures is much more complex and not usually handled by neurosurgeons. And it's only after doing 4 to 5 actual surgeries and reading the anatomy text repeatedly does one understand the anatomy of this region. And what is most important is that when you're doing your resections here of the median temporal structures, you have to remain subpia, because the moment you transgress the pia towards the brainstem, there is potential of vascular and neural damage. So if possible, do cadaveric dissections in the lab, but it takes a little time to understand the anatomy of the median temporal structures. So one could either do an anatomical resection, which is what we did. That was the lateral temporal lobe, and this is the median temporal lobe with the hippocampus here. So we preferred this so that we would get good specimens for pathology. One can also use the ultrasonic aspirator, which is more safe for the medial structures, but you don't get a sample for the pathology, so you don't get a confirmation of what you're dealing with. And also you have to use in very low settings so as to remain subpia and not damage the pia. So the next surgical issues were in the lesionectomies. And there are a variety of lesions which we came across, which could be causing intractable epilepsy. There could be tumor or tumor-like. And amongst this, we came across this new entity, the dysembryoplastic neuroepithelial tumor. This was a recently identified entity by Christine Dormus-Lupo, and we found it in many of our cases. Vascular abnormalities, biotic things, and developmental changes. So most centers work on temporal epilepsy surgery, and then only later on in their transition, they transit to extratemporal. The Sri Chitra people, I think after 3 years of doing epilepsy, 3 to 4 years only, first they did temporal and then they started doing extratemporal. But we transited from temporal to extratemporal fairly soon as we started getting extratemporal lesions. But compared to temporal lobectomies, which are sort of tailored resections, here extratemporal resections have to be done using electrocorticography. So how do we decide the margins? We need to do an electrocorticography, and we need a neurophysiologist to read the electrocorticography. So we do a direct recording from the cortex of the exposed brain and do the EEG recording there. That's electrocorticography. For that, we need grids, which are expensive and for one-time use. And there, the next dilemma came. When we got a machine, we had got about 10 to 12 grids with it. And they were supposed to be one-time use, and they were supposed to be thrown away, which is what I'd seen outside in the UCLA. So how do we, carry a program forward with these expensive items? So we decided, we asked the company people, how do you sterilize them? And they said, we use ethylene oxide. And we said, why can't we re-sterilize with ethylene oxide? And said, that's not permitted. So we decided to override them, re-sterilize them twice, and reuse them, because that was the only way we could go ahead with the extratemporal cases. I mean, if everybody, each case we had to have $200 to $400 of electrodes, US dollars, it would have been extremely expensive. So we took a risk, we re-sterilized them and used it, and touch wood, we did not have any problem. We started doing ECOG in all cases to gain experience. And there again, we had a problem. The first 4 cases, we put the electrocorticography grid and we couldn't get any recordings. We tried everything, the anesthesia drugs, the recordings, but nothing seemed to work. We called the company people, they were equally clueless. It was the first time we were doing it in India. Till we realized that the recordings which were done directly from the cortex, because the bone was not there, the scalp was not there, the voltages which we were recording are very, very high. So when the machine was set to the routine settings, those recordings were going above, far above them. So we had to reduce the sensitivity to much lower levels so that the top of the wave could be seen. And only after 3 or 4 cases did we realize how to go about it. So these were the electrodes we had, the grids we had, which we used. And here you can see the spikes before the resection, and after a resection from the same area, the spikes have gone. So this was the first case that we did in April 95, a 4-year-old girl with intractable epilepsy. And this is what we found on the scan, X-ray, on the CT scan and the MRI scan, a lesion in the median temporal structure. And this surgery was in 2 parts. There was a dural part and an intrinsic part in the cortex. And this turned out to be meningoangiomatosis, a rare disorder which was described for epilepsy. And this was the only meningoangiomatosis we had in a series. This was another small lesion in the median temporal structure, which had been missed in initial scans. This again is in 95, one of the early cases. And this came out to be dysembryoplastic neuroepithelial tumor. It's a cortically located tumor, does not increase in size, is not malignant, and has this floating neurons. And when you take it out, it is almost watery, water sort of seeps out of it. So this, again, we found that whenever we find it, is often associated with intractable epilepsy. It's a benign condition, does not grow, does not need radiation therapy, and gives excellent results with surgery. So again, you can see a lesion here. The gray-white matter of the median temporal lobe is not there, and this was a solid ganglioglioma. Another lesion near the motor strip, we did the function MRI with finger tapping. The recording was posterior, so we approached it from anterior, took it out. It was an astrocytoma. A calcified lesion on this scan on the median temporal structures again, which turned out to be a calcified hemangioma. A cavernoma in the cortex. And this here, to control the epilepsy, the hemosiderin ring has to be taken out, otherwise it doesn't work. A patient who was a post-traumatic patient came with a scar epilepsy, repeated episodes of status epilepticus. We had to excise this scar and he became seizure-free. A congenital lesion, a cleft in the cortex, a developmental disorder, schizencephaly. And here, you have to, during surgery with electrocorticography, find out which part is causing the epilepsy, which part is epileptogenic, and that has to be excised. Another lesion here, an abnormal area, turned out to be cortical dysplasia. You can see that the lamellar distribution of the cortex is totally destroyed. There may be heterotopic neurons in the white matter, and the neurons may be bloated with a forme fruste of tuberous sclerosis. So when we are operating lesions, how is it different from epilepsy surgery? We know that, how is epilepsy surgery different from just taking the lesions out? Now we know that most of the lesions do not contain neurons. So they are not the ones which cause epilepsy. It is the changes which it incites in the surrounding cortex which is the cause of refractory epilepsy. So you have to take out the lesion and the epileptogenic area cortex around it. And sometimes you get a dual lesion. They have a cystic area here, and even the hippocampus is atrophic. You can see how big the temporal horn is. Another case with a anterior temporal lesion and a posterior temporal lesion. So here you have to find the epileptogenicity and find out which of them is causing the epilepsy. Eloquent area lesions, we could do functional MRI, cortical mapping, and a wake craniotomy. Now, we were often criticized by the purist neurologists that we are not doing true epilepsy surgery, we are operating lesions. Now, before the MRI, MTS and cortical dysplasia were called true epilepsy surgery, non-lesion. And only the pathology showed the lesions. But after good MRIs, even they have become lesion, that something is picked up on the MRI. And now, non-lesional epilepsy occurs in less than 5% of surgery patients. So it is likely that all epilepsy surgery is lesional. It is only the sensitivity of a diagnostic test that we are not able to see the lesion. Corpus callosotomy was technically not difficult. You were doing transcanosal approaches regularly. Hemispherectomy was much more difficult to conceptualize. Videos were not available. So I again went to UCLA on a subsequent visit, saw Gary Mathern do one hemispherotomy and came back and started doing. So this is the infantile hemiplegia seizure syndrome with one hemisphere atrophic. We also tried a hand with gamma knife for radiosurgery. I had been to Marseille and we treated 5 cases of MTS with gamma knife. After 9 to 10 months, the auras would increase dramatically and then the seizures would stop. But they would get very severe radiological reactions with mass effect, which would need months of steroids to control. So 3 of our patients had severe reaction, 1 had a moderate reaction and 1 had no reaction. Those with severe reaction became seizure-free. 1 patient with moderate reaction had a partial reduction. 1 patient with no reaction had no reduction. So somehow that response was related to the reaction. So it's possibly effective, but the reaction was frightening. They would get Trapezius edema, severe need prolonged steroids, and we stopped doing it. We tried it for hypothalamic hematoma in 1 patient, got a good response for 3 years, but then again it came back. Post-operative seizures are demoralizing for the family and the patient. But what we realized is there is a running down phenomenon, that the seizures become less and then gradually disappear. So we informed the family pre-operatively. We would continue the same anti-epileptics post-op and start reducing after 3 to 6 months if they were seizure-free. Pseudo-seizures is another problem we had. Once the patient becomes seizure-free, the family expects the patient to be independent and normal. But these patients have been suffering for so long that they are not psychologically capable of dealing with the situation. So they started having pseudo-seizures, some of them. Follow-up was one area where there was no problem. We had very good follow-up. These patients have been suffering for such a long time that when they come for surgery, if they benefit, they are grateful for the surgeon for life. And you are not just controlling the seizures, you are curing them. So very briefly, in the 7-year period I was there, 135 patients operated, 128 focused resections, 66 children. A large number of our patients were under children. I mean, almost 2/3 of them, or more than half, were under the age of 20. Patients, 1/3 of patients had seizures for 5 years, 1/3 had seizures 5 to 10 years, and 1/3 have seizures for more than 10 years. Because nothing else was possible. So they came to us late. This is changing recently. Most of them were partial complex seizures. The seizure frequency, 1/3 of our patients were having seizures every day. The epilepsy was so severe. So 128 focused resections, 98 temporal resections, and 29 extratemporal, only one hemispherotomy. These were the type of abnormalities that we saw. And our complications were there, especially in the beginning, but thankfully most of them were short-lived. In the subsequent, with experience, they had become much less. We had 3 patients who died. One was operated for a temporal sclerosis. He was fine, discharged after 1 week. 3 weeks later, he had a seizure, had aspirated and came with an arrest. 1 patient died of infective complications, and 1 patient was seizure-free for 38 months, and then he had a tumor. So after cadazotomy, seizures are not controlled, only the generalization goes down. With surgery, we had 111 patients with a long follow-up of more than 18 months. And 80% of our patients were totally seizure-free. 11.7% had reduction in the seizures, but did not become seizure-free. And 9 patients, or 8% of our patients, did not have it. So the recommendation was that we have to be very selective in choosing our patients. As at that time, a lot of so-called well-wishers were watching us with hawk's eyes, waiting for us to fail and say, okay, we told you so, you can't do it. But we had to deliver good outcomes. Otherwise, we would have been denigrated. And with a bit of luck and determination of the whole team to succeed, we managed. Then we started spreading the message. The first 10 cases we presented at the Indian Epilepsy Society annual conference in Calcutta, where we were awarded the Best Paper Award. We went to various conferences and kept presenting epilepsy surgery to the exclusion of everything else. So much so that people don't recognize me for my microsurgery, they only know me for epilepsy surgery and gamma knife release. Now, several centers all over the country have started doing epilepsy surgery, and they're doing well. In the meantime, at AIMS, things have moved.
बस ये जल्दी से खत्म हो जाए
Dear faculty members, we'll be resuming the day 2 afternoon session in 3 minutes. Dear faculty members, day 2 afternoon session will be starting in 2 minutes.
Welcome back, everyone. For afternoon session, now we are moving split session 5. This session is on hospital-associated pressure injury. The moderator of this session is Ms. Rinjin Wangmo, RNRM, staff nurse and custodian of hospital-acquired pressure injury team. She has total 14 years of experience, out of which 9 years she is working as a pressure injury custodian. Over to you, Ms. Rinjin.
Thank you, Sapna. Good afternoon, everyone. Thank you for being this afternoon. My name is Rinjin Wangmo. I am a happy team in Interpasta Apollo Hospital. Now, sections we are going to discuss about the prevention of pressure injury. Prevention of pressure injury is very important, as all we know about the prevention is better than cure. Now, I would like to introduce Mr. Rajaji Nipolin, clinical specialist from Molecular Healthcare. His achievements are maintain the compliance of HIC, PCI of NABH and JCI accreditations. Attended the second JCI interview as an ICN, participate as a speaker on Apollo Critical Care Conference at Hyderabad. Presented Six Sigma project on needistic injury of infections Nursing Society Conference at Hyderabad. Now I would like to call Mr. Rajaji to prevent his to topic on prevention of pressure injury and nurses perception and action. Now I'm going to hand over to Mr. Raja Napoleon.
All right. Thanks a lot, Ranjan, for your generous introduction. Let me take a moment to project my slides. Well, it's my pleasure and indeed a privilege to be part of this conference. And please accept my heartiest congratulations for the entire organizing committee and all the participants. And my topic today is HAPI, hospital-acquired pressure injuries. What is a nurse's perception? And what are the actions to prevent a pressure injury? So today I'll be addressing about the basic pressure injury burden. What is the burden of pressure injury, and how do we define a pressure injury, and what are the risk factors and stages, a review of stages, as most of us know what are the stages, and what is nurses' perception about pressure ulcer prevention, and what are certain things that we can do to prevent the pressure ulcer incidents, followed by a question and answer. Well, can you guess this gentleman here on the screen? Well, I can hear some of you guessing yes. He's none other than the Christopher Reeve, which is who is popular for playing the character as Superman. But can you also believe that he lost his life due to pressure injuries in 2004? So how did this happen? If you notice the same person here, he was riding a horse and he fell down from a horse and he had a spinal cord injury and he was paralyzed. So obviously a bed-bound patient, he developed a pressure injury, but that was not the problem. The pressure injury became infected and then that led to sepsis, and that's how he lost his life. So the point here I'm trying to highlight is pressure injuries are not exception for celebrities or wealthy persons or superhumans. Pressure ulcers occur every day for most of the patients. So let's talk about the terminology. So pressure ulcers are addressed with many terminologies. So is there anything appropriate or a approved terminology? So can you guess what are the different terms for pressure ulcers other than pressure injury and pressure ulcers? Well, are you thinking about a decubitus ulcer? Yes. How about the ischemic ulcer? You might have heard about ischemic ulcer as well, right? How about bed sore, which is obsolete? Please do not use the term bed sore, although it is still being practiced because bed sore is obsolete. Patients still develop ulcers whilst they're sitting in a chair or whilst they're being operated in the theaters. How about pressure sore and pressure ulcer? So the appropriate terminology, or according to the international guidelines, the approved terminology is pressure injury. And it is there for a reason, because pressure injury, we'll be talking about the stages in the coming slides. So if we consider a grade 1 pressure injury, the skin is intact, the skin is not peeled off. So we cannot call something as an ulcer where the skin is intact. So the appropriate terminology for all these stages is pressure injury. Let us discuss about the burden. So how strong, or what is the number of pressure ulcers incidence or prevalence? If you see the general data, it is about 2.5 million patients develop pressure ulcers in just United States of America alone. And if you see, there's a big study, which is a review of all the published studies. They have studied about 6 lakh participants, and they have come up with this data. if you notice, the patients with spinal cord injury, every one patient out of 3 have developed a pressure injury, which is a very high number. And also it is also, the results were also telling that 30 to 40% of the spinal cord injury patients develop pressure injury in the acute phase and also in the rehabilitation phases of their life. If you notice country-wise, the Europe has about 56%, which is the highest, whereas the lowest is in the United States of America, which is 11%. Well, how about India? So what is the data in India? All right. So we have few studies published in India. If you see the data from Chauhan et al., the prevalence is about 4.94% in 445 hospitalized patients in medical and surgical wards. Whereas if you see the data from Mehta et al., he published the prevalence is about 7.8% in all the hospitalized patients. And the prevalence is more in the ICU, which is about 24.3%. And the sacrum and heels were most commonly affected. So this is the same with the global data as well. The most commonly affected area is, the first area is sacrum for a patient in supine position, and followed by a heel, which is the second most prominent area. Most common ulcers were grade 3, which is about 42.8%. And if you see the impact of pressure ulcers, it is impacting, I have categorized into 3 different ways. The first one is the patient perspective. So there is increased pain because the patient may already have pain because of the medical or surgical condition. So this pain is increasing, and it is also deteriorating the overall condition of the patient. And also the mortality. If you notice, around 60,000 patients are dying just due to pressure ulcers in just United States of America alone. So if you see the data in a developing country like India, the number could be much more higher because our population is much more larger than the US population, and our healthcare resources are not as developed as a developed country. And also low state of well-being. The patients also will be psychologically affected, so they'll be having low mood. Coming to the hospital and healthcare workers, it is a quality indicator, as all of us are aware, especially NABH or JC accredited hospital. It's a quality indicator which is relevance, or which can be considered as a quality of care provided by the nurses. And if you see, it is also a lawsuit, which means the patient or patient family member can register a complaint in the police station directly on a nurse if a patient develops a pressure ulcer. It's there in the developed countries, so it may also come in the coming days into India as well. And needless to say, it is a marker of reputation, which means the patient himself will be an advocate to convey the feedback about the particular service provided in the hospital. It's just one Google feedback away. So it definitely contributes to the reputation of the hospital. And also the readmission. Readmission, there are many causes, or many, the factors could be many for readmission, but pressure also is one of the factor for a patient to have a readmission. Coming to socio-economic related factors, the patient will have social isolation, which means the patient may not be comfortable going outside because the patient might have odor from the wound, or patient might be having not comfortable meeting other people. And also increased cost, because the patient already might be spending certain amount of cost because of his actual illness. But whereas due to this pressure also, the cost increases, be it the dressing charges or the travel from the hospital to the home, or the nursing charges and the consultation charges and other products which are being used for the wound itself. All right, so how do you define a pressure ulcer? Do we have a standard guideline? Yes, as you see here, the pressure ulcer is defined by an international guideline, the National Pressure Injury Advisory Panel. Earlier, the guideline was National Pressure Ulcer Advisory Panel. However, it was changed to National Pressure Injury Advisory Panel. And that is the reason that we are telling the appropriate terminology to address a pressure is as pressure injury. So it's defined as a localized injury over or bony prominence, which is due to pressure or shear or combination of both of them. However, there's also medical device related pressure injury. When a medical device is applied, the ulcer caused due to medical device is called as medical device related pressure injury. Coming to risk factors, so there are many risk factors. However, they are broadly categorized into external risk factors and internal risk factors. So the point I'm trying to highlight here is that we have less control to no control over the intrinsic risk factors, which means which are happening inside the patient's body. However, if you consider the extrinsic factors, there is more control that we can minimize the damage due to this extrinsic risk factors. So these are the external risk factors. One is the pressure, which is the direct force because of the patient's own body weight and the underlying surface. The capillaries are being disturbed. And the friction is a lateral force, which means the patient's skin is dragged from one surface or the other surface. So that leads to a skin damage. The third one is microclimate. So microclimate involves two things. One is the temperature and moisture. So when there is increase in the body's temperature, that affects the circulation to the skin. And also when there is increased moisture due to perspiration, that actually affects the integrity of the skin. And shear is something which happens when an object is pulled in two opposite directions. So when a patient's head end is elevated, the patient's skin is pulled towards upper side, whereas the patient's bones are pulled towards the downside. So there's a damage at the muscle layer. Pathway. So how does a pressure ulcer develop? So most of us might be familiar about the concept that when there is a continuous pressure that blocks the capillaries or that exerts pressure on the capillaries, and that is leading to ischemia, right? However, if you notice, it's happening on the later stages. The damage is happening at the early stage in the form of direct deformation, which means when there is continuous pressure on the cells die. And when there is a cell death happening, our body initiates an inflammatory reaction. So the first one is direct deformation because of the continuous pressure or mechanical load itself. And that is leading to inflammation because of this dead cells which are already died in the body, in the skin. Inflammation, and then the inflammation is causing the collection of fluid and then edema, and that is leading to ischemia. So this is how it is happening. So deformation and then inflammation followed by ischemic damage, which is a total effect which is happening. So the point here is it is taking very less time for a pressure ulcer to develop. So pressure ulcer stages review. So we have a grade 1, 2, 3, 4. It is based upon the depth of the injury. The first, when the skin is still intact, and the grade 2, if you notice the skin epidermis is lost and we can see the dermis exposed, and the blister is always grade 2. Although the skin is not peeled off, blister is always grade 2 or stage 2. And when the dermis is also peeled off and the subcutaneous tissue is exposed, then it is a grade 3 pressure injury. Whereas coming to a grade 4 pressure injury, full thickness of skin loss, which means the subcutaneous tissue is also peeled off and the muscle is visible. And if the bone is visible, still it is grade 4 pressure injury. So are there only 4 stages? No. We also have 2 additional stages, which is called as unstageable or ungradable pressure injury. So if you notice this unstageable pressure injury, we cannot identify which layer is exposed. So it is covered with a slough tissue or a dead tissue, which makes it difficult to identify till which layer is the damage present. So it is called as unstageable or ungradable pressure injury. Coming to the last stage, to deep tissue injury, which means the skin, the damage is happening in the deeper layers as it's there in the name itself, and it can appear in the maroon color or purple color. So nurses' perception, there was studies conducted on nurses' perception about pressure ulcers. So this study is about the nurses' perception on pressure ulcer prevention bundle. So the results were the nurses found that it is feasible and acceptable, and it helped to improve communication to prevent pressure ulcers. However, they also felt that they need to have a strong leadership, and they need someone else to influence the behavior. Coming to another study, which was different. So it was conducted in Ethiopia in the public hospitals. So they had negative prospect because of the reasons as I clearly mentioned here, because there's heavy workload on them and the staff were inadequate, and the shortage of resources like Nimbus mattress, or the equipment required is less, and then inadequate training. So all of these factors made them feel that it is they're not happy, or they're not able to prevent pressure ulcer. So how can we prevent pressure ulcer? As most of you are familiar, there's something called as S-skin bundle or skin bundle. So surface stands for reducing the intensity of the pressure by placing the resurfacing matrices or pressure redistribution matrices, and also reducing the pressure by repositioning the patient. Skin inspection, check for skin color, skin integrity, turgor, and document. Coming to mobilize, we need to mobilize the patient as early as possible, and also as frequently as possible. If the patient is able to be mobilized out of the bed, encourage the patient to mobilize out of the bed. If not out of the bed, encourage the patient to do activities in the bed, or else provide a physiotherapy consult so they can provide some passive exercises. Incontinence and moisture. So if the patient has incontinence due to stool or urine, address that particular factor by keeping the skin dry and also applying a barrier cream to prevent a further skin damage. Nutrition and hydration. So with the help of dietitian and nutritionist and the primary consultant, provide the calorie requirement for a patient, which includes carbohydrates, proteins, vitamins, minerals, fats, and water. So all of this risk assessment by using a Braden or Norton or whatever is your hospital approved guideline. A skin assessment, we already discussed about skin assessment, support surfaces like air mattresses, and patient repositioning every second hourly, nutrition. And there's something else that we can do to prevent the pressure ulcer or the severity of pressure ulcer. If you notice, there's something called as interface dressing. So all of us might be familiar about the term dressing, whereas interface means that acts as an interface between the skin and the support surface. So what is it about? So it's called as Prophylactic Dressing Standards Initiative. So it is recommended by the National Pressure Injury Advisory Panel and also the European Pressure Ulcer Advisory Panel. So what does it mean? So they're clearly suggesting that you can, it's not you can, but if you apply a polyurethane dressing with silicone over a bony prominences, you can prevent a pressure ulcer. So does that mean that you exclude any of the practices or the bundle that we discussed? No, not at all. It is always important to consider all the existing factors. This is an additional step that you're doing to prevent a pressure ulcer for those patients who are at high risk or moderate risk on a Braden scale. So how does this help? What are they telling? How does this help to prevent a pressure ulcer? So if you notice, there's something called as finite element model. So finite element model is very popular and successful in aeronautical and aerospacing. So here they construct the similar structure to pelvis and sacrum and all the muscles, bones, and fat, and they check by applying a Mepilex dressing. As you can see in the second picture, the picture in the middle, there's a dressing applied that's called as Mepilex border sacrum, and they check whether applying this dressing is really helpful to reduce the pressure, or is it helping the mechanical load, to relieve the mechanical load or not. So if you see the result, this is again a computer model to see the results, whether the dressing is effective or not. So the first picture, if you notice the one without dressing, it is red in color, which means the pressure is more, which can actually cause damage and lead to a pressure ulcer. Whereas the second one, if you notice the Mepilex dressing is applied for the same model, and then if you can notice the red color is dissipating, which means there is minimal pressure so that there's no damage. I'll be playing a short video so that you can see how the dressing is helpful to prevent a pressure ulcer. This has no audio, however, I'll be talking in between. So this is a multi-layer dressing, as the guidelines are recommending that it has multiple layers for a purpose. So here's the patient on the mattress and the patient is sliding down. There's a friction and also shear happening. So that's normal skin of a patient when there's pressure exerted without a dressing. Whereas when you apply a dressing which has multiple layers in it, if you notice the pressure, it is being absorbed by this multiple layers of the dressing. And the second one is friction, which means it's a lateral force. The skin is being dragged towards one surface or one direction. So this is without a dressing. Whereas if you apply a dressing, the outermost layer is slippery in nature, so it allows the patient to slide without any damage to the skin and the underlying tissues. So this shear will help, this dressing will help to absorb because of multiple layers. So these layers slide against each other, so it absorbs the shear force. And it also takes care of the microclimate. If you notice, the dressing is vapor permeable, which means the excessive perspiration or moisture is being evaporated into the atmosphere. So that's all about the video. And with the allotted time, I'll be going back to the presentation. So this is a dressing which has multiple layers, Meplex, border, sacrum. And so here I skip to the Q&A. So if there are any questions or doubts, please feel free to raise towards.
Hello, sir. Hello, sir. Am I audible?
Yes, audible.
Hello, thank you. Thank you, Mr. Raja Nipolin, for excellent presentations. Okay, I have some questions to the Mr. Raja Nipolin. Okay, could we prevent all the pressure injury by using the prophylactic?
All right, thanks for the question. So your question is, can we prevent all pressure ulcers by using a prophylactic dressing? If you see, we have a lot of data which is telling we cannot prevent 100% pressure ulcers, despite providing the best nursing care in the world and despite having the best medical technology. Still, pressure ulcers cannot be prevented 100% because of patient's own comorbid conditions or patient skin condition itself, overall condition of the patient itself, whereas we can prevent most of the pressure ulcers.
Okay, thank you. Next question is there. What is the difference between the prevalence and incidence of the pressure injury?
All right, so prevalence and incidence are the factors to check the occurrence or the rate of pressure ulcer. So when we talk about prevalence or point prevalence is something that you check how many number of pressure ulcers are there in a particular hospital or a particular unit. For example, if you consider a hospital by name A, so point prevalence is something that you check in 24 hours or that particular day whether it is community acquired or hospital acquired, you check the total number of pressure ulcers, patients with pressure ulcers, that is called as point prevalence. However, when we talk about incidence is something that you check how many pressure ulcers have developed after coming to the particular unit. So most of the time, the incidence is taken into consideration because that is the direct relevance to quality of care provided.
Okay, thank you. One more.
All right. So incontinence is something which is happening due to the skin being exposed to the over moisture. And the second thing is the skin is being exposed to the irritants which are present in the stool and urine. So this can be prevented by the first concept, to clean the stool as early as possible. And the second thing is to apply a barrier cream, which could be a zinc oxide, which means the moment you clean and kept the skin dry, so you apply a barrier cream such as zinc oxide. So when the patient passes next episode of stool, then this zinc oxide acts as a barrier between the skin and the stool. This is how we do. And also you correct the root cause, which is the diarrhea itself. Is it due to a food related or is it due to a medicine? So we provide some gut motility reducing drugs with the help of the physician.
Okay, thank you, Mr. Napoleon. It's a very useful question.
Ms. Tanjit, very good afternoon. I have one question here. Can I go ahead with my question? Yes, Mr. Raju, is it friction and shear is same, or if there is some difference, then what the difference between friction and shear?
All right, what is the difference between friction and shear? So friction is something which is happening laterally, which means, for example, if I keep an object like this, it is happening like this between two different surfaces. However, shear is something which is happening when we pull an object in two different directions. For example, if you consider a pen like this, shear is it is being pulled towards this direction with my right hand, and with my left hand I'm pulling towards the opposite direction. So the damage happens in between. It's not on the top or this superficial layer of the skin. So that is how a shear happens.
And little bit, adding a little bit more. If a comatose patient can develop shear, if a patient is a comatose,
yes, sir. Yes, sir. Due to pressure, shear, and friction. Yes, audience, any questions? Okay. At the last has.
Ma'am, you are on note.
Okay. Oh, okay. Time out. Hello. Yet at last, me, a member of the happy team, I would like to express my experience. Whenever you receive the patient on new admission, whatever, then you have to check the patient condition. If you receive the patient with pressure injury, you have to document. Documentation is very important. You have to document with the size, what is the color of the skin and which area is there. You have to do the measurement. Then you have to relieve the pressure from the bony prominence. That means you have to, secondarily, you have to change the position every hourly. Then to reduce the shear and friction, that is very important. Not only for pressure only. They develop the pressure, not only for pressure, due to shear, friction, and incontinence also, they develop the pressure injury. To avoid the rubbing and scrubbing the skin. Then to give the patients PFE regarding the skin condition, how to give the back care, how to do the dressing. On discharge time also, you have to give the PFE to the patient or patient relative. Okay, then use the prophylactic also. Prophylactic dressing is also very useful, especially you're using for prophylactic for bedridden patients, CRT and dialysis, those who are going more than 8 hours. Then ortho patient also, before going for shifting to the OT, we will apply for prophylactic. Okay, then previously it is the quite number of increased happy patients, but these days is number of decrease. Thank you so much.
Thank you, Mr. Napoleon, for an interactive session. And thank you, Miss Rinjin Wangmu, for being the chairperson of this session. Now we will proceed to our next interesting session on cranial surgeries and stimulation in neurosciences. The chairperson for the session is Mr. Jahanuddin Sheikh, critical care instructor, Fortis Hospital, Vasant Kund branch. He has clinical experience of more than 6 years at intensive care unit. He is a BLS and ACLS certified under American Heart Association and certified training of trainer level 1. He has gone through various audits, namely JCI, NABH, and Nursing Excellence. I welcome Mr. Jahanuddin to take over the session. Over to you, sir.
Thank you, Sapna ma'am, for introducing me. Ladies and gentlemen, a warm good afternoon to all at 28th Delhi Neuro Nurses Association virtual conference. Now we are at split session Neurological Nursing 6. The first session on the topic of management of patients with cranial surgeries related to nursing insight. Cranial surgery is a surgical procedure in which a part of the skull is temporarily removed to expose the brain and perform an intracranial procedure. Common conditions for cranial surgeries are brain tumors, subdural emphysemas, subdural hematomas, aneurysm, arteriovenous malformation, and intracerebral hematomas. For such sort of patient with this condition to be taken care with preoperative care, intraoperative care, and more prominently post-operative care that matters a lot. After a successful cranial surgery, which entirely depends upon the patient's good prognosis as well as quick recovery. So on this topic is going to be presented by Miss Rebecca Samathi Bai. She is MSc Nursing, that is Medical Surgical Nursing, postgraduate diploma in Medical Law and Ethics, Professor, College of Nursing, Christian Medical College, Vellore, Tamil Nadu. She has done senior training fellowship for 4 weeks in stroke rehabilitation and stroke nursing at Manhasset, New York, United States of America. Life member in Trained Nurses Association, Christian Medical Association of India, Nurses League, Critical Care Society for Nurses, and Society of Indian Neurological Nurses in the office as executive member, Vice President of the Society since 2009, President 2014 to 2017, Program Secretary since 2009. She is a CPR trainer for nurses since 2005 till date in CMC and abroad, that is Kingdom of Saudi Arabia, and BLS provider and instructor from AHA, American Heart Association since 2010. She is the faculty development convener at College of Nursing CMC Vellore. She is an active team member in stroke team to maintain data and responsible for assessment at emergency services She also contributes as epilepsy educator, as an active member in the team to teach both inpatient and outpatient, attends epilepsy surgery meetings. She has published papers in various Indian journals. So on this topic, now I would like to invite Miss Rebecca ma'am to present her presentation. It's over to you, ma'am.
Thank you, Mr. Zahan. Thank you for those kind words. Will you be sharing the PowerPoint or should I will share it? How is it?
I hope
Madam
Madam Sapna.
From your side.
Okay. Is it possible to share from your side, because I am not very compatible with this?
Sure, ma'am. Sure, ma'am.
Okay, before they, as they start sharing, I would, without wasting time, would like to, at the outset, thank the organizers for giving me this opportunity, Swapna and Mr. Zahan for those kind words, and congratulate the organizers for such a big venture. And I'm sure many nurses have benefited, and they're going to benefit out of this. At this time, I also thank the Dean College of Nursing, Dr. Vatsala Sadan, where I am working, for giving me an opportunity to participate in this. It is indeed a privilege to be a part of this forum, because it's always a privilege to talk to our own fraternity, as nurses, when we want to say. So I have conceptualized this talk or this presentation focusing only on craniotomy, though there are many other entities like craniectomy and many other surgeries are there. At the end of the session, please feel free to include your own views, ask me questions so that we can learn with each other. The time allotted is 20 minutes, so I will quickly go through my slides. It's a vast topic, but I've made it so simple so that all of us, especially the clinical bedside nurses, will benefit out of this. Next slide is, can I go to the next slide, please? The overview of this slide is, I will talk about the little bit of the introduction, background, historical perspective, terminologies, neurosurgical equipments, advanced technologies, indications, contraindications, pre-op and intra-op care, and also post-operative care, along with complications. And I will conclude my session with the take-home message. A craniotomy is a surgical procedure, as all of us know, in which a part of the skull is temporarily removed to expose the brain to perform an intracranial procedure. More than me, the sisters who are working, or the nurses who are working in the OR are very well, have seen that, experienced it, they have assisted it. So I have only the theoretical knowledge. And the common conditions that can be included for during a craniotomy or can be removed is brain tumors, aneurysms, arteriovenous malformations, subdural empyemas, subdural hematomas, and intracerebral hematomas. Also, we also have the next slide. The next point is, not able to move the point. There are some specialized tools and equipment which are utilized to remove the section of a bone, because the cranium is such a thick and such a big thing. Unless we remove the skull, we all know that we cannot reach to the brain. So when they do that, they remove a bone, and which is called as bone flap, and that is the main name why we call it as craniotomy. When the bone flap is replaced back, it's called as craniotomy. When it is not replaced, we call it as craniectomy. Now, there are some occasions where bone are discarded, the bone piece or the bone flap is discarded. A long duration of surgeries, infected bone, or sometimes in decompressive craniectomies where you don't want to replace the bone, you want to give time for the brain to, you want to give the space for the brain to swell, they don't replace it. So that is called as craniectomy. Going on to the next slide, which is a little bit about the historical perspective. From a historical perspective, ages back, we have heard about trephining. Trephine is making a hole into the cranium and doing something. This actually was done for patients with depression or patients with, when they thought evil spirits were there and they wanted to chase away the evil spirits, they started doing this trephining. And this trephination is the oldest cranial surgery. And then now we have the current modern surgical technique, which is called as craniotomy. This was first introduced by a self-educated surgeon called Wilhelm Wagner. Okay, with that introduction, we are now not calling it as trephination, but we call it as craniotomy. Okay. Now, some of the terminologies that I would like to talk is burr hole, which is a very common thing that we always hear, which is created with a special drill and that permanently removes the circular area of a bone. You can see in the picture, there are small holes and these bones are not replaced. They do a burr hole and then through the burr hole, they remove it. That is also part of a little bit of craniotomy, a small craniotomy. Here, the bone is removed in craniotomy and it is completed. The bone flap is discarded, then you call it as craniectomy. Example, decompressive craniectomy. Now, the surgical procedure to reconstruct. Now, you can't live without a bone because that area is very soft and that area is prone for some injury. So then they have to come back for a procedure called cranioplasty, which can be done 6 months to 1 year. They come back and that is a reconstructive procedure which is called as craniectomy or cranioplasty. Okay. The next slide is about, the next slide. Okay. These are some pictures which I want to show you the approaches, how craniotomy is done. We would have seen many approaches, little bit about it. Okay. Normally the craniotomy is called as frontal craniotomy, frontotemporal craniotomy, temporal craniotomy. Okay, these are some of the words that we use depending on which part of the skull is used, either the lobes or the bone. Suppose if the frontal bone is removed or the frontal lobe is repaired, then you call it as frontal craniotomy. So that way you may have frontotemporal craniotomy, you have parietal craniotomy, temporal craniotomy, suboccipital craniotomy. These are some of the craniotomies. The second picture is called as a bifrontal craniotomy. You can see a incision from one end of the head to the other end of the head. That is from ear to ear. This is called as a bifrontal craniotomy. Now in the third picture, you see an area called pterion. You can see that marked area, and that is a junction of the frontal, parietal and temporal bone. So sometimes you may see a pterional craniotomy. So all are supratentorial approaches, where the surgery is done in the front portion of the head. So that is called it as supratentorial. Now craniectomy, you see, you remove the bone and you can see in the imaging, the CT imaging, you don't have the skull there. The first picture is the skull is removed. Then later, when after cranioplasty, the skull is replaced. So these are some of the anatomic locations or how they name the surgery as a frontal craniotomy or whatever craniotomy. Okay. Now, so why is the surgery based on, why is it important for us nurses to know what is this anatomical location of the surgery? There are two terms that I want to say. This is not a very old term. It's not a new term. It's a very old term, because you would have seen surgeons writing in their operative notes, supratentorial surgery or infratentorial incisions. Can I have the next slide, please? In this slide, we see some of the positions, the intra positions that we use. It is also very important for us to know when we receive a patient. In the pre-op, when we take care of patients, we know what kind of surgeries they're going to undergo because they write it. But in the in the intra-op, in theater, when they position the patient, there are a lot of technical things or the equipments are being used. And we as nurses who are giving care in the post-operative period should know what position was used. So you see a supine position, you can see a lateral position, You can see a retrosigmoid where the patient is positioned in lateral, and where then retromastoid behind the ear, they open for an infratentorial tumor. Then you have midline suboccipital, where in the suboccipital region they put an incision. Most of the time, what I remember as a staff nurse is they used to do surgeries in sitting position. Patient is made to sit, and then the head is flexed forward, and then they make it. Now, because of the risk of pneumocephalus, they're not using this position in our institution. I don't know if someone is using it, but they do a lateral position or a supine position. So these are some of the positions that, now why I'm showing you these positions are the position, it is held in a holder like thing. You can see a holder where pins are fixed. Now the patient is going to be in that holder for at least 4 hours, 5 hours, 6 hours, depending on the duration of the surgery. So when the patient comes back to the post-operative ICU, he may complain, or he or she may complain about pain in one particular area, or pain at the pin site, or they may have some bed sores or pressure sores. So it is very important for us to observe those things also, and not ignore them as a very simple one. That is why I thought I'll show you the intra positions. Okay, I was talking to you about the anatomical location or supratentorial and infratentorial surgery. Now, supratentorial is, thank you. Supratentorial is, there's something called the dura mater has 2 folds. I'm not going into the anatomy, but a little bit I will tell you. And one fold which is close to which is called as tentorium cerebelli, it divides the cerebral hemispheres. As you see in the picture, there is one partition. So what happens is all the frontal lobes are in the upper portion, and the brainstem and cerebellum are divided. So that is called as tentorium cerebelli, which divides the whole brain into 2 pieces. So whatever is above the tentorium is called as supratentorial surgeries. Whatever is below is called as the infratentorial. So what are some of the surgeries in supratentorial? It's all the lobectomies. Anything that you do with cerebral hemispheres, it is supratentorial. Any surgery related to the brainstem, cerebellum, some amount of occipital portion also is included in the infratentorial surgeries. Thank you. Okay, some of the equipment that they use. This again, my knowledge is very limited. I know as a theoretical thing, but I'm sure all the OR nurses will talk more about it. But we need to know as nurses what are some of the equipment that are being used in theater. Craniotome. Okay, it's a high-speed pneumatic cranial drill. Hudson brace, which is a manual drill. Then Freer elevator, pen-filled dissector, artificial dura. Dura is supposed to be, they cut the dura, operate on the lobe, and then they have to close the dura. What happens after some time, the dura will shrink. So that time they will not be able to approximate the dura. So they put a dural substitute, okay, something like that, and then they take a stitch. Otherwise, they will be CSF leak. So all these are some of the, I have a slide to show you some of them. Okay, in the next slide, I'll show you some of the equipment, why they use it. You can see a picture of how the dura is open. Now, the first one is the craniotome handpiece. They use this to make a hole, on the cranium. They make a hole, and then they for that they use it. And then you have the head holder, where it is fixed onto the cranium, and then it keeps the patient's position in one position, so that the head will not move, the head holder. Then you have the high-speed drill, where you have to make a drill into the thing, and then they get inside to the bone. So that is the drill. Then you have the Gigli saw wire. Gigli saw wire is where you insert through the burr holes, and then by zigzagging, they will cut the bone piece out. So these are some of the drill bits. So when patient says they have pain in ICU, we must remember, imagine all these things. So patient would have had this. So we have to have that kind of considerations. That is why the patient is having pain, and also not only related to the surgery. These are extra things where patient can present with pain. There are some advanced technologies also when we talk about craniotomy. One is microsurgery. Now, microsurgery is, all of us know what is these days. Robotic surgery, microsurgery have become very frequent. Now, microsurgery is used where you want to magnify very simple and delicate thing, very small and delicate tissues. So you can see through the microscope and operate. Ultrasonic surgical aspirator, or otherwise CUSA, is a aspirator where the bone tissue is not cut out. This by using a fluid or a fluid, it is actually it breaks down the tumor, and then the tumor particles are sucked into it. That is how CUSA is used. That is not an advanced technology, but it is equipment that is being used. The next is stereotactic radiosurgery. If you have seen one, or if you have experienced, you know how they are doing it. Stereotactic surgery is used where you want to precise a small tumor deeply sitting and to localize that. So with the use of a CRW frame, you see a frame here in that picture, which is called Cosman-Robert frame, and a measuring thing. So you take three-dimensional measurements like X measurement, Y and Z. X is actually anteroposterior, Y is the superior inferior, and Z is the left and right. And then the intersection of all these 3 points is where you have the tumor, brain tumor. Sometimes it can be an AVM. So these things can be destroyed or coagulated by using stereotactic radiosurgery. You can actually take a biopsy of those lesions, etc. Neuronavigation, laser surgery, radiosurgery are all new techniques. Laser surgery is an acronym of light amplification by stimulated emission of radiation. That is the acronym for laser. And radiosurgery is also like that. It's a gamma knife surgery where we do. Last one is awake craniotomy. In this craniotomy, patient is not given general anesthesia. Patient is awake. Patient is awake, either talking or singing or playing violin. I have a picture to show you, just playing violin and all. And why they do it, I'll show in that slide. Okay, next slide, please. These are some of the advanced technologies. Next slide, please. Okay, awake craniotomy, just one word about it. The goal of awake craniotomy is to maximize the tumor resection, preserving neurological function. As you see there, the lady is playing violin and they're doing surgeries. Here, general anesthesia is not given, but the nerves are blocked and then surgery is being done. So the surgeon will be careful to preserve the eloquent areas. When you say eloquent areas, the areas of motor activity, speech, etc. So that is awake craniotomy. This is a new thing in our, we are doing that, awake craniotomy. I'm sure many institutions are also doing it. Okay. The next slide. Now we are going into the most important topic of care of craniotomy. I won't go through this list of indications, because all of us know that it can be brain aneurysm, can be tumors, it can be cerebellopontine tumors. You want to do a lobectomy, epilepsy surgery. There are many reasons we do a craniotomy. It is not just to remove the tumors, but many reasons we do a craniotomy. There are also contraindications. Now, you cannot call it contraindications. These are just concerns, because 80 years old patient is admitted, we still do a craniotomy. Not that it is not a contraindication. But, when you have this list, like poor functional status, severe cardiopulmonary disease, systemic collapse, all these things becomes a concern. So before taking them for craniotomy, there'll be a lot of discussion on how we are going to do it. And how do we treat that? For example, if there is a systemic collapse, patient has a brain tumor or brain abscess, but he also has sepsis. Sepsis has to be corrected. The multi-organ failure should be corrected, and then he'll be taken for craniotomy. So these are concerns where when a patient is taken, if you note, if the surgeons have missed it out, if we have noted something like this, a bleeding disorder or a poor functional status, we can tell them there is a concern like this, so that they will be also careful. That is contraindication. Okay, the preoperative care, all of us know what we have to do, the routine investigations, the physical preparation, skin preparation is very important. Nowadays we don't do a whole head shaving, because for the cosmetic regions, especially in ladies, you can't do full shaving. So we do area where they're going to do the surgery, we will just do the shaving, so that the patients can hide that incision for cosmetic reasons. Okay, and GI system, there's not much of a preparation except this 12 midnight starvation. Psychological preparation is very, very important, because explanation is we have to give explanation, we have to get the informed consent, we should get pre-anesthetic consultation, what medicines have to be included before sending to theater, what drugs should be included, omitted, everything we should be clear, get a clear order from the doctor, and send necessary chart and films, antibiotics to OR. Going on to the intro, next slide please. A pre-op checklist also should be completed. Okay. In the complications, what are some of the complications of craniotomy? I will deal before we go on to the nursing care. Okay. Can I slip this slide, because it's just intraoperative care? Okay, complications. You have two types of complications. One is surgery related and the other one is general. Now, surgery related, it's very, very important for neuro nurses. One, cerebral hemorrhage, increased ICP. These two are very important, and already someone has dealt with increased ICP, so I won't go into it. Pneumocephalus, as I said, usually happens in sitting surgery. Whenever patient complains about pain, headache, we should be careful to immediately report, so that we will either know if it's a pneumocephalus or is it a sign of increased ICP. Seizures, it can be a focal seizure or it can be a generalized seizure, whatever seizure. Even if it's a small twitching of the hand or the mouth, we must immediately inform the doctor. CSF leak, if there is any CSF leak from the wound or from the nose after transsphenoidal surgery, we must be able to tell them, document it, and also tell them. Meningitis, if there is any compromise in our care, in the suturing or in the anything, intra-op, pre-op, post-op, if we did not clean properly, if there is a bacterial invasion, patient will definitely go into meningitis. Cranial nerve dysfunction will be there in both infratentorial and supratentorial, that we will see in the next slide. The general complications, now mostly we think if there is a neuro patient, we should most concentrate on the neurological assessment. No, we have to concentrate on the cardiac and respiratory instability, because all are related. The cardiac, if there is a problem in the cardiac system, CNS will be affected. If there is a problem in CNS, cardiac system will be affected. Respiratory system, if hypoxia, all that will be affected. So we have to look at the cardiac rhythm, we have to look at the saturation, we look at the arterial blood gases to see if there is any problem. And posterior post-operative nausea, vomiting is common after general surgery, also common after the surgery. Okay, going on to the post-operative phase, we will skip this and go on to the post-operative, the supratentorial. I'm sorry, I have to run like this. As a nurse, okay, this is general nursing care of post-operative care, where we have to, I'm sorry, the previous one, please. I will finish with this. Okay, so early assessment, immediate post-operative care, we must do early assessment for 8 hours, then 2 early assessment for 8 hours, then 4 early thereafter. We have to monitor all the vital signs, the neurological sciences like GCS, pupils, limb movements, vomiting. If anytime you find anisocoria, immediately it has to be informed, because that tells you that there is an increased ICP. And all the other like bed dressing, seizures, speech, all that has to be informed also. We should not cluster care, because in any time when we cluster care, there will be increased ICP. So to reduce ICP, we must not cluster care. We must be very not hurried. The next is supratentorial and infratentorial care that we have to give. In supratentorial, as we all know, head of the bed should be elevated, no restriction in turning. There's no concern, elimination concern. Make sure that fluid volume deficit is corrected. Infratentorial, again, there is no change then, but post-operative nausea, vomiting is always a concern. Presence of pharyngeal reflex should be done. Before you start feeding in infratentorial, make sure that the gag is checked. Otherwise, if gag is absent, Ryle's tube feeds will be continued. Initially, we can start with soft solids and then go on to liquids later. The next is cranial. This is a very important thing. Now, many times we think nurses, we don't have to look at this. Very important, we have to look at it because we are the ones who care. So we have to see for all these things. In supratentorial, there will be cranial nerve 2 and 3 palsy, sometimes 4 and 6. And infratentorial, you'll have 7, 8, 9, 10 will be affected. So check for all these things. You have to do an assessment, check for this, and then report to the doctor. They will very well appreciate us. If we do the assessment and we tell them, then they checking. The next slide, please. Okay, transnasal surgery. Transnasal is also a cranial surgery, but nothing to do with cranium. The surgery is done through nose. So we have to follow the unit protocols as the surgery is being done. Okay. And major thing is they come with a nasal pack, or sometimes they don't come with a nasal pack. Depending on what is the problem, we have to address to it. Okay, that is transnasal and transphenoid. The take-home message for this talk is, I know I had been running like what it is, but to finish it. But the important thing that we have to remember is post-operative neurosurgical care is to prevent or minimize complications. And if we do neurological assessment properly, appropriately, that will prevent, most of the complications. Systemic complication has to be corrected so that the neurological complications will also be corrected. And if it's a neuro nurse in an ICU, if we do that, if we are properly trained, the mortality and the morbidity will be reduced. So we should possess adequate knowledge and critical thinking skills so that we'll be able to assess and tell. This is all we can do as nurses. Thank you. And any inclusions I would like to take or clarifications.
Thank you so much for a wonderful session, Rebecca, ma'am. Now, I will summarize the session. As with a very quick session, I will summarize it. As ma'am says, that bone flap is all about of remove skull bone, and if they will replace it, then it will called as a craniotomy. If they are not going to replace it, then it's called a craniectomy. And some terminology ma'am has used, that's called the bar hole, that by the help of machine they will create a special drill to get the access. And what's called the cranioplasty, if they will replacing the bone within 6 months to 1 year, and they will keep that bone for the sustainability, or they will make a pocket on the abdomen, and if you replace back it, that calls a cranioplasty. Then ma'am has said about the types of craniotomy. It's just all about of anatomical location of the skull, whether it's in the frontal one, then frontal craniotomy, it goes like this: temporal, parietal, bifrontal. Then after that, ma'am says the intraoperative position, like lateral, supine, sitting position. But by that only, if the nurse will come to know, they can, before the doctor comes, they can make the patient with a desirable position. And then ma'am again says that the two terms that use that call a supraanterior and infratentorial. And that is basically it's the difference between the cerebral hemisphere and brainstem and cerebrum. Then ma'am says some neurological equipments used like artificial dura, high-speed drill, head holder, craniotoma handpiece, and some advanced technologies like microsurgery, laser surgery, radio surgery. And ma'am has given a bit more stress on the awake craniotomy, and that is the motto behind of that. Here, patient is not on generalized anesthesia, on local anesthesia, just to block the nerve to maximize the tumor resection. And again, ma'am said about some indications, contraindication, free of care is as it is, like We just maintain the, and also ma'am said that nowadays we are not going to save the entire hair. Which part we are going, that only you have to remove the hair. Then intraoperative care. Then the complication we have to stress in this. There is a two type. One is the surgical complication, one is general. For surgical, like due to that increased ICP will be there, cerebral hemorrhage, meningitis, seizure, CSF leak, and in general, DVT, deep vein thrombosis, infection, pain, gastric ulcer. And then we can see the post-operative care that plays a very important role. For this, we have to maintain the vitals, GCS, Glasgow Scale, pupils, limb movement, vomiting, and anosognosia. This is unequal pupil size. If it is more than 0.4 mm, then we have to immediately tell the doctor, because it will give you the indication that there's an increased ICP. And also ma'am says that in supratentorial, what position, and infratentorial. In the both, we have to head of the bed will be 30 degree in the both cases. In supratentorial, we can use a small pillow, but in infratentorial, we're not going to use. And then ma'am also said the very important things that if there is some findings, cranial nerve injuries are there, if we nurses will identify it and we have to inform prior the doctor comes, then they will appreciate our job. That is a very important thing, ma'am. We should have to learn that. And some says ma'am about the transnasal surgeries, and the takeaway message, as ma'am said, that our nurses should be knowledgeable, skillful, and they should be a critical thinking. And this kind of platform can give an opportunity, and a speaker like ma'am, the nurses will get a lot of empowerment and knowledge, and they can practice a lot in a very effective manner for the welfare of the patient. Thank you so much, Rebecca ma'am. Now the forum is open for a Q&A session. Yes, now the forum is open for all the participants. If you have any question related to cranial surgeries, please pose your question. Okay, ma'am, Rebecca ma'am, I am only asking on behalf of all the participants at the ground level staff. Ma'am, if there's a patient comes like a RTA, road traffic accident, or they suspecting about the patient maybe have a right MCA infract. So in this case, ma'am, we in the before the patient taken to the OT only, in the middle of the night it's coming, then we can use the DVT pump, or what position we likely to give for the patient?
Mr. Zahan, sorry, what is that? What did you ask?
Yeah, ma'am. If the patient comes like in emergency,
road traffic,
road traffic accident, or they're suspecting maybe subdural hematoma, or they have suspecting as a right MCA infract. So in these cases, ma'am, at the patient has got admitted in the ICU, so the nurses, they will apply the DVT pump or not, and what likely position they used to give? Elevation of that.
In an emergency like that, they any position, usually the lateral position with the head end elevated only. We don't put the bed flat, because they won't stay in an ICU for a very longer time, because it's about 10-15 minutes. They will be shifted to theater if they want to do some surgeries, or if the patient is so, depending on if they have like for a head injury, if you're saying road traffic accident, then a collar will be applied from emergency services only, but still the head end will be 30 degrees only. And what pump did you say? You asked?
DVT pump, ma'am. DVT pump.
DVT pump. We don't use a DVT pump at all. Is it DVT? We don't use a DVT pump at all.
Okay. Thank you so much, ma'am. And still we have some few minutes. The forum is open for the audience. If you have any sort of doubt and question, please pose your question.
They can, if not questions, they can also include their own views or their experience, so that it will be a benefit for all of us. If not questions.
Yes, of course, sure, man. Yes, from the participant, you wanted to share your own inputs. By that, it will be more informative session for everyone.
Mr. Sheikh, please move to the another session. We are running short of time, please.
Okay. Thank you, Sapna ma'am. Thank you, Rebecca ma'am. Now we are moving for the second speaker.
Thank you very much. Thank you.
Thank you, ma'am. The second session on the topic of use of simulation in neuroscience nursing. Simple meaning of simulation is imitation of a situation or process, or in a bit broad sense, replication of real life clinical scenarios to achieve experimental learning. Simulation is extensively used to educational purpose. It is used for cases where it is prohibitively expensive or simply too dangerous to allow trainees to use the real equipment in the real world. In such situations, they will spend time learning valuable lessons in a safe virtual environment, yet living a lifelike experience, or at least it is the goal. Often the convenience is to permit mistakes during training for a safe critical system. Therefore, on this topic is going to be presented by Miss Ekta Malik. She has done her MSc Nursing in Obstetrics and Gynecology and postgraduate diploma in Reproductive and Child Health Program from Public Health Foundation of India, Deputy Manager at DSS Image Tech Private Limited. She has been associated with Pioneer Institute, National Reference Simulation Center, FGT University, inaugurated in collaboration with Indian Nursing Council, GPEGO, and Lateral, where more than 130 nursing faculties are trained on simulation-based education all across the country. She also has contributed in the public health sector to reduce NMR, that's the neonatal mortality rate, MMR, maternal mortality rate in Bihar state with Care India. She is level 1 certified OSIM trainer, which is a prestigious simulation course in Europe, and has done simulation facilitator training by Pronto International, a US-based organization. She is an American Heart Association certified basic life support and advanced cardiac life support instructor and National Neonatology Forum certified neonatal resuscitation program trainer as well. She is the master trainer for training of trainers on simulation-based education and capacity building of midwifery faculty on skill standardization and simulation run by Indian Nursing Council. She has got appreciation for research publication in Scopus Index Journal. Now I would like to invite Ekta ma'am. Please present your presentation.
Thank you so much, Mr. Sheikh, for this kind introduction. Let me just share my screen. A very good evening to everyone, and I'm really grateful to the DNACON Organizational Committee for having me on board, and pay my respect to Ms. Marilyn Flimsy for trusting me for this part. I'm truly honored for this. So in today's session, we'll be talking about use of simulation in neuroscience nursing. In this topic, one thing I want to make you clear that this particular session will just orient you or to aware you about simulation. If you really want to be a simulation trainer or simulation facilitator, so you can contact me for that. I'll share my details at the end of the session. Yeah, so I just assuming that most of you are aware about the simulation, what is simulation, and we have started using this term very frequently from a couple of years only, particularly in India, because in foreign we are they're already 20-25 years ahead in simulation. So years back we have started using simulation in healthcare, especially. If I have to tell you what is simulation or simulation based education, so it is replication of real life clinical scenarios into your own settings so that you can give experiential learning to your students. As you can see in the screen, so there are few people you can look into the screen. The one is the standardized patient, the person whom we can give a role. Okay, you have to behave like a patient. And others are maybe doctors, maybe relative, maybe nurses, maybe students or whatsoever. So this could be a simulation setting for the students. So if I have to tell you, some of you might be wondering why we started using simulation in healthcare, or what is simulation. So regarding background, if you can look on the screen, so there is a study mentioned where the study is saying that approximately 3% of the hospital patients result in 98,000 deaths per year in United States. So this was a landmark study that was done in 1999. So even if you can recall your own learning in graduation or maybe post-graduation, so how we have learned are most of the skills, mainly most of the skills on the real patient in hospitals. So don't you think, is it a risk on the patient safety? So simulation is the answer for that. Even apart from the patient safety, if I talk about the benefit of simulation, one thing is when you go to the hospital, let's say today you have prepared for a topic on trauma management, and you go to the hospital for a day, you did not get any patient on trauma, or maybe for a week or for a month or maybe 2 months, you are not getting any patient on trauma, for example. So how are you going to apply your knowledge into the practical? Again, simulation give opportunity to practice your critical cases, to practice your rare cases. How many of you are really prepared to handle the emergency situations? Or how many of has really practiced in a team? So simulation give an opportunity so that we can actually practice in team. We can actually practice on those critical cases that we hardly encounter into the clinicals. So that rather than learning on our patient, being a student nurse or maybe a fresher nurse, rather than just practicing on the patient, we can provide quality of care. So there is plethora of research that is supporting simulation as a methodology to give confidence to the student, to improve their knowledge, their skill proficiency, and how do they make decisions in emergency situations, or how they communicate in a team, or how they are working in a team. So plethora of research is there that is supporting that simulation can help us in all those areas. So I'll be just talking about simulation, then I'll be showing a video so that I can give idea of simulation. How do we do setup in a clinical setting and in a simulation setting, and how do we go on with this? If I have to elaborate on simulation, the question is, when do we do a simulation and how do we run a simulation? So as I already mentioned, so what do you think? Can we really throw the student directly into the simulation? The answer is no. Because let's say student just been enrolled in first year, can we directly throw the student in simulation? No. So before starting the simulation, the student should know knowledge. The student should really know about the condition. What is the condition? Let's talk about vital signs. The student should know what is pulse and what are things that can fluctuate a pulse. Okay. After that, student should know how to take a pulse or how to take a BP. The student should have done ample amount of practice on skill proficiency and also decision making. They should know in which condition they have to prioritize which thing, whether they have to prioritize the airway, whether they have to prioritize the circulation, whether they have to prioritize the medication, and so on. So once they have done this knowledge part, they know about the skill, they know about the decision making. Now students come together in a team in a simulation and they started doing simulation. So at one time, as you have seen in previous slide also, as one time we do not allow more than 4 to 5 students, because simulation is an individual learning. In simulation, when we talk about the facilitator, or when we talk about the instructor, we always say facilitator. Because even it's not about just the student, it's about the teacher as well. Teacher has to come out of that instructor zone and come to become a facilitator so that they can work as a team, because simulation is very extensive. If I have to go to the technical part of the simulation, it has 3 components. As you can see, first is a pre-brief. So let's say we have just called 4 or 5 students today. So first thing, what will I do? I will ask them, okay, today we are going to run simulation on epilepsy. So you have to just go through your knowledge and come prepared tomorrow at this particular time. And as a facilitator, I'll prepare the room, because in simulation there is no real patient. So what I'm going to do, either I'm going to have a mannequin. As you can see in this first picture, there is a baby lying in the radiant warmer. That is mannequin. Okay. And another, there could be a standardized patient, as you see in the previous slide. Okay. Next thing is we would require certain equipment, because we want them, once they will go after simulation, once they'll go to the clinicals, they should be knowing, they should be identifying the equipment. They should be identifying various articles, like, okay, this is the laryngoscope, okay, this is the ET tube, and these are the various sizes of ET tube. So there is lots of learning happening in the simulation. So in preparation part, you'll be keeping mannequin, standardized patient, you'll be keeping your equipment, you'll be preparing everything. As you can see, there is a bed, there is a radiant warmer, there are PPEs, there each and everything that is required to run that simulation that student would be requiring during simulation. So after that, you'll call them inside. As a facilitator, you'll call them and you will pre-brief them. In pre-briefing, you just orient them to the environment. Let's say, okay, now this is a patient. In mannequin or standardized patient, there are few things you can do in actual. There are few things you have to simulate. And in this mannequin, you will be getting your readings. Where are you getting this reading? Are you getting reading on the patient monitor? Or your facilitator will be telling you the readings when you will check for vitals or other things. Then in pre-brief, you will also tell what will be the learning objective. Like in your lectures or in your skill session, there'll be objectives. Same like that in simulation, there'll be learning objectives. Each simulation has at least 2 to 3 learning objectives. Then you talk about what will be the patient situation when they encounter with. Then you will talk about what will be the role of the participants, who is going to be a nurse, or who may be a relative, or who may be an observer, and so on. Once they are ready with everything, here I want to put stress on one thing. Here many people get confused between simulation and role play. Role play is something where participant would be knowing each and everything. Let's say they would be knowing, okay, at this particular time I'll meet the patient, then I'll check her vitals, then I'll do this, then I'll do that. But in simulation, we are not going to tell them what you are supposed to do. I will just tell them, okay, this is your learning objective, and now just patient in this condition. Now you manage the patient. Okay, I hope you can make the difference between both. So after then scenario starts. In scenario, there will be just participants and student. There'll be no facilitator around. Even they cannot talk to their facilitator. The facilitator has to may I request a participant to mute yourself? Okay, so if
video off on.
May I request the participant to mute yourself, please? Okay, so in scenario, as you can see in this particular, there are 2 and they may have 3 and 4. So in scenario, facilitator will not be there. Student will be independently, they will be performing with the patient. But the facilitator will be out of the room, but controlling each and every condition. Let's say in this particular scenario, there is they are resuscitating a patient. Okay, so the facilitator will be controlling, okay, initial vitals will be this. Now they have started doing PPV, so they may improve the patient condition. Or let's say students are not doing well, they may deteriorate the patient condition. So it will be completely controlled by facilitator, and student will be performing based on the patient condition as they do in real clinical setting. So scenario usually run for 10 to 15 minutes depending upon the learning objectives. Once scenario is over, then last and most important part of the simulation is debriefing. In debriefing, this is, we can say, soul of the simulation, because major learning, or we can say 80% of learning happened here. In debriefing, facilitator has minimal role. Most of the time, the participants will be talking to each other. They'll be talking on what went well, what part they can improve next time, or how they're going to apply this learning into the clinicals. And at the end, facilitator will summarize the session, and if required, they can do a resimulation of same session so that they can apply their learning directly into the simulation. Now students are prepared to go to the clinicals. Now you can make difference. What will be the difference when the students are going directly from classes to the clinicals versus they cover their skill, they cover their knowledge, they cover their decision making, then they come to simulation and then going to the clinicals. Even on that part, Indian Nursing Council is also working on incorporating simulation in nursing curriculum that may roll out very soon. Okay, so that's about simulation. I hope all of you are clear about that. Now I'll be running a video for you. And there is disclaimer for this video. I know this is not of very good quality and this is not a very structured simulation because I had just this video with me. So I just thought I'll give you an orientation so you will have an idea about simulation. Just let me know if you are able to hear the voice. Can you hear it? Is it audible?
Not not audible.
Not audible. Okay,
Not
let me
audible.
try. Wait a minute. I'm so sorry for this.
Ekta ma'am, it's not audible.
Ekta, are you playing me directly from the slide? If you have the video separately, then you can play from there. I think.
Ekta ma'am, you are not audible. Please unmute yourself. Ekta ma'am, you are not audible. Ekta ma'am, is it finished? Can I go ahead? Just raise your hand. If from your end is it finished, just please raise your hand. I can proceed further. Okay. As we are running short of time. Okay. Thank you so much, Ekta ma'am, for your wonderful presentation. Now I'll just summarize about Ekta ma'am's presentation, as the presentation topic was the simulation in neuroscience nursing. As simulation says, replication of real life clinical scenarios to achieve experiential learning. As ma'am has presented that one data from the USA in the year 1999 that 3% of hospital patients, they died just because of medical errors, causes injuries that result in 98,000 deaths per year in USA. As ma'am rightly has mentioned, and by that also we have also learned it, what are the methods, the three components we have to follow in the simulation. That first one is a pre-brief, second scenario,
third is debrief. One thing we have to focus more in pre-brief, that is orient the environment. Who all of the participants are there? First, we have to orient them the environment. Then there should be a learning objective should be there in the pre-briefing. Then come back to the second component, that is scenario. In that scenario, only the trainees without facilitator will be present, and the facilitator will be having full control, but from the outside, and they have to give the entire that place or situation to the trainees. They should have to operate the thing, whatever the learning forum will be there. Now, the third thing is that components is debriefing. In the debriefing, the participants will talk more and discuss the scenario task. They will talk more, and later on, the facilitator will summarize the simulation task. And after that, if the participants, they think that they have not reached up to the mark, they can retake the simulation again. And after that, Ekta ma'am has shown the video that seems that it's like a intubation was going on the mannequin. They have done, and after that, ma'am has lost due to technical some problem. So we are not able to audible to ma'am. And now in this condition, we are not able to take any questions from the ma'am also. So ma'am, please share your number, because we wanted to know if we wanted to go for a simulation training, what are the basic things are required. As you already said that this is a very new, in the European countries, they practice a lot. In India, we are lacking a lot with this. So ma'am, please share your numbers. Whenever we need, we'll contact you. And it is very effective, as nowadays many more nurses are coming from the COVID era. So their third year and fourth year, they have done everything online. So no exposure to the patient. And it's a highly challenging once they comes to at the patient bedside. So this kind of training definitely help us. So ma'am, kindly please help share your number and your location also. If you are around the Delhi, then we can easily contact you, and as well as all that mannequins, we can get it from you. Okay. And now I would take this opportunity to thank to this Delhi Neuro Nurses Association for giving me this opportunity as a chairperson to play this role. And also I would like to thanks to my Chief of Nursing, Ashwini ma'am from Fortis Hospital, Vasankunj. And also I would like to thank to my Nursing Director and Group Chief of Nursing, Madam Captain Sandhya Shankar Pandey, for giving me this opportunity. First time I have played a role as chairperson with this virtual forum. It means a lot for me. And thanks for the organizer as well as Merlin man. Whenever I have the doubt, she keeps clarifying my doubts. And thank you so much, the organizer, Omnicurious. And now it's over to Sapna. Please go ahead.
Thank you, Ms. Rebecca ma'am and Ms. Ekta Malik for an interesting and elucidative session. Thank you, Mr. Jahanuddin, for moderating the split session 6. Thank you. Finally, we come to the last session of the day. The chairperson of the session, Ms. Bhagya Lakshmi, Masters in Hospital Management, Nursing Quality Coordinator, Apollo Health City, Jubilee Hills, Hyderabad. She has been actively participated in different audit processes in the hospital, for example, 360-degree and NABH. She is the auditor of Nursing Full Circle Audit and various internal audits in the hospital. She is AHA certified ACLS provider. She is research and publication club member of Apollo Hospital Group. She is currently working on 2 research projects. She was a part of organizing committee for Critical Care Conference and International Patient Safety Conference. Over to you, Ms. Bhagya Lakshmi.
Yeah, thank you, Ms. Swapna. Am I audible?
Yes, we can hear you very well, please.
Let us have the introduction about the next speaker. It's on case presentation on meningitis. It's by Miss Divya Rawat. Yeah. Next is about the case presentation on meningitis. It's by Miss Divya Rawat. She is a nursing officer, Neuro ICU at Indraprastha Apollo Hospitals, New Delhi. She has done her diploma in general nursing and midwifery from Florence Nightingale College of Nursing, GTB Hospital, Dilshad Garden. Over to you, Miss Divya Rawat.
Thank you, ma'am, for introduction for me, and hand over the mic to me. Now my case presentation. Now my case present topic is post-procedure meningitis. Now I'm just brushing your knowledge on the meningitis. The meninges are the layer of the tissue that separates the skulls and the brain. Now the meningitis, it is an acute inflammation of the meninges caused by the bacteria, viruses, fungus, parasites, and non-infectious also. Now microorganism enter the CNS, skull and backbone fracture, medical procedure, along with the peripheral nerves, blood and lymphatic system. Now the pathophysiology of the meningitis, bacteria or the microorganism enter the bloodstream by any trauma or the surgical procedure, enters through the mucosal surface or the cavity. It's break down the normal barriers, cross the blood-brain barriers, which proliferates in the CSF, inflammation in the meningitis, which cause the increase in intracranial pressure. Now, bacterial meningitis, it is also known as septic meningitis, extremely serious that required the immediate care, can lead to the permanent damage of the brain, disability or death, spread by the causing coughing and sneezing. Treatment available, antibiotic as per the causative organism. Now, sign and symptoms, fever with chills, headache, stiffness of the neck, seizures, confusion, disorientation, altered mental status, lethargy. Now, two important sign or clinical examination in the meningitis, which perform when the patient is admitted with the complaints of meningitis. First one is Kerning sign and second one Budinsky sign. In Kerning sign, how the perform is the doctor or examiner flex the knee at the 90 degree, flex the hip at the 90 degree, extend of the knee is painful or limit the extension is the positive Kerning sign in the meningitis case. If in Budinsky sign, passive flexion of the neck due to the pain, knees is also flexed. This shows the positive Budinsky sign. If two or the sign is positive, then doctor decide to send the CSF sample for the further evaluation. This is the chart. This is the chart with the normal CSF value, with the bacterial meningitis CSF value, with the viral meningitis CSF value, and the tuberculosis and fungus. Classified by the appearance, protein, gram stain level, glucose in CSF, serums, and others. Now, the complications of the meningitis is sensory and neural hearing loss, epilepsy, seizure, memory loss, paralysis, learning difficulty, behavior difficulty, decrease in intelligence, septicemia, and may cause the death also. Now, care of EVD. The problem associated with the EVD is, first one is infection, because a surgical procedure is an open route for any microorganism to grow and cause an infection, or an over and under drainage, trauma and hemorrhage, and blockage or blockage. All of these are the associated problems with the EVD. Now, the nursing interventions. nursing intervention related to the meningitis is assisted in vital signs of the patient. Check the vital signs of the patient for earlier detection of an infection or headache, drowsiness, and decrease alertness. Assisted the neurological status of the patient. Check the GCS of the patient every hourly. If any change seen in the sign, it's a sign of any complication, immediately inform the doctor. Assisted the Kerning sign and Medinsky sign, as we discussed in the previous slide, is how it is performed. If check the sign of the meningitis irritation. When it is happened, it's a sign of infection. Assisted the nutritional status of the patient. Provided the relative feeding as per the doctor advices. Administered the medicine as prescribed. In this, we follow the drug stand and time and follow the aseptic technique during the admission. Maintain the skin integrity of the patient. Provided the back care to the patient. Change the patient position second hourly. In between this, we mobilize the patient at the bedside chair. Reduce the risk of infection. Follow the aseptic technique for any procedure. Follow hand hygiene and infection control policies. Now, some other nursing intervention is assisted the neurological status and the vital sign constantly. Rapid IV fluid replacement may be prescribed, but take care not to overhydrate the patient because of risk of cerebral edema. Reduce the high fever to decrease the load on heart and the brain for oxygen demand. Protect the patient from injury secondary to the seizure activity and altered level of consciousness. Monitor the daily body weight. Prevent the complication associated with the immobility. Institutional infection control precaution. Inform the family about the patient condition and permit the family to see the patient in appropriate intervals. Now my case scenario, I took one of my patient, which I provide the care in the neuro ICU for my case presentation. Now the case scenario was a 10-year-old little female was diagnosed with the post-procedure meningitis. Her surgery, endoscopic third ventriculostomy, done on 5/8/2021 in the Cosmos Hospital because she had an obstructed hydrocephalus seen in the MRI on 3/8/2021. At that time, she had a complaints of fever, drowsiness, unable to speak since 10 days back from the admission. Patient come Indraprastha Apollo Hospital, Delhi on 25/8/2021 for the further evaluation and the management. On admission, she had a complaints of high-grade fever, seizures, and the GCS was E2, V1, and 5. As previous splits, and in previous splits, already somebody discussed about the GCS. Now NCCT was done in Indraprastha Apollo Hospital, which shows the ventriculomegaly and the segmentation of the lateral ventricle. On 26/8/2021, right-sided EVD or extraventricular drain was placed by the Dr. S.K. Sogani and Sunit Mandirata to decrease the intracranial pressure. CSF sample was sent, which shows the glucose was 4 and protein was 1362, which revealed the bacterial meningitis. So treatment was started, IV antibiotic according to the culture report. On 28/8/21, they took LAMA because of the family financial condition, and extraventricular drain was removed at that time. On 11/9/2021, again she was admitted to Indraprastha Apollo Hospital with the complaints of fever, seizure, drowsiness 2 days back from the admission. On presentation, GCS was A2, V1, M3. Supported management was started with the IV antibiotics and seizure prophylaxis, but no change seen in the condition of the patient. CSS sample analyzed shows glucose was 36 and protein was 722. On 18/9/2021, contrast CT was done. On further evaluation, exanthechromatic fluid, a yellow cerebral fluid, come out from the subdural spaces. So Dr. S.K. Sogani and Sunit Mandirata plan to place a left-sided extraventricular drain with burr hole. Intraventricular medicine was administered under aseptic technique through the extraventricular drain by our duty on doctor for a week. Followed that the CSF sample was sent, which shows the glucose was 31 and protein was 509. Injection vancomycin and amikacin was given under aseptic technique, a sterile technique. Dressing was done. Medicine dose was advised by the pediatric neurologist, Dr. Vinit Bhushan Gupta. Doctor and nurses give the special attention to the patient daily and did the dressing keep the surgical area clean and dry. Ensure the area is sterile because the high risk of infection in the EVD. Now, the care of EVD, strict aseptic technique was ensured in handling the monitoring and cleaning of the medical devices. The child was monitored of the sign of infection. Proper alignment of triggers of extraventricular drain is maintained. On and off positioning of stop clock. Oscillation is in the catheter is checked. Ensure there is no kinking in the catheter. The Glasgow Coma scale was checked every hourly to detect early neurological deterioration. The dressing was kept intact, clean and dry. On 7th day, EVD was removed. IV antibiotics as supported management was given. Day by day, GCS of the patient was better. Physiotherapy was started to improve the motor power. Ambulation in the wheelchair and bedside chair was done for the coordination, posture and balance. Nutritional status of the patient was improved through the Riles tube feeding. During hospital stay, patient have a variation in sensorium, multiple episodes of fever, which was managed by the supportive treatment. Patient condition improved and they start taking orally. Conscious and obey simple command. On 10/11/2021, patient got discharged from Indraprastha Apollo Hospital. Thank you.
Yeah, Ms. Divya, it was a very this presentation was very well explained, and the pathology, the way you explained was very informative and it was very clear to understand. I have just one doubt. Is there any position where we have to maintain for the EVD when the patient is on EVD, and how to monitor the drain?
Yeah, there is a particular position. The EVD is placed at the Turgis level. It is the air level. Always placed at the air level, not to the lower level, not to the upper level, because CSF is drained out through the gravity. If EVD is placed above the Turgis level, the CSF flow is hindered, and if the drain EVD bag is placed at the lower level, the CSF through the gravity CSF is collected more amount, which shows the neurological deterioration in the patient. And what was the second question, ma'am?
Is there any of monitoring the EVD drain, like every hour or the second hourly?
That will be that will be decided by our doctors. When we receive the patient from the OT then we ask the doctor. And if there is any amount of CSF if CSF collection, if the doctor says 50 ml in each shift, then there, according to this, there is a stop clock. We know how to open, how to close in each shift. Like we drain 50 ml and stop it and empty into the bigger whack, and for next staff we hand over the next staff. Then the prescribed amount is 50 only. In your shift, empty the only 50, not more than that and not less than that.
Divya, is there any other questions from the delegate? Free to be asked. As of now, there's no questions from the chat box. So, Ms. Divya, thank you for your presentation.
Thank you, ma'am.
Any questions? We have 40 seconds left. Hope there will be no questions. So I'll go on to my next speaker. He is Dr. Arjun Tyagi. He is a clinical fellow in emergency medicine from the Lister Hospital, UK. He has published many papers as author and a co-author. His special interest is to develop educational programs in emergency medicine. Over to you, Mr. Arjun. Dr. Arjun, sorry.
Good afternoon, everyone. Can everyone hear me?
Yeah, we can hear you.
Okay, I'm just going to share my screen. First of all, thank you for this opportunity. Thank you, Chairperson, for introduction. So my topic is handling of polytrauma. So basically, we're going to go over the ATLS guidelines for how to deal with polytrauma and how to actually handle the patient in emergency and ICU. So first of all, let's just start with what is polytrauma. So polytrauma, so the perfect definition would be severely injured patients with associated injuries. But the more easier thing to remember is 2 or more severe injuries in at least 2 areas of the body. So that means if there's a fracture in the humerus and the humerus is broken in two places, that's not a polytrauma. That's just a comminuted fracture. However, there's a fracture in the humerus and a fracture in the femur, that counts as a polytrauma. For this to be polytrauma, these injuries as a total, or at least one of these injuries, should be life-threatening to the patient. So if there's 2 big bone fractures, then there will be enough blood loss from that can be a danger to the life. So we can call that polytrauma. So initial management of the polytrauma is vital because it is the one thing that is going to decrease the patient morbidity and mortality. For that, we follow the ATLS guidelines, which consist of rapid primary survey with simultaneous resuscitation of vital functions and a more detailed secondary survey, which happens after the primary survey. And then finally, initiation of the definitive care, which happens after the patient has stabilized and is moved to the ICU. So as we all know, primary survey, everyone learns this, ABCDs of trauma care. So A is airway, which with in ATLS, airway means airway maintenance with restriction of cervical spine motion. B, breathing and ventilation, circulation, hemorrhage control, disability, which basically means assessment of the neurological status, and exposure, which also means environmental control. So the airway maintenance with restriction of cervical spine motion is the first thing that we do. It's the most important thing we do because it is the most life-threatening scenario in which whatever we do, if we don't manage this, the patient's going to die. So the first, we assess the airway. What are we doing? Like, why are we doing this? Because we want to make sure the airway is patent. So for the patency, we need to do a rapid assessment for the signs of airway obstruction. They can be because of many reasons: foreign bodies, fractures, which can be either facial, mandibular, laryngeal, or any hematomas or accumulated blood. So for that, we start doing suction. So the first thing that we do is ask the patient, can you hear me? Call the patient's name if you know that. So if the patient is speaking, then we already know the patient's airway is patent. However, for this to be successful, we need to make sure we keep doing that, because sometimes airways close up after a while, because as you know, there might be some injury which can be accumulating the blood, or there might be a hematoma which might still be developing. On your first assessment, you might not find that the airway is blocked, but after a while, maybe even after 2 minutes, you realize the patient is not breathing anymore, the patient's airway is not patent anymore. So you have to keep doing this. So if in some case you see that the patient is not breathing, sometimes after mechanism or any kind of mechanism of injury, the patient might be closing his mouth too tightly, or might be there be some fracture or for some other reason. First thing we do is jaw thrust and chin lift maneuver. As you all know, it is the easiest way to open the airway. Even when we're trying to intubate a patient or put in a oropharyngeal airway, this is the first thing we do, jaw thrust and chin lift maneuver. Sometimes doing this only can help open the patient's airway and we don't need to do anything. On other times, we need to do this and then carry on with the definitive airway management. While doing all of this, we need to make sure the patient's spine, cervical spine, is not moving too much, because excessive mobility will either develop a neurological deficit or it will progress the neurological deficit. In most cases, cervical spine is protected with the cervical collar, and then and whenever the airway management is necessary, for example, if you want to do a tracheostomy, if the doctor wants to do a tracheostomy, he'll ask you to open the the collar, or there might be some collars which have some space in the middle. But even then, you still should use a two-piece collar which can be opened from the front. In that case, the tracheostomy can be done, and then the team member can again put it on and make sure the cervical spine is immobilized. So whenever you see a patient which does not have a cervical collar already on, the first thing that you do is use manual stabilization, which is shown in this picture. So basically, you try to hold the patient's trapezius muscles while using your forearms to hold the back of the head to make sure it doesn't move. The basic things to do is put the collar. So that's one way of immobilization. But the perfect way to immobilize the spine is to do a triple immobilization, which that means is, so first of all, you've put a collar on, then you put them on a trauma board, and then you put a tape around that with either cotton rolls on the side or foam rolls on the side. So that's triple immobilization, and that's been the research has suggested that it is the most effective way to immobilize the spine. These are the cervical collars that we were talking about. So the first one is a soft collar. So soft collar should never be used in a patient with trauma. So these are only used for patients with neck sprains or minor injuries. What we need to do is use hard collars, which are these: Miami J collar, Aspen collar, Philadelphia collar. So these can come under very different names. However, we just remember them as hard collars. They all can come in one piece or two piece. You might be able to only use what is available to you, but the best way to immobilize the spine is to use a two-piece collar. Two-piece collar means that there are two separate components which can be taped together on the side. So next thing is breathing and ventilation. To adequately assess jugular venous pressure and the position of trachea and chest wall exertion, you should be exposing the patient's neck and chest, performing auscultation, palpation to check for any other injuries in the chest. So basically, we're doing all of this because we want to rule out the most dangerous things. So the most dangerous things which can, hinder the ventilation is tension pneumothorax, massive hemothorax, open pneumothorax, and tracheal and bronchial injuries. So if a patient has any of these, then we need to start thinking about a definitive airway management and a definitive treatment. Every injured patient ideally should be receiving oxygen by a reservoir device. However, if the patient cannot handle, if the patient's airway is not patent or the patient's lung is not able to comply with the airway reservoir mask, then we use intubation. For that, we need to do again what we talked about: a jaw thrust, chin lift, and then the whole procedure will be done by the anesthetist or the consultant doctor. There are some other injuries as well which can compromise the breathing and ventilation: simple pneumothorax, hemothorax, fractured ribs, flail chest. However, they all come in secondary survey because they're not immediately threatening the life of the patient. The circulation with hemorrhage control is again, we need to make sure the patient is having enough cardiac output so that there is a cerebral perfusion, so the patient does not lose the level of consciousness or does not develop any neurological deficit. So first of all, circulation, we do level of consciousness. If the patient is already conscious, that's a good sign. Skin perfusion, see the patient not pale, pulse. Then figure out if the bleeding is happening externally or internally. If there's an external bleeding, then the best way to do it is not tourniquet, to provide put manual pressure directly on the bleeding. If that doesn't work, then you can try tourniquet, but do not use tourniquet as the first method. Other than that, there might be internal bleedings. However, you won't be able to find them until you do some imaging like chest X-rays, pelvic X-rays, and fast ultrasounds. Immediate management may include chest decompression and application of a pelvic binder and extremity splints. However, these are done after we have already figured out what the problem is and put the immediate hold to the bleeding. Definitive management may require surgical or interventional radiological treatment and bone stabilization. So the things that we need to think about is, does the patient have a good vascular access? Which means, does the patient have 2 large port IV cannulas so that we can administer fluids, bloods, and plasmas? Because on an average, you need to administer about 1.5 liters of fluids in every trauma patient. Blood samples then should be sent for all the hematological studies. And the important thing to remember is we also need to do blood gases, AVGs, and lactate levels as well, so that we can help the leading doctor make the diagnosis and then plan the definitive management. Also important test to remember is a pregnancy test for all females, because you don't want to send a patient for an X-ray or a CT scan when the patient is pregnant without discussing it further. Okay, so disability again is a neurological examination. The patient's level of consciousness should be examined, which is done by a GCS score. Then the patient's pupil size and reactions are seen, signs of lateralization, and see if you can determine the spinal cord injury level. So these might be done by the senior doctors. However, you need to still do the GCS. Even if the patient has moved to the ward or the patient has moved to the ICU, there will always be neuro observations in a patient with trauma. There might be other causes for altered consciousness, which might be hypoglycemia, alcohol, narcotics. However, until proven otherwise, always assume that the patient has central nervous injury. Prevention of secondary brain injury is very important. That's why we always maintain adequate oxygenation and perfusion. For that, we keep the oxygen saturation monitor attached, pulse oximetry, which we can monitor. That if it goes down, then we need to be worried about the patient's cerebral perfusion as well. Because of the evidence, brain injury can be absent or minimal at the time of initial examination. It is crucial to repeat the examination. So again, this will be done again and again. Lastly, there's exposure. So obviously, in order to see everything, you need to expose the whole body. You will be doing a log roll to check the spine as well. But don't forget to completely cover the patient after you've done all of those things, because there's always a chance the patient can develop hypothermia. So the things that we always forget, these are the things that nobody forgets. These are the ABCDs. We've been taught this a lot of times. Things that we forget are, we need to make sure the patient has correct chest leads for the ECG, pulse oximetry and carbon dioxide monitor. Once you attach the monitor, they will all be going on. Again, the ventilator rate should be done on the monitor, as well as every few minutes, a person, team member should be physically holding the patient's chest to see the ventilatory rate, an AVG measurement, urinary catheters and gastric catheters, which basically means you put a Ryle's tube in to decompress the distension if the patient's abdomen is distended. Other helpful tests are again blood lactate, X-rays, and fast ultrasounds, and then finally we start doing the secondary survey. Secondary survey does not begin until the primary survey is done. However, if your team is big enough, then you can start doing the secondary survey while maybe the first team is done with A, B, and they moved on to C, and the second team, the team can move to secondary survey as well. Secondary survey is basically a head-to-toe examination of the trauma patient and with a complete history and physical examination as well. So this is where you see all the other associated injuries, which might not be life-threatening, but they're still important to treat because they might not cause patient's death, but it can cause patient to lose some function in the limbs, maybe. Purpose is to make the secondary survey purpose is to make a definitive diagnosis and a management plan. So this is the spinal board that we always see. They come in various forms, but the main thing is that we have a spinal board always when patient is being transferred from a bed to bed, or when the patient is going for an X-ray or a CT scan or something, and the diagnosis is not made yet. You would not take the trauma board off until you have definitely cleared the spine is fine. As you all do this often in your jobs. So this is the best way to do a patient transfer from bed to bed. So firstly, you put a trauma board below the patient by log rolling the patient. Then once the patient is on the trauma board, then you put a cervical support. Then you put a transfer board, slide the patient across, and then log roll and take the trauma board off. However, I can see that you won't be doing this every time because there might be cases when the patient has been cleared of a neurological or a spinal injury. Then you can use a bed sheet to transfer from bed to bed. However, this is still the ideal way. In an ICU, there might be some things that you need to take extra care of because there may be a lot of chest bleeds and maybe a ventilator tube or something. There might be a lot of things that you need to take care of. So always make sure there's an anesthetist present in case the intubation tube or any consultant or any senior doctor is present, because sometimes while transferring the patient, there might be dislodging of the intubated tube, or there might be something which can be harmful for the patient. So it's not that you need to have them manually help or have them physically present there. You just make sure the doctor knows that you're going to do this so that they are aware that this is happening. And if need, they can come and manage the patient. Thank you. Please, if you have any questions.
Thank you, Dr. Arjun. It was very well explained about the polytrauma and ATLS guidelines, what we have to follow, what is ABCD means, how the airway management, how the breathing and ventilation, what about the circulation, and especially importance of the primary and secondary survey so that we should not miss anything when the patient is with the polytrauma. And the importance of spinal board, it was very briefly explained the importance of spinal board till we get the clearance about the neurological spinal involvement, then still we have to prevent the immobilization, like we have to immobilize the spine till we get the clearance that the spine is not having any trauma. So it was very informative session, Dr. Arjun. I'll just, delegates, if any questions, kindly post it in the chat box. So, Arjun, I just have one doubt.
Yeah.
So, log roll, as per picture, it showed like how many people requires to turn a patient when we require a log roll to be.
So the ideal thing to do is 3 on one side, 2 on one side. So the patient you're turning to the side, there should be 3 people there, and the back side should have 2 people. However, this might not always be the case, and you can still do it with 2 on one side and 1 on one side.
Yeah.
But the ideal scenario is 3 and 2.
Because it's actually, we feel no, for a log roll, we require manpower at that time to be there to turn the patient. So it's actually a difficult time at the hospital settings when we receive a case with the polytrauma or where the patient is having the spinal injury. So I just started out.
Yeah, that's why it's important to have ATLS certification so that anyone who is around the hospital, who is around in the ward, in the ICU, they can just come and help. It's just a log roll. It takes about 2 minutes maximum. Anyone can come and help.
Yeah.
Because it's important that all the patients' vital areas are covered when doing a log roll. Any other questions from anyone else?
I don't think so. You have any questions? So, thank you, Dr. Arjun, for your wonderful session about the polytrauma, how to handle. Thank you so much.
Thank you for the opportunity.
I would like to thank Melin ma'am for giving me this opportunity, and I would like to thank my speakers, Ms. Divya and Dr. Arjun, for their wonderful presentation during this session. Thank you so much. Over to you, Ms. Swapna.
Thank you, Ms. Divya, for the case presentation. Thank you, Dr. Arjun Tyagi, for an interesting session. And thank you, Ms. Bhagyalakshmi, for moderating the session. Wake up with determination. Go to bed with satisfaction. I think this quote glues here right. I hope that all these sessions have highlighted all the possible areas of curing and caring of neuro patients. I thank you all for making time in your busy schedule to join us here. I request participants to move to Hall A for the valedictory session. It's been a pleasure to host this event with a wonderful audience. Once again, I remind all the participants to fill the post-test. The certificates will be mailed to your email IDs, which is shared with us. Here, I acknowledge the contribution of organizing committee members, without whom the conference would not have been a great success. I extend my heartfelt gratitude to Captain Dr. Usha Banerjee, Group Director Nursing, Apollo Hospital Group, for her constant guidance and mentorship. A special note of thanks to Ms. D. Merlin Flincy, Principal, Apollo School of Nursing, Delhi, Ms. Rohini Sharma, Vice Principal, Apollo School of Delhi, Ms. Rachna, Charge Nurse, Apollo Hospital, Delhi, Mr. Ranin Chako, Charge Nurse, Apollo Hospital, Delhi, for their tireless efforts. I am thankful to Mr. Abhilash for his technical support. Last but not the least, I express my sincere gratitude to DNNA office barriers for their guidance and cooperation. We also thank DNA officials, especially Dr. Priyan Ranjan and Dr. Dinesh, for providing us this great platform of learning. We also extend our gratitude to the streaming partner, Omnicurious, for their support. Thank you, one and all. Please join Hall A for the valedictory session. Thank you, everyone.
Thank you, Sapna, for taking your time and moderating the entire event of this day. You did your job very well. Thank you so much. The speakers can close the link and join the link of Hall A for the valedictory session.
Virtual conference only. And for that, I appreciate the effort and cooperation of Dr. P. N. Ranjan. I would also like to congratulate the scientific committee for making a good scientific program and inviting good faculty. And I would like to thank all the faculty and members and speakers for sharing their knowledge and experience with us. And I'm sure we all are going home enriched with knowledge after attending this conference. So thank you, everyone. Over to Anshu.
Thank you, Dr. Satnam, for those kind words. And I think I can announce the winners for the various award papers. So I'll start with the award papers in neurology. And the first award paper, first winner is Dr. Avinash Goswami from Apollo Hospital, New Delhi. A round of applause, please. And the second winner in the same category is Dr. Neelam Sahu, again from Apollo Hospital, New Delhi. I think, and the third is again from Apollo, Miss Prerna Rana from Apollo Hospital. So I think Apollo has taken the bulk of the prizes from the award papers. Okay, so now coming to neurosurgery. In neurosurgery, the first paper went to Department of Neurosurgery, GP Pant Hospital, Dr. Chaineka Kutum. She has won the first paper. The second award goes to Dr. Sumit Bhandari, again from GP Pant Hospital. Then you have the third also going to GP Pant. So I think GP Pant has taken all the awards in neurosurgery, Dr. Prashant Lakhe. So a round of applause for Department of Neurosurgery, GP Pant Hospital. Yeah. All the awards in neurosurgery. The e-poster combined, the first prize goes to again Dr. Deepak Chaudhary from GP Pant Hospital. The second prize again goes to GP Pant to Dr. Binita Dholakia. And the third prize to Dr. Shishir Pandey from Apollo Hospital. So coming to the Neuro Nurses Award, the first prize goes to AIMS New Delhi to Vansing Prince C. The second to GP Pant Hospital, Dev Muni Verma. And third to Medanta Nilanjana. So I congratulate all the award winners, and they can contact Mr. Deepak Ojha for the awards after the conference gets over. So I think after the award winners, we can move on to the next thing. And I would now welcome our new president-elect, Dr. Sanjeev. Unfortunately is sitting with us, Dr. Dua.
Yeah, hi.
Please introduce yourself to the new president-elect.
Thank you, thanks a lot for your support. And it was a wonderful conference, Ranjan and Sudhir. Very well organized and really very well done.
Thank you so much, Sanjeev.
Okay, so we'll look forward to meeting you soon in the next EC meeting, Dr. Dua.
Absolutely, would look forward to that.
Okay, congratulations. So now we come to the last point of the second last point, and I would request Dr. Satnam Singh to hand over the charge to Dr. Vinit Suri, who is the incoming president of the DNA for the year 2022-2023. So Dr. Satnam, please do the honors.
Oh, welcome, Dr. Vinit Suri. I welcome you to be the next president of, take over the charge of president of Delhi Neurological Association. I wish you all the best. And we had a good time in executive committee meetings last year, though it was all virtual, and but still we had a great time. And I wish you all the best. I hope there's a lot of improvement in, especially the attendance is required in meetings and conferences. I think we have new ideas how to improve this, and I wish you all the best.
Satnam, and we are going to be in the EC to guide us, further, because we are here for one more year. And we have a very, very able EC with Dr. Anshu, Dr. Acharya, and the entire EC. And I would like to thank the members of the DNA for entrusting me with this responsibility. Very big shoes of Dr. Satnam to get into, but I will try my best, to do whatever best I can do for the organization. I've got some experience with Indian Stroke Association, so I think we'll use that
all that here and try to develop Delhi Neurological Association into, and take it to greater heights. And I think I'm ably supported by a very, very capable EC, and with Anshu there and with Dr. Satnam also there to guide us, because he's going to be with us for one more year. And now Dr. Sanjeev Dua also joining. I think we'll try to, make some changes in the coming year. Hopefully, because the last 2 years were unfortunately marred by COVID and none of the meetings were physical. But I think if this year allows, then we'll have more physical meetings. And I think we have had in the EC some ideas which we have discussed. And I think we are going to try to implement those ideas. And so I thank all the members for entrusting this responsibility. And I accept it with a lot of humility. And thank you, Dr. Satnam, for handing over. But you are going to be there with us for the next year.
I will also like to thank all my colleagues in EC for their support and guidance in last 1 year. Thank you so much.
So before I finally end, I would just announce the resident quiz winner, which was just completed a few minutes ago. So now I have the list with me. And the winners for the resident quiz is number 1 comes Teams Max, Dr. Raghav, Dr. Nilesh, and Dr. Priya. And congratulations to all 3 of them. The second team was Team Apollo, Dr. Swapnil, Dr. Shishir, and Dr. Avinash. Congratulations to Apollo and all the residents. And the third came Team AIMS, Dr. Fatima, Dr. Vinay, and Dr. Deva. Congratulations to all the residents from AIMS. So with that, I would now come to the final point on the agenda.
Anshu, can I make a point, please?
Yeah, sure, sir, please.
On behalf of myself and my colleague, friend, Dr. Tyagi, I must really be grateful to Satnam and Anshu, because, 4 months have been hectic. We've been calling each other. We've been calling on telephone at all hours, what is to be done, till the time we decided that we have a virtual meeting. I'm extremely grateful to them for all the cooperation in every form. Satnam and Anshu cooperated with me to make this a grand success, which has been. Of course, I'll be failing in my duty if I don't thank my entire department of neurology and neurosurgery, which functioned as one. And all my boys, my postgraduates have been there with us for these 2 days. Last but not the least, Deepak. Deepak is always great. Our DNA advisor, I would say. For every small thing, we would call up Deepak, take his advice, or Deepak would take up Anshul and take his advice, so that we did everything the right way. Thank you very much. God bless. And I hope that DNA continues to flourish and we continue to have good academic programs in the years to come. Thank you very much, everybody. And thank you very much, Executive DNA.
Thank you, Dr. Ranjan and Dr. Tyagi.
Yeah, thank
a
you.
word from Dr. Tyagi also.
Yeah, thanks from my side, core of my heart. You all supported us so much. We could organize it along with Dr. Ranjan, and he's definitely a very kind of spearheaded person who can head any kind of meeting. And he guided us, and we supported him, and we could make it. Thank you very much for supporting us. Thanks.
Thank you. Thank you. Any word, Dr. Suri? Any final word?
No, I think I wish everybody lots of good luck for the coming year. And let's hope that DNA flourishes further. And, we have a lot of responsibility to take DNA into greater heights.
Maybe very soon we have
lots of good health and prosperity to everybody.
We are looking forward to a physical meeting.
Yes.
Yeah, definitely. Yeah. That will be better. That will be better.
I think Dr. Vinesh is going to the president now.
We'll go to president's house now. President has got a new house.
That is long awaited.
That is long awaited. We wanted to go to his house, but we can't go.
No, we will have the next EC meeting in my house. I'll arrange.
Okay.
My only EC meeting, yeah. We also want to come.
Okay. Okay. Thank you, everybody. Thank you. Okay. Dr. Satnam, can I close the meeting now?
Yeah, yes, please. I think let's close the meeting. Thank you so much.
Thank you. Bye-bye, everybody.
Thank you. Bye-bye.
Well done.
Thank you.
Thank you. of the exam. Okay. Its availability.
So wait.
For the